Good morning, everyone. Hope you all had a great dinner and great day one yesterday and last evening. Thank you for all your support and active participation. This will start the day two, focused on advanced spine endoscopy techniques and technology. So I request all the delegates outside the hall, please be seated. So without further waiting, we will start our day two with Dr. Ankit's foraminoplasty techniques.
So good morning, everyone. Today the session will be showing three cases, two endofusions, different techniques of endofusion. So we'll discuss more about endoscopic assisted fusions today. So how does that help, and what are the various techniques, and what is that evolution, how it has evolved. So the speakers will be talking more about fusion today. So we'll be showing two cases. One, the posterior approach, where we can do in various ways, either do a partial facetectomy or a complete facetectomy and use that as a graft and insert the cage. Then how to remove that bone in an easy way. So we have developed a technique called A-surf technique, which is called endoscopic resection of en-bloc resection of facet. So we call it as A-surf technique, which we have with the simple tools. We have just described the technique. So how to remove the facet easily without much bleeding and safely. Then use that as an autograft and pack the space. Then the next is the transcambian fusion, which was conceptualized and started by Dr. Saeed Usman, and later so many people are doing it. So how to go through the safe triangle of cambian and inside the cage. So two cases will be showing, one by me and one by Mahesha. Then the third case is the thoracic stenosis. So thoracic stenosis, it's a D9, D10 stenosis with ossification of yellow ligament, where now you can easily do endoscopy, stenosis decompression, going over the top bilateral easily. So we'll be showing these three cases and discussing around these three topics more. Yesterday we left one topic, Dr. Ankit didn't get the time to complete the talk. So his talk is on foraminoplasty. So because you saw the yesterday's upper lumbar, but there are occasions, as Dr. Koichi Sairo emphasized, so there are occasions where you need a aggressive foraminoplasty. So foraminoplasty. So Ankit is a seasoned endoscopic surgeon from Indore. So he will be showing techniques like whether to go land in the foramen, go into the disc, come out, that's inside out, or land in the foramen, stay outside and do foraminoplasty. There are again two terminologies he will be describing in detail about foraminotomy and foraminoplasty. What do you mean by that? I think he will describe in detail. Over to you, Ankit.
So, good morning all. First of all, I would like to congratulate Dr. Sukumar, Mr. Naresh and all his team for wonderful third consecutive Spinoscope and providing me the opportunity for presentation in this video session. So I will be just giving you a brief about the foraminoplasty, how to plan and what are the techniques available. But I will be showing the outside in, landing from outside the foramina and then doing the foraminoplasty and doing our work. So traditionally we have been using the transforaminal route trajectory, but with the development of floating sheet technique, now we can work in the foramen from upside down or downside up. So that has made foraminal work tremendously easy for us. So these two terms have been used synonymously, foraminoplasty and foraminotomy. So foraminoplasty is basically, it is the decompression of foramen for foraminopathology to treat the foraminal stenosis. And foraminotomy is dilatation of the foramen or widening of the foramen to get entry into the epidural space. So most often we need both the things simultaneously in a single patient. So as we all know, the foraminal boundaries, the upper pedicle with adjacent posterior vertebral body, the disc, and the superior articular process, lower pedicle, and the disc. And these all structures can be responsible for the throttling of the root. And before planning the surgery, we have to see from where the compression is coming up. So our landing is slightly different as the traditional or conventional transforaminal technique because it is foraminal technique, not transforaminal. You have to land before the foramen and then enter into the foramen. So these are the available methods in the literature. The pioneer Martin Knight, which we used the laser, side firing laser. Then Hoagland and Schober used the trephines and reamers. So these are all available techniques in the literature, but I will be showing the drill. So I use drill and start from the outside the foramen and then enter into the epidural space. So these are the indication. The small foramen or with the foraminal stenosis, highly migrated fragments up or down, the collapsed disc space when you cannot enter into the disc space on first go, and then short pedicles, large facets or osteophytes, lateral canal stenosis, or chronic disc herniation, which is not reachable by the common trajectory. So these has to be seen before surgery, planning the surgery into the MRI or CT scan. So this is my case for today's video presentation. It is a 52-year-old male with severe right leg pain for 1 month. He had a failed conservative trial. And he was referred to us with a severe pain down to the shin and some paresthesias in the foot. So you can see here the tight foramen, there is a lateral canal stenosis with a fragment here lying just below the pars, and at the tip of SAP there is small fragment which has gone downwards. So these things has to be seen before you plan. And if you see in the axial, that is the fragment here, and the extension of the fragment. But thing to note is the right side facet. See, there is significant loss of facetal, the fat intensity in this image on right side because of the facetal hypertrophy or arthropathy, you can say. And you can't see the exiting root here. So this makes this patient a very good indication for outside in foraminoplasty, because you have to start from outside and see all the structures before you go inside. This is the X-ray. There is no significant instability. See, I do CT scan in all the patients who are planned for foraminoplasty. As you can see here, there is significant grade 3 facetal arthropathy, distortion of the facet, and the direction of the facet is sagittal, which favors our foraminoplasty technique. And there is spicule from the SAP and osteophyte from the upper vertebral lower end plate. You can see in 3D also. So this is the superior articular process, and this is a overgrowth of IAP. So this thing is, and you can see the distorted facet. There is significant overgrowth from both the IAP and SAP. So this you have to know before, because when you land, sometimes you are confused which is SAP, which is the overgrowth. So these are the steps of the foraminoplasty, a typical posterior lateral entry, but according to the patient profile and the target points, you have to decide from where you have to start. So we land outside, then drill foramen, then get entry to our targets, and that completes the procedure. So this is the video. So this is the entry in the AP view. We are outside the foramen, and note down a spicule here. This one is the spicule, and in lateral view, our entry is the lower 1/3, ventral 1/3 of the superior articular process here, and after this we insert the scope, and my right side is cranial and left side is caudal. So that is the superior articular process, this one, and this is hypertrophy. That's why it seems quite big here, and then we move to down and to see the junction of the pedicle and superior articular process from where the drilling is started. So gradual drilling is done from from caudal to cranial side, and that makes the foramen little wider to put your sheath further, and that makes the sheath mobile. So as you can see that first I am widening the foramen lower down because I don't know where is the exiting route. So this, I'm using the 3.7 transforaminal scope here, and I am quite comfortable because the sheath is smaller as compared to the 4.1 or 2, but because it is a mobile thing. So this is the superior articular process. You can see here. So we just prepare it, keep on preparing with the RF, and then we drill more superior articular process. We keep on drilling till we see either the epidural fat or ligamentum flavum, according to your target. What is your target, what you are targeting? So as you can see here, that I can see the glimpse of the epidural fat. So some more drilling is required. So this is the continuation of the drilling, and that is the overgrowth which I was mentioning in my CT scan. So that's why I was saying sometimes we are confused that this is the tip of SAP. So it also needs drilling because the fragment which I was mentioning, it just below it. So you drill it. My sheath is completely floating. It's like interlaminar. I am moving here and there. That's why you see every time my drill slips down. So I have to adjust it again and then drill it again. Many times when it is little difficult or more mobile, so I use the chisel also. I'll be showing here in this video too. So this spicule can be removed with chisel like this. Still now I haven't seen the exiting route. I'm still working outside. So just removing this, and that exposes your foraminal ligaments. So now you see the foraminal ligaments which I'll be cutting, and note down my direction of the annulus cutter, which will be horizontal and downwards because superiorly there is an exiting route. So that exposes the exiting route here. You can see on my right side. So some more work is required because there was a disc herniation along with the osteophyte. So first we decompress the root from ventral aspect and then from dorsal aspect. So there was a lot of adhesions or amalgamation of tissue, maybe because of the facial arthropathy is the secondary reaction, or maybe due to the inflammation due to second disc herniation. I don't know, patient didn't give me the history of any injection. So that's how we decompress the ventral part of the exiting root, and then come to the dorsal. This is the dorsal aspect. So we remove, see how much adhesion there with the flavum and root. This is not actually flavum, this is a part of capsule which is hypertrophied and inflamed. So we remove it with kerrison and annulus cutter. This makes your root mobile because I want to retract it slightly to get into the fragment. So this is now retracted, root is retracted. Now I am trying to remove the fragment which is lying in the axilla, you can see in the middle. This was the fragment which I have shown you in the this MRI. So now this is pulled out, and this decompresses my exiting root completely. You can see here now the epidural space I can see. Now you can turn your sheet down to work into the foramen. So to decompress the traversing root. So that completes my surgery. This is slightly different from para-PSLD, which has been shown yesterday by Dr. Mahesha. So that finishes the surgery. So to conclude, it is better to enter to the cave with a light rather than going blindly. And foraminoplasty with drill from outside is safer and effective because you see the exiting root first, and it avoids the complication of blind procedures. Thank you.
Excellent, Ankit. So, any doubts? Yeah.
No, it is slightly. See, it depends on target. If you are only planning for foraminoplasty, like Dr. Mahesha showed you yesterday in that the para-PSLD, which is 5 centimeter from the midline, and so because this patient has a fragment also which was going down, so I took about 9 to 10 centimeter entry. So for foraminal work only, but if you are planning like there is some central fragment also or downward fragment, then you may be taking a entry from your usual distance like 12 centimeter or 30 centimeter, depending on the patient profile also. Many times what has happened, the patient has chronic foraminoplasty, so I need to do the foraminoplasty as well as going into the disc and to remove the central disc. So sometimes I have taken 2 entries, one for the foraminoplasty, then it is dilated, then I take another entry to get into the disc space to remove the fragment or the central decompression.
But even for transforaminal discectomy, our needle first hits the superior articular process. So
no, for transforaminal you don't need to dock on the superior articular process. I mean, you are saying the tip of the superior articular process.
And then we
you walk down the superior articular process and that enter into the foramen, and then you see in AP and lateral view where I am. But in this, I just dock on the superior articular. I'm not going inside the disc. I haven't gone inside the disc.
So why not with that thing you actually do the same things in?
You mean inside out?
No, with the transforaminal discectomy approach, is that foraminoplasty cannot be done? I mean, because
see, these 2 techniques are different: the inside out and outside in a way from where you are starting. So inside out, traditionally we first go into the disc, do our disc work, and then come out and then do foraminoplasty. That is also good. But when such a case where we don't know, the facet is large, you can't see exiting root. If you go blindly, ream something, then you may injure the exiting root. There is no space, and you have seen in this video there is a lot of amalgamation of tissue because of secondary inflammation, and it has been seen in many. Even in yesterday's case, there was a lot of inflammation. So what you see, if you do it blindly with the reamer or the trephine, then you may bleed. You may bleed also, and you may injure your exiting root. And so if you start from the outside, like I landed in the lower part of the foramina, starting my drilling up, so I know where I am.
No, to answer your question, it is possible with a normal transforaminal approach like 12-14 centimeter. It is possible, but the key is you should not enter the disc, because once you enter the disc with the dilator and cannula, you don't get the leverage to work on the facet. What he has done is he has kept all outside and he has done the reaming. So even with the transforaminal approach, we don't enter the disc if you are planning facet work, because once you enter because the key is to rest the cannula on the disc, and it becomes very easy to work on the facet.
So I'll extend this one. See, I will clear your doubt. I know what you want. See, there are 3 situations here. Yeah, so that's why I want to make your things clear. See, there are three situations here. You want to do discectomy along with foraminoplasty, you want to do only foraminoplasty, or you want to address foramen first and then enter the disc. Okay, so these are the three scenarios. What Ankit showed was only foraminoplasty. He didn't want to do any disc work here. It's just a foraminoplasty. For foraminoplasty, ideally the entry should be medial, because you just land on the facet and your drilling is oblique, and your exiting route addressal will be better if you are more medial. Like say, as Mahesha showed yesterday, 5 to 6 centimeter or 8 to 9 centimeter. So this will give you the landing on the facet, and you get a good facet purchase, and you can drill the facet better. Pedicle to facet drilling and exiting route, entire exiting route decompression is better when you land medially. If you want to discectomy also, most of the time it is medial to the foramen, then what if that entry might become difficult? So for that, as Mahesha said, normal entry 10 to 12, you can go and do a discectomy and do foraminoplasty. But sometimes what happens, if facet is very, foramen is a little bit bigger, or facet lie is not oblique. So that's what, when time permits, I'll show you. If the facet is very slopy, then what happens is you keep on drilling the superior facet, and you will never reach the ligament. You think, I've drilled so much of facet, still you are not reaching medial part of the ligament. When you are more horizontal, that's 12 to 14 centimeter. Or sometimes it find difficult to find a facet margin. You see only soft tissue there. You don't see a facet. When you are coming out, you don't touch a facet. Normally when you are coming out, you touch a facet somewhere, right? When you are too horizontal, you might never touch a facet. It's only muscle. Suddenly you are already out, but you don't touch a facet. So when you are really contemplating for a foraminoplasty, so better is you try to go oblique and try to take a more medial entry where you can do very good foraminoplasty. But you want to do a foraminotomy, just you want to create the space, and you want to do discectomy where you do in outside in approach, then it is up to you which way you want to do it. But when you are planning to drill a facet, oblique entry, that is medial entry, will help you more technically.
Ankit, very well demonstrated. I just have one question. There were end plate osteophytes from L5.
Yeah.
Did you remove it, or
Yes.
did you not remove it?
It was removed. It
Okay.
was first removed, as
Because
I mentioned.
when we talk about foraminoplasty, we need to clear the axilla. This is very important.
The osteophyte was slightly lateral. I mean, it was the age of when the sloping of vertebral body. So there was a lot of tough tissue rather than having. So I removed it before freeing the exiting route, because first I go ventral, remove it, and then go dorsal, so to make it mobile. So then that's why I can retract the route to work into the axilla, or when I want to go into the epidural space.
And also I think because you have taken a medial entry point, you could go above the root. If you take with a normal lateral entry, it is difficult to go above the root.
Very difficult.
Yes.
You can't go cranial to the root. And the drilling of this shoulder osteophyte, the osteophyte between the traversing and exiting root, what there was there, that body you can drill better when you are more medial, because it's like working interlaminar, where you can drill better. You can use a handheld
Sometime when there is
mill
a diffuse bulge up to the extra foraminal bulge, then also you can turn your sheath and then drill the osteophyte from the
So it's like a working interlaminar with some obliquity. So medial entry is always better if you want to do foramen work. So somewhere between 6 to 8 centimeter, whichever way you want to work.
Things go that side and come back.
Yeah. Thank you, Ankit.
Thank you.
You can go in between. So see, 9-10 centimeter also you can do very good discectomy, because the moment you do foraminoplasty, You can just depress the scope and go medial to the root and remove the. So Anthony Young, I have seen his entry point is 7.5 to 8 for all the discs, and he does excellent work with foraminoplasty. So he's a master. I've been there with him for a week. He showed 3-4 cases how to do a foraminoplasty and remove the disc. His entry is only 7.5, and even he doesn't measure it. He's just there. He just hardly uses his C-arm. So you can do very well. The moment you do open up the foramen, you have a lot of space there. So you can tilt the scope and you can go in immediately.
Next talk.
Yeah.
If you talk about learning curve, maybe if you are experienced with interlaminar approach, para-PSLD will not have the learning curve of transforaminal approach. You mean
Para-PSLD.
Para-PSLD? Yeah, which approach? No, if you are experienced with transforaminal approach, that is easy for you. But otherwise...
So for a beginner, if you ask, because he is a master, the bleeding is very less in what Ankit showed, because you are directly going there and facet volume you are landing. So there is no bleeding there. But here we are dealing with the vessels which are along the root. So that space where the tip of SAP and the transverse process, lot of vessels are there which carry along, which go along with the root. So if you can master that, I will say para-PSLD is very good for foraminoplasty. Yeah.
Because bone resection is easy with the
So our idea for foraminoplasty is to decompress the exiting root. How best you can decompress the exiting root is with para-PSLD. But it's a beginner's perspective. I would suggest learn foraminoplasty transforaminal approach. Then you can just take a medial entry and go cranially and start doing the same work. Yes. Yes, you can do that. Yes, yes.
But it will take longer time.
The
same question somebody had asked, Varun had asked yesterday. But that will take more time.
No, sir. What your argument when you are doing a foraminoplasty means the foramen is too crowded. Okay. Yeah, definitely. Yes. Yeah. Yes. You can. You are not confident. You can just peep into the disc. But sometimes you don't know when the exiting root. Yesterday, Dr. Prasad was asking. Exiting root most of the time is pushed more posteriorly and cranially. It increases your Cambrian's triangle volume in extraforaminal disc most of the time. Sometimes there is a possibility that it might be pushed more inferiorly. Then your volume becomes less and you might have a danger of entering the root there. So better is you float in the foramen, try to identify the bone or landmarks, then slowly remove the soft tissue, you are there. So
But it's not difficult. We removed that all annular hump we removed yesterday. Yeah. We have to learn how to work under the root. Either you can retract the root or use a small...
the moment you are doing para-PSLD or interlaminar approach, we need to see the corridor. So what might extra bone might come in our way. So this understanding is there, then it is very easy. Thank you. So I welcome our brother Suresh. So he is an accomplished surgeon. Yesterday he gave a lecture. So he started his journey in 2019. So now he is one of the senior faculty KOL for multiple international companies. He grows across the world now. So he practices in Malaysia, North Malaysia. So he does almost everything now in endoscopy. So we are very happy to see you, Suresh. So over to Suresh.
Good morning, everyone, and thank you, Dr. Sukumar. I started my endoscopic journey in 2019 with Dr. Sukumar, and today I'm very happy to be here to share my experience on this topic, lumbar interbody fusion, transcambien approach. How do I do it? All right, as introduction, we know there's numerous spinal fusion techniques available for lumbar interbody fusion like A-leaf, P-leaf, D-leaf, O-leaf, and X-leaf. With the advancement of endoscopic surgeries, there are several percutaneous fusion techniques have been reported. But however, these techniques have their limitations as well in the terms of cages, which are too rigid and large, which is difficult to pass through the working channel. As advancement in the endoscopy, now with the endoscopy we can do interlaminar endofusion, transforaminal endofusion, transcambien endofusion, and also transfacetal endofusion. And with the modification and availability of expandable cages makes this procedure easier. And not all of us are luxurious enough to have these expandable cages in our place, and even if it's available, it's too expensive. So today I show you all how I do in my way. I use the normal MIS T-leaf cages to do this procedure. All right, the advantage of doing endoscopy is all the work can be clearly visualized with a direct endoscopic view. The indications are lumbar foraminal, lateral recess, central canal stenosis with segmental instability, lumbar disc herniation with segmental instability, grade 1 and grade 2 spondylolisthesis. The contraindications, severe disc space narrowing due to limitations of the endoscopic procedure itself, severe spondylolisthesis more than grade 3, due to the limitations of reduction, and any disease that could affect the bone quality. So these are basically the instruments that I use for this transcambien fusion. All right, preparation and surgical steps. First is positioning, target point of initial needling and skin marking. Then end plate preparation, bone grafting, cage insertion, and screw fixation. Positioning and target point of initial needling and skin marking. Generally, I do it under general anesthesia and sometimes also under epidural anesthesia, but endo T-leaf can also be performed under LA and monitored conscious sedation. This reduces the risk related to GA and also gives us a check real-time feedback from the patient. So it's very useful for elderly and medically compromised patients. So this is how I position my patient. I usually use 2 pillows, make sure the abdomen is free, under a radiolucent table. So I get the skin markings, midline, and also the disc line, these 2 lines, followed by the other lines which is superiorly on the superior pedicular line, inferiorly the inferior pedicular line, and on the right side, right lateral pedicular line, and also on the left side, left lateral pedicular line. So I normally put in the screws percutaneously first. If there's one level, I put in all 4 screws. And if there is some amount of listhesis, I normally try to reduce it by placing the rod on the opposite side. And also it gives me an opportunity to distract the disc space as well. Discectomy and interspace prep. So for my entry point normally for the lumbar region is about 8 to 10. And I try to target the tip of my needle into the midpoint of the disc space, both in AP and lateral view. So this, at this point, this gives me a good to prepare the disc space. So once the needle is in, I change to trocar and the cannula. So I do the the disc space preparation by using rongers to clean all the soft disc material. And also use the curettes to prepare the end plate and remove the cartilaginous part of the end plate. So usually I try to get a good decompression until I see the ventral part of the annulus. And for a good end plate prep, you must be able to see nice petechial bleeding on both inferior and superior end plate. This ensures for good fusion later. So this all looks well prepared disc space. So the next one is cage trial and bone grafting. So usually I use allograft, which is chronos around 10 cc, mixed with bone marrow. So the bone grafting done through the funnel. So after the bone grafting is insertion of the cage. So at this point I change the sleeve to the larger sleeve, which is, you can see this x-ray here. This sleeve has got a long tongue. So here we need to place the sleeve in such a way that when you look in the lateral view, it's half in, half out in the disc. And you turn it to protect the exiting root. So by this way, the exiting root, it is safe. So changing the sleeve. And this is the insertion of the cage under II guidance. So I try to get the disc as ventral as possible and also on the AP view crossing the midline. So this shows after a well-placed cage. And lastly is the rod insertion and final tightening. So this is the skin incision. Okay, now let me show you all a few cases. I've been doing this transcambium endofusion for the past 2 years, and up to date I have done about 30 cases. So this is my first transcambium endofusion. This is a 58-year-old male presented with lower back pain with right leg radicular pain. So did L4-5 endo transcambium fusion. This is a 60-year-old female, severe lower back pain with left leg radiculopathy problem. She had was L3, 4 and grade 2 spondylolisthesis L4-5. So she had 2-level endofusion done, and with a single portal of entry for the both disc level. This is another case, 54-year-old male, had L4-5 discectomy done 10 years ago, now presented with severe lower back pain. So she had a grade 1 spondylolisthesis L5-S1. This is a 65-year-old female presented with bilateral lower limb radicular pain, left more than right. So she had a spondylolisthesis L5-S1 with spinal stenosis. For this patient, I did posterior stenosis decompression first, followed by the transcambium endofusion. This is a 55-year-old female, lower back pain, bilateral lower limb claudication. Did L4-5, posterior stenosis decompression, followed by fusion. This is a 58-year-old male, lower back pain, right lower limb radicular pain. So same. So here he had grade 2 spondylolisthesis. She still managed to do it under transcambient fusion. And this is a 47-year-old female. So she had some form of intradiscal procedures done twice by a pain specialist for lower back pain. But there was no improvement. 2 months later, pain worsened. She was unable to stand, sit, or walk. Repeated MRI showed an unstable segment at L2-3 and discitis at L4-5. So I think to look back, back pain most likely was due to the unstable segment at L2-3 and nothing to do with L4-5. But unfortunately, this is what happened after the intradiscal procedure. So for her, I did L4-5, transforaminal decompression with percutaneous screw fixation, followed by L2-3 endofusion. This was done about 1.5 years ago, and she's doing well. And last 3 months ago, I just removed the lower pedicular screws. This case done last week. It's a 48-year-old male, lower back pain with left leg radicular pain. It's a well-prepared intradiscal space with after insertion of the cage. And there you can see the exiting route. Sorry. Okay, this is the post-op X-ray. So with that, I conclude my talk, and thank you so much.
Very good presentation. What is the percentage of post-operative dysesthesia in your cases, infusions?
The last 30 cases, maybe about 3 patients.
Is it related to the size of your cage or?
I think the size of the cage.
Okay. Till which size you put? Maximum size?
With this technique, I can only get in the largest diameter is 11.
Okay.
11.
Okay. One more question. You showed a case where there was discitis, but you did surgery for upper level in the same time?
Because he was in so much pain, and for me, I thought that pain was initially was at L2-3, the instability. But I took a chance, but I did the blood investigation showed ESR and CRP was like borderline.
Okay.
So I proceeded with debrided the.
Okay.
But she did well.
It is a bit risky because unless it is an emergency, you are not supposed to do a major fusion when there is an active infection. Okay. Any questions? No, you can treat the existing infection with implant, that's okay. But you are not supposed to do a new fusion when there is an active infection elsewhere, because active infection is a contraindication for elective spine surgery. This is my point. Yes, if you are treating it, yes, it can be done. That's, I am not against that. Yeah, any other question?
How did you remove the implant when it was
Which one? The pedicle screws? Same, to the same incision, but you have to open a bit bigger. Yeah.
You just require little longer Langenbacks. The narrow Langenback you may not have readily available, but I have custom made Langenback retractor which are deep. Yeah. So it is possible to remove them. It is not difficult, because when we do percutaneous fixation for fractures, when they come back for implant removal at 1 year, there are no fins to identify. You have to go deep and take it out. Yeah. So if there are no more questions, I call upon.
The sheath only takes in 11 millimeter cage.
No, but if you see Jayon, they have a sheath which will take, I think, up to 14. They have made a big sheath. So thank you, Dr. Ramaswamy. I call Dr. Varun to give his talk on oblique lateral lumbar interbody fusion under local anesthesia.
So very good morning to all, and thank you, Dr. Mahesha, for inviting me on the stage, and Dr. Sukumar for giving me this opportunity to discuss the way I do the transcambien fusion. I mostly do it under local anesthesia, sometimes with an epidural sensory block, and I'll be sharing some tips and tricks for that. So I'll be talking on transcambien fusion. So these are the regular cases which we keep seeing in our OPD. So you can see the listhesis, the instability there, and this is what, makes us bring out our scalpels and decide for going for a fusion. Most of these patients in these subsets have some medical comorbidities, especially the elderly, and we sometimes have to, they are not getting the anesthesia fitness, and we are supposed to, we are forced to treat them conservatively. Surgery is the ideal choice, but what about those patients who are not surgically fit and not responding to conservative? So do they not have any hope? So my preparation for these patients starts in the pre-operative room itself. So pre-operative medications 5 to 10 minutes before shifting the patient, because I'm doing these cases under local anesthesia. So give them an analgesic, pantoprazole, tramadol, ondansetron, etc. We just give them 5-10 minutes before. So by the time the patient is taken into the OR and made prone, all these drugs have now started taking their effect. Foley's catheterization, ECG stickers, cautery pad, wide bore cannula in the arm, all this is done inside the pre-operative room. And if I'm using a epidural tube, that epidural line is inserted sometimes 1 day prior. So there is no OT wastage. Time in the OT is not wasted at all. So this is how we do that. Then positioning, the patient again is made prone, head over the ring, and check any compression is there over the eyes. The neck position is checked. The patient is repeatedly asked whether he is comfortable, because during the surgery we don't want the patient to fidget just because he is uncomfortable. The surgery is not very painful, but sometimes the elbow pad is impinging or some chest pad is impinging, all that. So this is how we do it. So patient warming blanket. So anything which can make the patient uncomfortable during the surgery, we tend to take care of that, so that part they don't fidget. It is rarely the surgery which is making them move and fidget, but the uncomfortable positioning. So this is, I use a different color drape so that if they get exposed, I know that the unsterile part is there. And I put a tegaderm and over the epidural line so that I can paint and drape over that. We can apply betadine during painting. Even these hands and arms are also secured, not very tight. The Mayo stand is placed over the leg so that the patient cannot kick and make things unsterile. So this is just lightly tied so that they have a very small zone of movement. So the abdomen is completely free here. I'm using a Jackson table, but you can use the bolsters as well. But you can see because of the obesity, the X-ray is a little of poor quality. So how do we proceed in these cases? So this is a small tip. I just, use this leucoplast or the cloth tape and just tie it and push the abdomen away from the surgical site. So try to drag it cranially or caudally, depending upon where your surgical site is, like this from both the sides. And this, just takes out the fatty segment away from the surgical area, and this is tied like this, and you can see the X-ray has remarkably improved. So this is a small tip. The foot of the patient is exposed so that we can ask them to move the feet during the surgery and see. Again, if in a single C-arm setup, I take the pre-operative images of the level taken and the vertebral level is squared, and then we place the notes over the C-arm that in the AP this is the value, in the lateral this is the value, mark the angulation so that every time in back and forth the X-ray technician doesn't get confused and not much time is wasted and there is no guesswork, and this also reduces the radiation as well. Then marking of the C-arm on the floor so that at least 90% of the time he is back in the same position. So now I'm using the dual C-arm. We can place these in the AP and lateral position so that back and forth between the AP and the lateral goes away. So you can see this is how, and this is the working corridor from where the surgeon stands, and this is my anesthesia protocol. For the transcambin area, we use a local infiltration of 5 ml lignocaine with adrenaline, 10 ml sensoricane and 0.5% and 5 ml of NS. So this is just a sensory dose and doesn't cause any motor blockade. Then I'm using dexmedetomidine IV infusion for sedation, 1 microgram per kg for 15 minutes loading, followed by 0.2 to 0.7 per kg per hour as maintenance. So this decreases the blood pressure as well and causes some sedation. Then 50 mics of fentanyl at the really painful procedure times, and then a small anxiolytic dose of midazolam. If the patient is hypertensive, we can use an NDG infusion. And this is the epidural, sensory epidural, which we can also use. Especially, I used to use it in the beginning of my learning curve. And this is just a small instrumentation set that we are using. So this is how we target, mark the AP line and the disc line, and then the oblique line is marked, which is the disc inclination line. The distance from the midpoint to the back is then translated to the disc inclination line, which gives us our entry point. So we need to remember that in case of a fusion, we intend to land in the anterior 1/3 or middle 1/3 for the cage placement, as opposed to in the posterior part of the disc for the discectomy. So this is why this trajectory, which is a little more medial than the usual trajectory, helps. So this is a case, 40-year-old female with pain in the back, which was radiating to both the lower limbs, and SLR on the right was 20 degrees, and claudication was there, and you can see the listhesis, and you can see the stenosis as well on the MRI. So this is how we place the patient under dual C-arm, and this is the technique. So regular transcambin entry, the guide wire, then the dilator goes over the guide wire, the working channel, then a big drill is put to, this quickly takes out a big chunk of the disc, and then big discectomy and shavers are used. So quickly shave off the disc sizer to size the disc, and then the cage is placed over a guide wire. And then again local is given, and this power trephine I use to take out the iliac crest graft. So this is all under local, and then it is mixed with the graft expander and put through the cage, and then you can see the cage goes over the guide wire. And then local anesthesia again for the screw placement, and you can see that the patient is well awake and aware, and she is quite comfortable as well. So this is the regular technique of placing the pedicle screws. In the interest of time, I'll just skip this part of the video. And this is the final construct in the lateral view. This is the AP view, you can see, well reduced and well placed cage. And these are the transverse screw incisions, because they are more cosmetic, the rod incision, the cage and the bone graft incision. And this is the immediate post-op. And by evening, we just mobilize the patient, because all this is done under local anesthesia. So this is the questions we generally face. Can we do adequate disc preparation by this route? So this is the amount of disc which was removed. So you can see adequate disc preparation is being done. And again, you will crush the exiting route as you pass the cage over the guide wire. So you can see the design of the cage is different, and it is quite bullet nose and tapered in the front, and as it goes in, it just distracts the disc space. So this is the key. We are not using the regular T-lift cages, and as it goes inside the transcambin, it just glides underneath the exiting nerve root and just pushes it away. So something like this phenomena, and the key is just to spend as little time in the transcambin, in the cambin triangle as possible once the broad part of the cage is being passed. So this is will it fuse? 55-year-old male, again pain in the back, L5S1, again did with this technique, and this is 1 year follow-up, and on 2 year you can see the solid fusion there, through the cage, outside the cage as well. So most of the graft is placed outside the cage. So is it just good enough for one level? So this is a case of 48-year-old female, again listed as L3-4-4-5, so fused with the transcambin approach. Another case, 45-year-old male, back pain, bilateral radiculopathy, and intact neurology, listhesis L3-4, and reduced disc height at 4-5-5S1. You can see here, this is the flexion extension views. These are the preoperative MRI. You can see and this is the 3-level transcambin fusion that was done for this patient, again under local, and you can see on the post-op MRI, the disc space is jacked up, and we have got good indirect decompression there. These are the decompression at all the levels. So again, a 70-year-old male, L3-L4 degenerative spondylolisthesis with lumbar canal stenosis, managed somewhere else with an L3-L4 laminectomy and a discectomy and fixation. Then he came with an adjacent segment disease. You can see here that flexion extension, the fusion is solid, but now he has developed an adjacent segment disease. So again, under local anesthesia, and this patient was quite unfit. He was a cardiac patient, and he was not getting GA fitness, some chest issues as well. So this is how we managed L2, L3 fixation. Again, local anesthesia, transcambin, and just bypassed and fixed to the lower. And once this fusion is done, we tend to remove this. So this is the post-operative. You can see the scar of previous surgery, and these are the scars which from the transcambin route we had given him. So the take-home message is that the transcambin fusion is safe, effective, and efficient. Careful patient selection and thorough knowledge about the proposed procedure is mandatory. Indirect decompression can work very well, and always have the option to use an endoscope if you require a more direct decompression, maybe in the same sitting, or maybe you can stage the procedure and do a direct decompression as well. So thanks a lot for a patient hearing, and I would invite everybody. So we have started a new Cambin Society, and I invite everybody to join there, where we'll be discussing more about such cases. So thanks a lot for a patient hearing.
Thank you, Varun. Excellent presentation. We always been seeing your work. Excellent work. So just a couple of questions, and for the sake of understanding from the beginners also.
Yeah.
So when you are doing this technique, will you confirm the adequacy of your end plate preparation by putting a scope?
Sir, in the initial stages, I actually used to do that, but over a period of time, I realized that it is just an extra step which I am doing. So unless I am doing a direct decompression of the foraminal area for some reason, as per the pre-operative radiology, I don't tend to put in the scope, because you see the bleeding in that discal area is only going to come from the end plate. Yeah. So whenever I have the bleeding coming out from the channel, that means I have prepared the end plates, and we get that grating feeling when we are using the curettes and everything. So with time, I have relied less on actually visualizing the end plate preparation.
Yeah. So there is always a debate when an open surgeon tries to understand how much is enough for a disc removal, how much end plate need to be prepared. Is it just enough for the cage surfaces to just oppose, that place is enough, or you need to do 2/3 of your the end plates or more than that. So there's a lot of literature is there. When I was searching for my talks some 4-5 years back, I came across a paper saying that the moment you do a end plate preparation, partial end plate preparation, and do a grafting, and so there is a remodel, what you say, the pluripotential effect of the chondrocytes. Chondroblast becomes osteoblast, and they found that just a place where cage has to get apposition is enough, so that the other entire disc space after 3 years, they found out the fusion rates are equally same compared to what you do aggressive end plate preparation. So that is debatable, definitely yes, as long as we don't do it and see ourselves, we are not convinced. So, but when you see the Hamid Abbasi work and now Varun is being doing, sometimes we feel that that might be enough. There is no need for more end plate preparation where your cage is getting opposed. You do a best preparation there. So that is what my observation over years. Second point to add to Varun's experience, sometimes what happens if he is using a autograft from iliac crest graft, but if you are using a synthetic graft, what happens is the synthetic graft is a crystal, it breaks, and sometimes the crystals might back out and they might land in the foramen. So that might cause, Syed Usman has 2 case reports where they had formed foraminal osteophytes. Later he has to go transforaminally and again remit out. So for a beginner, yes, as till confidence is gained, you put a scope and see the adequacy of your end plate preparation. Second is any foraminal tissue you are leaving behind, then you can go ahead with your, it takes 10 more minutes more. So you have a good confirmation that you have not done an inadequate job. So that's my observation.
So 2 things I would like to add to the observation, sir. When we are preparing the disc space, I am toggling the working channel.
Yeah.
So the end plate preparation is much more than just the direct approach.
Yes.
So we, since we are in the, we have passed through the foramen, passed through the neural elements, and now landed in the disc space. By just toggling it up and down is very safe. And then your entire area of preparation and bone graft placement is much more than what is actually just the trajectory of the tube. That is one thing. And the other thing is that the graft expander that I pack is before putting in the cage, so that the cage basically compresses the graft expander, and there is no graft expander, the crystalline part posterior to the cage, which can come out. So I don't pack it afterwards. It is just basically ahead of the cage.
Yeah. And more important point he emphasized is the time you spend near the foramen. That is very, very important. If you spend more than 45 minutes near the foramen with a dilator in situ, it's a lot of stretch on the root. So you just spend as less time as possible and come out. So that's very important. And cage insertion, it's a momentary traction to the nerve. So that's why, so whatever you do, it should be very momentary. Yeah.
Thank you.
Mahesh, you want to?
Just a comment.
Yeah, yes, sir.
Regarding Suresh's presentation, I was just a little bit concerned about infection, which we discussed about. When there is an infection, I think we should not do another new area for the operation. And I think if it is, we are treating the infection, like in cases of osteomyelitis, sometimes, or bad infection, we take out the infection, put, instead of PEEK cages, titanium could be better. So that is one thing, but excellent presentation, Suresh. Another thing is about your presentation as well as Suresh, you're doing it under local anesthesia and sedation. It's really incredible. I think good, very good for the patient who are not suitable for surgery as well. I think just one thing, do you have come across anything you're doing under local sedation? Oh, I should have done this under GA because patient is moving or troubling, that kind of thing.
So sir, for that actually the patient selection is the key. And the learning curve, I would say, is not only of the technique, but how you set up the entire thing and be, very quick about it.
Correct.
And your entire team needs to be, well versed with the procedure. So that is also part of the game, so to say. And even today, I always put in an epidural line. So the thing is, with time and with experience, my reliance on that epidural line has become less and less. But it is always there as a safety net, so that I don't have to abandon the procedure. So it should not happen that I put the cage and I'm not able to put screws, or maybe I put 3 screws, now the patient has become uncomfortable, I can't put the 4th screw and the rods. Yeah. So if ever it is needed, you always have an epidural line there and you can just give a sensory top up. After that, the patient is very, very comfortable.
Thank you
so
very much.
To start with, sir, I did my first endofusion in 2018. We started with local, then graduated to epidural. In fact, we were the first to start epidural technique in endoscopic spine in 2019. But off late, I do everything under GA. I am very comfortable, so even if my colleagues are doing, juniors are doing, and they take more time, I am not worried because sometimes what happens, as Varun showed, the 3-level fusion really takes a longer time.
Correct.
And your junior is placing the screws and it takes little bit more time. Some, especially obese patients, lying prone, it becomes too uncomfortable.
Yes.
And elderly, what our observation was, invariably they will have cervical spondylosis. So they can't lie down in prone and conscious. Correct. So they start complaining of neck pain after 2 hours.
Yes.
So it becomes very difficult and they become too jittery after that. They want to rotate the neck, they can't do it often. Sometimes we find it very difficult even in epidural. So that's why off late I do entire everything, even transforaminal or interlaminar, everything under GA. I'm very comfortable. So it's all about your anesthetist. Varun is in a setup where he has excellent anesthesia. Whole team is there. You can say whole army is there.
If I had excellent anesthesia, I would have been doing under GA.
I think the teamwork is so important. I think, and Varun has shown his preparation before the operation.
Yes.
I think
so
that is incredible.
Incredible,
that helps him a lot.
So you need to set your own protocol according to your where you are working. So that gives you more strength. So, but anyway, always we need to have a backup. If patient in the middle of the surgery is creating trouble, we need backup. So that epidural catheter placement definitely gives you some confidence.
Great.
Thank you, sir.
Thank you.
Varun. Yeah, excellent work, Varun. I really appreciate your work. Well done.
Thanks.
I have 2 questions. One is in continuation with Dr. Suraj. He said, do you check with the scope whether your end plate is adequate? My question is, how do you confirm that you're not breaching the end plate?
So that is, again, it is like the grating feeling. Yeah. And you have to do it with a very light hand so that you don't dig into the end plate. In osteoporotic bone, it can sometimes become a challenge. But you can always take the lateral view and you can see, so I use a flexible curette which can bend on, so I can just see that it is not breaching the end plate. So idea is just to scrape the end plate to get the bleeding and not be overly aggressive about it.
Okay. And my second question is now, is this your primary technique for lumbar fusion now?
Now more or less, almost 80% of the time I'll be doing something like this.
Okay. And if you say 80%, what are the 20% which you would say that you don't want to do a transcam infusion on this?
So like my practice over the time has changed because in my hands this is a very fast process. So I would rather place the cage this way, fuse and do a decompression with a stenoscope, rather than trying to go lateral with the stenoscope, because for me personally it is faster. That is the only aim. So in my mind I have dissociated, like I was telling you, dissociated the fusion technique and the decompression technique.
Right.
So both are different. If it is required, fusion like this and decompression in some other way.
Thank you, Varun. This was
Varun,
very impressive.
just to add to that, what is your experience when patient has a global stenosis, bilateral facet arthropathy, global stenosis? You still to do transcam in, or you do add interlaminar?
Those are the cases, like he said, 20% where I have to address the deformity part of it, or maybe the facets are fused, there is no mobility even on the pre-op flexion extension x-rays, where I have to do an extensive release posteriorly, or maybe I have to address the fixed degenerative scoliosis. Those are
why
the
I'm
20%
asking,
cases.
yeah, why I'm asking this question is I've been discussing with all our OLIF colleagues, including our friend. So there is a OLIF people say whatever stenosis, no need to worry about the stenosis. Put the case, jack up the space. It becomes. So I've been discussing with Dr. Amit Jala's team, Dr. Karthik Kailash, Sharma from Bombay. So they say it opens up. So I just want to understand myself, how does a subarticular stenosis, which is very bad, opens up without direct decompression, just with indirect decompression. I'm just yet to know. People though they show their slides pre and post-op, it has opened up entirely. Will it happen in all cases? That is my question. So anyone has that experience, especially Ajay, being from the center which does more cases?
Actually, we all have a problem of generalizing things. So the issue is generalizing. It's not that indirect decompression does not work. Indirect decompression would definitely work where it has to work. But we are generalizing that it will work in all. And that is exactly where the failure would happen. So basically speaking, having done...
They should understand what are the cases we should go for indirect decompression.
The best thing what I have learned over years with OLIFs and other procedures and direct decompression is also that you should be able to identify what is the buckled part of compression and what is the hard part of compression. So for that you need to differentiate what is the hard bump anteriorly as end plate osteophytes. At the same time, ligamentum flavum always is not soft. The subarticular part of the stenosis can be composed of hard bone, and that can be identified only and only with a CT scan, which is not done routinely at our place or everybody. If you start using CT scan in all your diagnostic evaluation, you will be specifically able to identify that in the subarticular region, exactly behind the root, there is hard stenosis which is there, which is not going to go in spite of you distracting it. That is where you need to do a focused decompression. Either you have to combine it with a focused decompression, or you should not be doing it and do it a direct decompression procedure and a fusion procedure. But if you are relying on indirect decompression, CT scan should become an essential part of our evaluation to identify the osteophytes in the subarticular zone, which is ventral as well as dorsal. So this is the most important thing which we can definitely categorize which to be taken which way. So this works. There is another thought process in that. Say you can do a transcameron fusion cage in there. You put a bigger cage in the transcameron way. You have done it under local. Mobilize the patient. Why are you putting screw on the first day? Yeah. Take the patient as a second stage surgery on the second or third day. By that time his lateral recess stenosis, if has to be symptomatic, will get revealed. And then put a screw and put a decompressive procedure also at that point of time. So this you can stage also. This is practically possible. Yeah. So but in our setups, when patient is coming for a single admission, answers, single anesthesia, cost is an issue, these all things cannot be done. But practically this is possible. You jack up, you make the patient mobilize. 2 days afterwards, you take that call whether there is a radicular symptom there. By that time, you have done an imaging also. And in the same sitting, you complete that job and send them home.
Yeah, that is possible. Yeah.
Point to add.
Yes, exactly. Stage the decompression maybe after a couple of days.
So there are clinical criteria where indirect decompression would work. Like those patients who have no rest pain only on walking. That is first criteria. Second is mild to moderate stenosis and no calcified facets or no significant.
So this a beginner should understand that every time indirect jacking does not help. So we are with Dr. Karthik Kailash from Chennai doing a study where we want to study our cases compared to his OLIFs and see after 2 years just a jack up is okay. He says even grade 4 my patients the space opens up. So he is also their residents. He has given a thesis to one of his residents. So we need to follow up after 2 years.
So what happens, like if you don't do a direct decompression, is it enough for a grade 4 stenosis?
Space would open up by jacking up. That is all given. But the point is whether the foraminal osteophytes and all those things will disappear or not.
Yeah, that's what.
That
So
personally I
it's
feel
just
need to be addressed separately.
observational study.
Yeah.
So
No, that's what I'm saying. For personally, I would do a decompression in those situations.
So we'll
I'm
just
not
see,
still convinced
because
that
it's all, we always think that it doesn't happen. Maybe it might happen. So we don't know. So only time will tell us, the observational studies will tell us.
There are two components. One is vascular and other one is direct compression. So maybe the vascular component improves after jacking up, and that's why patient has improvement.
No, even radiologically there will be improvement.
Yeah. Yes. Exactly what Mahisha is saying.
So
Ankit
that's
is
why I'm
saying.
telling,
Say we have to remember that we are seeing so many number of stenosed patients without symptoms coming in our OPD.
Yeah.
Say in a grade 3 stenosis also the patient may not be symptomatic. So what we have to aim is not to achieve a radiologically complete decompression, but the threshold value which was the thing which precipitated the symptom. So if you get back to that level of stenosis, still the patient is going to work.
And also Ajay, when we do fusion, whether it is missed relief or open or endoscopic, most of the time, I don't do aggressive contralateral decompression. Only the side where I am going to put the cage, that is more than enough.
Yesterday, Koichi showed a plan of transforaminal unilateral laminotomy. So for central stenosis. So what he did was complete fascectomy on one side and removing the ligamentum flavum up to the central portion of one, and then the cord drift to that side. So for central stenosis, he has started doing that.
Yes.
So it is.
Last time I think the surgeon from Hussein last time who came, he showed his technique, transfacetal going to the opposite side and doing transforaminally, decompressing the bilateral lateral recess, central canal through the ipsilateral fascectomy. So yes, there are so many corridors opening up. Definitely, thank you, Varun. Excellent talk and discussion. So take home is that as a beginner, we need to understand the intricacies of foramen, and each case is different. We can't generalize every case. So with that, I will go to next speaker, Dr. It's your talk. Max, okay, Max, you can. No. Yeah. So Professor Max will be talking on his experience on endofusion. So Professor, just to you want to add the comments about how much you need to prepare the end plates? How much you need to prepare? What is that you are happy? How much need to be prepared?
Yeah, thank you. Yeah, it's a very good presentation, and also I agree with the preparation must be clear and avoid the damage to the end plate, and it's better to do to the contralateral side and also the dorsal side of the disc space in order to allow you to have enough release of the disc space in order to put more cage bone graft and in order to help to avoid subsidence. Because now there's more evidence showing that if you have good disc preparation, then can avoid the complication afterwards. So I think it's one of the key steps, and I'm going to share that point also with the new equipment that I believe maybe soon we'll see in India. Yeah.
Okay.
All right, thank you. So thanks again for inviting me to give this talk. I believe you already very exciting about endofusion. So here I will go quickly go through a little bit about the recent advancement in the endoscope, endobody fusion. So thanks again. So here is my disclosure. So here I'm going to give three directions. First, review a little bit about history. Second, talk about the advancement and also the new techniques. So you already see a lot about the use of endoscope for fusion. So I'm not going to go into deep details, But there's usually you can use two techniques. One is facet sparing, one is for sacrificing. So these two already have very good technique description and also tool innovation. So this one, you can see that cleanse clamping, as previous speaker mentioned, you can avoid the facet resection, reduce the time, and also can use under local anesthesia. And actually, the new biomechanical study show it can provide better biomechanical stability. So I will highly recommend if your patient, they can use this technique, they can have a better postoperative early recovery. But there is still some drawback, like in case with high iliac crest, maybe it's not suitable. And also the central stenosis, you must have additional decompression. The surgical procedure, like yesterday, Professor Sai already shared. First, you can go with an outside-in technique, and then resect ASAP to enlarge the bony camping triangle, and then try the cage and put in bone graft, and then finish this procedure. So all the tools have been greatly advanced. So you can avoid the extended nerve injury by the retractor. So I believe you can do it safely. The second, you can see this Dr. Michael Wang. He had also done several cases with a new invention of the cage mesh. It's a sac that you can put into the disc space and squeeze the bone graft. So this allows him to use smaller incision, a smaller preparation, and the patient can have awake surgery. And this can also, I think, can greatly revolutionize our spine care. And the third, you can see that posterolateral approach now is also greatly advanced because the advocation of by Dr. Harrison King, and also in bipolar is by Professor Hyodong Hwa. So these two surgeons, they standardized this procedure, and actually previously bipolar posterolateral fusion has already been greatly developed. So this is my good friend, Dr. Jung Kim. He also previously invited him to Taiwan to give his demonstration in 2018. So that time, I think he just showed us is a very simple standard procedure, very similar to open T-lift. You can do with bipolar or unipolar to just resect the facet and prepare implant as previous speaker mentioned. I think this is a very gentle and a very simple procedure, but you need to get used to the scope view and also the bleeding management. So this now we also start to advance, because the advance we know these two ways and know how to avoid the injury and complications. Now we are thinking about how to provide better fusion, better elastic subsidence. So in Taiwan, there are some surgeons also started to two cage technique. I think maybe also Dr. Shura also doing this. Two cage, no matter it's unipolar or bipolar, you can have two cage because they can provide a better footprint. So this, I think, is ongoing, and I believe you can start to try this. So like my case, this is a simple case. So L4-5 degenerated spondylosis with spinal stenosis. So you can see the huge stenosis area at the axial cut. So the procedure is simple. You can just start with unipolar or bipolar. So my earliest phase, I used bipolar because it's relatively easy to have a bone resection. So just identify very important 2 points. One is the Woos point, which is the medial starting point of the facet in resection. So you can find it, it's always the base camp when you do unipolar, bipolar. And then second, I will under CM or check the lateral border of that resection point, which now also be known to be Kim's point. So some doctors like to come from outside. Some doctors, like me, like to go from medial to outside. So I resect this point to this point, so can have a very similar to just open procedure. So after resection, actually you can get a very easy decompression bilateral because on the contralateral side, you can do it very easy to see the contralateral root, and then do the disc preparation, as previous mentioned, under scope view, and then prepare the implant and put in the cage, put in the bone graft and then cage. The bone grafting is also used the tunnel, use the funnel, and usually at that time I would stop the water flow to allow our bone graft to have a more impact inside and reduce the fluid inside, can also help you enhance the fusion rate. And so the use of a new material like DBM or bioglass, I usually use bioglass in this scenario because it's a little bit waterproof. So that's also a little bit sticky, so can avoid the flowing out from the disc space. So after this, we have a final check to confirm that there's no roulette or durotomy after this. Actually, I have one case that I'm going to show. Even at my very early phase, I have a durotomy. But after that case, unfortunately, I just have no other cases. So I also use the flow seal all the time to avoid the postoperative hematoma. And then finally, I do the screw insertion because I feel after the decompression, the screw insertion and also that the reduction can be better. So the procedure, I believe in the future can have some debates. Okay, so this is my case that currently I have about 44 cases. And but for this study, I estimate 21 cases for their outcomes, like surgical outcome, operation time, hospital fusion rate, and also a functional outcome for their questionnaire, and compare the result. So 21 cases, mostly single level, and they have some, mostly they are degenerative spondylosis. And my surgical time is a bit long because there's a learning curve at that time, about 3 hours. And usually they don't have a long stay, but still, I think 4 days is a bit long. Now later I'm going to review some doctors, they can just stay for 1 day. So 3 complications, durotomy, migration, and so lead to 3 revision surgeries afterwards. And so I estimate their bone fusion result with this scale. And the fusion result is quite good, and subdivision rate also still a little bit high, about 13%, which is similar to the literature. But mostly they are group B with a moderate subsidence. I believe in the future, because like I mentioned, if we have a better bone grafting and a larger footprint, can reduce the chance of subsidence. So in Taiwan, there's a doctor said his case have less than 1% subsidence. And the other, about the functional outcomes, actually is, of course, it's a fusion surgery, so the outcome is good. And also this one is another case with 88-year-old lady with L2-5 spinal stenosis with L4-5 degenerative spondylosis. So this case, how will you select? Of course, we do endoscopic fusion and decompression. So we do for L2 to L5 decompression, L4-5 fusion with this incision. So it's easy that you can extend your decompression with the 2-polo. So it's no matter that, just very similar to unipolo, you can do a jumping technique or sliding technique, very similar. So you can do it with unipolo or bipolo, and then do the fusion. So the lady, next day, she's very happy and can stand and walk. Actually, she discharged 2 or 3 days later. But I still have complication like this case. It's a subsidence case. After fusion, the case have a migration and subsidence and cause the existing nerve compression. So this case, we do a unipodal transforaminal decompression and just impact the cage back, and then the patient went full recovery afterwards. And the other case is an incidental durotomy that we can see after surgery. I checked and I found there is some roulette. So it's also, fortunately, I found it intraoperatively. So I always have a second check for this kind of case. So you can see the roulette come out. So I just pack with the gel foam and the Duragen, and then use the T-cell to have a seal. So this case also discharged smoothly and without any complications. So just even if you meet some complication in endoscope, don't worry. You can manage it with endoscope. So now comes to the current advancement. I know everybody already see a lot of tools. So for the discectomy tools, now there's advance. Also for the foraminotomy tools, there's new advancement. And also now we can use such kind of trephine to remove facet as well. So there's new company developing new tools that you can see under endoscope to remove the facet. So can largely increase the speed for facet preparation. So usually facet resection is a big issue. The other thing is about the fusion tools. There's more retractors coming up. So with the expandable retractor that include the roulette protector. So there's also some debate between the two-tip retractor or one-side tip retractor for transcamping fusion. So there's more doctors like to use one-side tip because the two-side tip can have the chance to damage the external root or the transversing root and might cause a durotomy when using two-side tip retractor. The third is about implant preparation. It's always another time-consuming process. So there is a company, Reverse Mind, they now have a new model for power drill to prepare the implant. So there's some manual tool also coming up. I encourage you to try because this tool can have a chance to increase your speed up to 20 minutes, less than just save 20 minutes. The other thing is about the cage design. Now still debates because the expandable cage have been found to increase the disc height, but not the lordosis. So this, I believe, maybe still a bit expensive, but maybe in the future can be a choice. The other thing is for the composite cage and 3D printing cage, they are offering better fusion outcomes. So in the future, maybe you can consider use this kind of cage. So with the new evidence, 2021, the meta-analysis show endoscopic fusion provide a better outcome, less pain, and but a longer surgical time and a shorter length of stay. So it's the same until now. So the other group that is published in the Spine Journal, they have less inflammatory cytokine after the endofusion. And in 2022, there's a series showed that bipolar fusion and unipolar fusion, bipolar fusion seems to have a better fusion rate and a less learning curve. And, but of course, this is in debate because bipolar fusion and unipolar fusion now is just starting phase. So there's still a lot advancement inside. So in the future, I believe these two techniques will be similar. That reason for the better fusion rate that bipolar endoscope surgeon feel because the scope diameter is smaller, so it can go into deeper to the disc space to see more clear about the implant preparation. But I believe in the future, if we have angular changeable scope, then unipolar scope maybe have a chance to be better. Okay, so the other is I checked on the recent review. They always give us the same result. In 2023 in scientific report, in 2024 in Oxford open meta-analysis, they both give us the same result is less blood loss, less length of stay, less complications, and less pain, less leg pain, but longer surgical time, longer training time. So I believe in the future, what we need to deal with is the training. So this kind of forum is important. And also now we can see a lot of benefit for endoscopic fusion. So it can reduce, even we can perform in obese patient, awake surgery and fast recovery, and can have a decreased durotomy rate because the better visualization. But of course, training, equipment, and need more studies. So like Dr. Shura mentioned, a registry in the future will be beneficial to all these things. So the new innovation techniques, I believe we are incorporating now, like a new navigation from Real Track or JoyMax. They are using an electromagnetic way to see the needle. which is just different from the original traditional navigation. And also there is a fusion technique with the ultrasound. So this one is the MRI ultrasound fusion imaging navigation. So the patient can have an MRI and their device, their image will fusion to the ultrasound. Then they can see the needle on the ultrasound. So they can provide less radiation during the surgery, and also can show the MRI image at the same time. So this already have 2 to 3 clinical report. Maybe you can share review next time. We are doing actually a meta-analysis for navigation system, and we also found the benefit of using navigation for endoscopic spine surgeries. So the other thing I saw at a booth, there is a new navigation system using a computer vision. So this can avoid the use of a camera, and also it's a new model. So I believe this company can do a very promising endoscopic spine surgery assist in the future. And also for the AR, MR, now also there is some more company coming up, like it's an Israel company, they are using a goggle. But there's problem still exists that the use of a goggle is a little bit not comfortable, and also can a little bit cause a dizziness. But I believe in the future, this model can be better and can really assist our daily spine work. And new things coming up is use a robot. So this is a new study coming up just this year. It's from South Carolina. So they had done 23 cases with a robot for the spine endoscopic fusion. So they found out it's beneficial. It's a good reduce the surgical time, and also reduce the learning curve, and also their length of stay is just 1 day, which is really amazing. And I believe in the future, this can be an ambulatory surgery. So I think I see this is a very good opportunity for endoscopic fusion, because it can really change also the reimbursement and also the payment system. The other thing is about endoscopic system that, as I mentioned, now there's a more different scope with a different angle change, diameter, length, and also it can incorporate not just unipolar scope, you can incorporate bipolar scope. So in the future, maybe you can have 2 to 3 scope at the same time, and some doctor even do 2-side endoscope surgery. So it's, I think a lot of things coming up. Or digital scope, higher image quality with 8K, and 3D visualization, ultrasound, infrared, harmonic displays. Those are all coming up. So so we're going to use it. And this is my, as I mentioned yesterday, we use a computer vision to recognize the tissue, can avoid the tissue damage, and have a better, safer operation. So this, I believe, also can be another opportunity. And also for the robots. And currently we see the robots, they are always used for just like a localization, positioning. But in the future, now we already have such kind of robot that you can do tiny, delicate work inside of the tube. So in the future, this kind of robot may revolutionize our practice, like under dry scope, you can still do something. Or maybe under inside, you can do some adenoid repair, maybe dural repair, or maybe some grafting with this. So there's a lot of imagination can be become real in the coming up years. So I think the last is always the patient. Our patient, they need this, because our patient, they want to recover faster. So enhanced recovery after surgery. Now endoscope really create a benefit zone, not just for the decompression, but now also the fusion, and also in the future, maybe some regenerative medicine can also help them to prevent such kind of complex surgeries. So endoscope really evolving and hoping I think that previous indication now has widely expanded, and also to then maybe in the future can do the deformity surgery, malignancy removal, and arthroplasty and regenerative medicine. So this thing already happening, like our arthroplasty. We are using endoscope for cervical and arthroplasty. I think soon maybe will be used for lumbar arthroplasty as long as the equipment showed a good functional outcome or benefit. So my last page is still, we have many good friends willing to share like you, and also this thing lead to an important platform that we are going to invite you. This is, like yesterday I mentioned, we are biodesign methodology-based group. Biodesign, what's biodesign? Biodesign is a design thinking in medicine. It's not just focused on spine area, but also for all medical area. So this is a way that doctor and engineer and business person can team up, and they find the clinical scenario, and they identify the real importance, the question, and then they come up with some brainstorming ideas, then develop a strategy for them, then try to make it a real solutions. Or maybe sometime become a startup, sometime they become a policy. So this is a way that work together by the need-driven innovation and aiming to have a better innovation. So now we are focusing on spine care. So there is some country already involved, like Stanford, India, Taiwan, Australia, Singapore, Japan, Israel. And so Asian Spine Hospital is also a hub of this. And my university, Taipei University Hospital, will work on the East Asia site. And so we are now focusing on endoscopic spine innovation, and we have workshop in December. We are hoping to invite you all to attend this. So also at the end of this month, we are going to have this workshop, and that time we are going to share more knowledge at that. If you are willing, please let me know. Please come to Taiwan. We are just next to Taipei 101, 5 minutes walk. So it's very convenient, easy to find us. So last page, I want to say again, namaste.
Thank you. Thank you, Professor. It's an excellent talk. I just want to ask one question. You showed that there were 2 or 3 cases of cage back out. So in your observation, what was the cause of this cage back out? Was it inadequate size or maybe inadequate end plate preparation? What was your findings?
Thank you. Actually, I found those cases with older age, and the bone quality is relatively poor. And the other reason might caused by my implant violation during the surgery. So now I just avoid use of the shaver because that can cause damage. And the second, for the bone quality poor patient, now I use the bone health optimization strategy. I always give them bone medicine before surgery for 2 months, then do the surgery, and after that, I still encourage them to use the bone forming agent after that. So now I have that, no case of subsidence because of this process. And also we increase the amount of bone graft, but also with bioglass, which is last chance to have migration. Because recently there's some doctor reporting migrating bone graft can cause compression to the lateral recess afterwards. So with the endoscope surgery, although we can have more bone graft inside, but sometimes can also lead to another issue caused by bone graft. So this part must be very careful. Yeah.
Okay, so just Varun and Suresh, so what is your experience of this transcambion fusions cage? Anytime you had to face this cage back out, and how did you again address it, if at all it has happened?
So sir, the way I do transcambion, all of the structures are intact, and the cage goes in line, and then I just make it a little bent, push that cage inserter down so that the cage is not in line with the window in which it is put.
Okay.
So all those things have minimized, really minimized the cage back out. That in my series I have not seen. The cage preparation again is in line with the disc, and then I toggle it and prepare all around. The same thing is with the cage. Insert it in the direction and then just maybe bend it a little bit so that the back out trajectory is different from the window trajectory.
Yeah.
And then compress over the screws.
Definitely. So
and a tight fitting cage again also helps in preventing.
So what in our experience of 280 cases till now, both transcambion and posterolateral approach. In my experience, transcambion fusion, the cage backout is
not
almost negligible, what we have seen. But posterolateral, it can happen. As Professor said, if you have not done overdone the preparation, damaged end plates, or if you have done a small size cage, the backout is more common in posterolateral approach than transcambion. In my observation, it's our experience.
I had one transcambion cage backout in the early stage. That was because of poor sizing, because the undersized cage, if you put, there is a likely chance that it will come out. So as long as your cage sizing is proper and position is perfect, it will never back out. Transcambion, actually, if you push the cage inside, close to midline or beyond it, it will never come out. That is one advantage. And interlaminar cage will back out if you have not gone up to the anterior annulus. This is very important. The cage has to be close to the anterior annulus. If it is posterior, and also if the size is very important, if the size is also not adequate, then it will come out.
I want to add on one thing about the cage position, because I always impact my cage to the anterior side. Yeah. So even if this situation still can have migration, so just always keep in mind that your cage also the position is good enough. Maybe your patients still need to encourage them to avoid overuse of their spine after the surgery. Thank you.
Yeah. So, Lohanna, you wanted to ask a question.
Yeah, Professor Max, what is your trick to put flow seal or T-seal inside? What cannula you use, or what special device you use for flow seal or T-seal?
Thank you. I always use flow seal, but also need to be careful about the compression to the dural sac. So usually I use the flow seal directly to the cannula, and then use the dilator to impact it with the blunt end. But when I press it, I just gentle press, not very forceful press, because that can increase the pressure inside. So I just always do that slowly and smoothly and compress it. Then when sometimes I also can have the chance to have bleeding, can postpone cause blurred vision, bleeding, blurred vision. So I do the same. Always do flow seal to the dilate to the trocar, and then use the dilator to press gently and reduce the bleeding. And second, but also need to flow it out always, because some surgeon they report they didn't do irrigation after that, and can cause complication because the patient have a neurologic deficit after surgery. Because also they said it will not expand too much, but it can still absorb the water and blood and expand. And the second is about T-cell. T-cell is usually I use when durotomy happened. But it can also have a massive effect if you just directly apply with something compression on it. So I always also first take out all the fluid, and then I use a very long tip that actually they provide this kind of long tip, and can directly apply to the durotomy area. And don't apply fully, you just apply slowly, and you don't need to apply at once. You can apply 2 to 3 times to allow that become a layer by layer, and that can avoid following problems. And so after use of this, and with the technique of sandwich technique, previous published by Dr. Choi, Gang Choi, this can largely avoid the chance to have open repair. So I actually, until now, I only do 1 case of open repair, 2 cases of endoscopic repair, and after that, no case need to repair at all. So I encourage you can consider that. Thank you.
Thank you.
So one simple technique for a cheaper technique, you have patients when it is bleeding in endofusion, stenosis, or whenever there is any bone bleeding or anything, just remove the scope, allow that saline column to be there. The saline is a very good hemostat. You just allow for 5 minutes. Just keep the cannula, the sheath in, filled it with saline. So this column itself will cause it's a very good hemostat. Wait for 5 to 8 minutes. Go in with the scope. Just remove the clots on the thecal sac. Don't touch the bony edges. The whole clot smears the bone edge. You just remove over the thecal sac, and it's amazing. So all you have to wait is for 5 to 10 minutes. So it stops. Yeah, I told you yesterday I used in one cervical case and one lumbar case I have to use. Yeah, so Revospine has a long one cannula they have made to inject the post-op steroids. They have made a good 2.5 mm cannula, 2 mm cannula. So that you can pass it through the scope. So it is long enough, so I attach the syringe of the flow seal to that and inject. It is easily. Pipes. So, but any cannula of 2 mm, sometimes flow seal gets stuck. So 2 mm is the better cannula. You can make it, it's very easy to make it.
Yeah,
Thank you.
One small question.
Yes. Yes.
Yeah, a partial back out of the cage, fuse, possibly the patient failed to follow up maybe after 3 months or 6 months. Symptomatic, asymptomatic, how do you manage?
For the shoulder
with fusion, yeah. With partial back out with fusion, symptomatic, asymptomatic.
Actually, yeah, some cases don't have any symptom.
Yeah.
Like the case that I impact back the cage, I worry might still have shoulder source there, but fortunately the patient have no symptom. But I think sometimes the patient still have symptom if there's no fusion, and can lead to chronic back pain. And so that scenario may need revision surgery after that. But fortunately, until now, no case need to do the cage retrieval. Yeah, I hope that can persist.
Yeah, another small note as far as we Indians are concerned, with regards to flow seal, there is a cheaper alternative as such. What you can do is you can take the dry gel foam, scrape it, take it into a syringe with saline, and take an infant feeding tube, possibly 10 French or something, and you can always inject it, and it works very well, hardly $200-300 as far as we are concerned.
Yeah, I remember you telling me last time.
It's a very useful tool as far as we Indians are concerned.
Yes. And to your question, Ramesh, the cage back out, again, we need to find out what is the cause of back out. If you have done a posterolateral approach endoscopically, the corridor is very good. Even after 2 months you go in, the corridor is good. There you can just go, if it is because of aseptic inflammation or undersized cage, you can still go there, grab the cage, remove it. Either you can bang it anteriorly if you think cage is adequate size, or you can remove the cage, scrape out all the debris and put a bigger size cage. It is very easy in endoscopy because the adhesions are very less. So I had one case in posterolateral approach, patient had a back out after 2 months. Even after putting a adequate size cage, I had put 13 mm. But when I went inside, the cage had backed out and I removed the cage very easily. And to my surprise, there was a lot of granulation tissue between the interface of cage and the end plate. So we sent it for culture. Culture was negative. Patient was absolutely asymptomatic except for the radiculopathy. So we just curated it out, and I didn't put any case because I feared any infection, because culture comes later, right?
Yeah,
so I didn't place any case in that patient. He's doing fine. But still, if you are sure enough there is no infection, definitely you can bang it anteriorly, or you can remove it and put a bigger cage. It's easy compared to open surgery.
Yeah, the problem is when you have a patient coming after 6 months or 8 months with fusion, and you inadvertently you take an X-ray and you find that it is backed out partially. That is when the decision making is a bit dicey.
Endoscopically, it is easy if you have done a previous endoscopic surgery.
Maybe a small thing like if you're starting using the expandable cages, probably the backache problem will be back up of these cages. It will be less and less.
Yeah.
It may be that it may settle down the height because sometimes the end plates are poor quality. The cage can go into the body. It may settle down, but it may not back up.
Yes.
So backup will be probably less and less if you start using the expandable cages.
Yeah, definitely, sir. Point taken. Thank you.
Max, one more question last to ask to you. Mentioned about Wang, who had used the biologics for enhancing fusion. So anything to, because the BMP what comes from Medtronic is a gel which comes in multiple sizes, and you actually don't need as much a size for an intervertebral body fusion. So do you know anything which can enhance fusion, any osteobiologics, or beyond Medtronic or any other company which does it as a contained bag, which does not enhance excessive hypertrophic ossification, the path which we are following, or anything, any ideas about that?
Yeah, thank you. So it's a great question. Everybody wants to fuse faster. So there's some new material coming out that can, like biomaterial, bioglass, that can be similar to iliac crest bone graft. So the company like Actifuse is from Baxter. They have this kind of bone graft. I personally love it a lot because, as I mentioned, it a little bit waterproof, so it will not be irrigated by the fluid. So it can stick to the disc place and maintain there. So you can consider to see that. And the second is about the DBM or some BMP2. I think currently I have no evidence for BMP2, but I use some case for DBM. DBM because the amount is always a little bit little. So I personally now still use more bioglass, which I feel better. Yeah.
So bioglass is what Baxter is coming out, is it so, or?
Yes, bioglass, it's very similar to artificial bone graft like HAP. But they have an additional bioglass can stimulate the bone graft, bone formation. So
okay.
Yeah, so now there's more. I think there's the ongoing studies for that, and also there is some other company they have proteins. So that I'm sorry, I have no information, too much information for the company, but they are also widely used in the United States called iFactor. So maybe you can see that kind of product in the future, and also for the now like PRP or PRF, PLT, or some exosome, they are also now greatly used in this kind of procedure. So, but that sometimes can cause a little bit nerve inflammation in some cases. So I believe in the future we still have more study needed for using a PRP or exosome or stem cell in this scenario. Thank you.
Thank you. Thank you, Max, for the excellent talk and the discussion. Now I invite Dr. Abhinandan Reddy, my colleague, to talk on endofusion in elderly osteoporotic patients. So always we have been discussing now the end plate preparation problems in osteoporotic patients. But we also should understand about the screw placement, the screw problems in osteoporotic patients, and especially when it comes to grade 2 listhesis, how will you reduce it? It is very challenges when we face doing a fusion. So Abhinandan will emphasize on the tricks and how to do endofusion in osteoporotic patients.
After an Abhinandan talk, Dr. Pramod Lokande, unfortunately due to some personal reasons, he couldn't come. He's logged in and is online, so he will give a lecture on cervical endoscopic decompression posterior approach. So over to Abhinandan.
So once again, I welcome you all for the academic extravaganza. So now that you know where to put the scope, what size of scope and what sizes and what angles, now let's just concentrate on how to put screws. Okay, so most of our patients are elderly, so most likely we'll deal with osteoporosis day in, day out. So especially when it comes to open surgeries, we have a lot of options for treating with osteoporosis. But when it comes to endoscopic surgeries and MIS techniques, MIS screws, you have got limited options where you want to secure a screw, or especially in a listhesis case and an osteoporotic patient you want to reduce, then you are very much concerned about the screw hold. So as you all know, osteoporosis is a systematic skeletal disorder with decreased bone quality where the screw hold is very, very less. Is it really a problem? Yes, it is a real problem which we face day in, day out, because most of our patients are elderly. So these are few case examples where inadequate assessment of osteoporosis or inadequate treatment of the osteoporosis with the instrumentation, what it can lead to. So this kind of instrumentation or not understanding the bone quality as such can lead to many kinds of complications, screw back out, screw breakage, rod breakage, all sort of such stuff. So what we were usually trained. So these are few techniques where we augment the screws, routine normal screws with the cement, address the osteoporosis to have a better hold, longer screws, more medialization to get a longer screw, and a dual core screw which has a cortical thread near the pedicles and all that. So what we are going to do in MIS techniques. So as we all know, adding a little amount of cement to the screw, it increases tremendous screw hold, especially in an osteoporosis patient. Though there are little complications associated with cement leakage and other pulmonary complications of cement leakage into the systemic circulation, with adequate experience we can mitigate that also. So these are few case examples. So I would like to have my screws as medial as possible so that I get a longer screw, and as thick as possible. Generally we use 6.5 screws, and as anterior and possible so that I can have a double cortical hold. So especially in listhesis, when you want to reduce, you want to have a good screw hold, right? So you are putting all kinds of forces. You are distracting, you are pulling the screw, you are increasing the disc space, you are rotating the spine. So these all forces which we are putting up, does the screw really have that amount of hold where you can put all your tactics, where you can reduce a listhesis, especially grade 2 and beyond? So in a normal spine, yes, the screw holds good, you can reduce it. There are no such complications like screw is backing out or the screw is breaking. So we have adequate disc space, you are distracting. Okay, so are you able to do these kind of forces in an osteoporotic spine? No matter how bigger the screw is, how medial the screw is, are you still confident in applying all these forces in reducing a listhesis especially? Or if you are doing a multi-level stenosis work with multi-level fusions, how the screw holds? These are few case examples which I am showing. What we do at Asian Spine, especially in our endofusion patients, as you can see, there is a grade 1 to 2 listhesis with severely osteoporotic spine. Though we do DEXA scan, that BMD scan, we quantify it as minus 2.5 and beyond as osteoporosis. But what we feel is, when you are trying to insert the guide wire while putting a screw, how easily the guide wire passes gives you a rough estimate of how osteoporotic the spine is, whether to put cement or not. So if I am able to pass the guide wire pretty easily, it is reaching the anterior cortex pretty easily. So for me it is more or less like a very severely osteoporotic spine, no matter how much the DEXA score is. As Dr. Max was saying, priming the patient before is an ideal job with teriparatide or something else, which increases the bone quality so that the implant related complications later on is less. But especially in our Indian setup, patient coming back after a couple of months of therapy, probably trusting you again might be a challenge. So the other options would be like augmenting the screw with the cement. So we have come up with a simpler, cheaper options also. We are using the same MIS screw. We are not using the fenestrated screw, because using a fenestrated screw, I am a bit scared, because I have to inject cement at a higher pressure and it is too much liquid. So the chances of leakage are too high. And also they are on a costlier side, especially on local made or a imported quality. They are on a higher side when compared to the normal options. So this is a technique which we do. We generally insert all the guide wires beforehand. Then on the picture you can see I put a normal kyphoplasty working channel. I insert the cement. Then I reintroduce the guide wire before the cement gets hardened. Then I put the normal screw over that cement. So I give at least 5 to 8 minutes time for all the screws to set in, the cement to set in. Now the screw hold is pretty much good. Then I do all my forces, reducing, pulling the screws, pulling the vertebra back, expanding the disc space and all that. So this is the kind of picture. As you can see, it's a grade 2 listhesis, severely osteoporotic. I have introduced, like in the previous image, I have put all my screws, cement augmented. So this is the picture we have. So it is a kind of cheaper option with the normal screws which we do day in, day out regularly. And also we are able to do endoscopic fusions for such grade of listhesis in an osteoporotic patient also. So it's just adding to our scope of endoscopy. So these are few case examples which I am showing. So this is also kind of listhesis where with severely osteoporotic. As you can see on the image, I have introduced my working channel for the kyphoplasty. Through that only I put all my cement. Then I reintroduce my guide wire. Then again I put my screws. So the amount of disparity you see among the two screws. So I am confident now that my screw holds good. I can pull it as much as possible and I can distract as much as possible. So you can see the different cases which we have been doing over the past 2 years with the similar normal screws and normal cement. Yes, we had a case of leak, but then again endoscopy helped us. Through the endoscope, we went in there, we removed the cement on time. Patient did not have any kind of complications as such. So working with cement is really essential. Consistency of the cement is also very much essential to understand when to inject, when not to inject, how hard to push it, and how fast you have to reintroduce the guide wires, and how fast you have to put the screws on the already existing cement. So these are all the few case examples which have been working out. So we have almost reduced high grade listhesis grade 2 and also beyond with cement augmented screws, especially in the elderly with osteoporotic females. But then we, after doing all this stuff, as Dr. Max has already said, we again reintroduce the bone forming agents like teriparatide. We continue for almost 2 years along with calcium and vitamin D supplementations on a regular basis. Also, we are not just concentrating on the screws in an osteoporotic. So even how much to prepare an end plate. Yes, grating sensation is always essential, but over enthusiastic preparation of an end plate also can result a lot of complications, especially as you can see the screw back out, the cage back out. So you have to be very careful in dealing with the end plates also, especially in an osteoporotic spine. Over enthusiastic distraction can also lead to subsidence, like Dr. Max has shown, like a couple of his cases there was subsidence. So do not try to expand the disc space beyond a certain limit so that you are eager to put a bigger cage, but the end result might not be good, because over a period of time, probably in the follow-up, there might be end plate crashes and the cage is submerged into the body. So over enthusiastic preparation also is limited. So once the surgery is done, what to do to increase the bone strength? As I have already told, we start on patient on teriparatide. There are few other alternatives, but also you have to supplement with enough calcium and vitamin D. Thank you.
Thank you, Abhinandan. So, for the lack of time, we'll take the questions when we are showing the live surgery, because Dr. Pramod is logged in and is online. So, over to Dr. Pramod. Good morning, Pramod. Can you hear us?
Yeah, can you hear me?
Yeah, sir. We can hear you. Good morning. Sorry, we are sad that we missed you this time.
I'm also very sad because this is one conference I wouldn't miss in my entire year of schedule. But
yeah.
So, maybe next time.
Dr. Pramod Lokande is one of the senior most endoscopic spine surgeon in India. He is our good friend, mentor. So he's been doing excellent work from past almost 20 years now. So he's based in Pune. So he will be sharing his approach of endoscopic spine in cervical region. Over to you, Dr. Pramod.
Yeah, thank you, Sukumar. Thank you for the invitation. Since Dr. Bhanod is not coming, he was supposed to talk on cervical posterior foramen anatomy. So what I've done, I've combined both the talks together along with some important tips on complications avoidance. So that is going to be a lengthy talk. I hope all of you can bear with me.
Definitely.
So my talk is about the posterior approaches to the cervical spine and the techniques and the complications avoidance. So this is always the first slide which I always prefer to all of you to see, so that it will get us all back to the basics of what minimally invasive spine surgery is, or endoscopic spine surgery is. The aim is to, the two basic fundamentals are to minimize the access related injury, minimize the injury to the soft tissues and the bone. And second is to avoid unnecessary fusion. So it is, endoscopy is more like a motion preservation surgery than like a fusion surgery. So this is what it started for, any cervical compressive radiculopathy. ACDF is still the gold standard. And it does have its own share of complications, but all of these complications, they can be avoided with experience and, practice. But the problem of adjacent segment disease, it's still persisting and there is no answer to it right now. The second option, which is a non-fusion one, is the disc replacement. I think it is a very glamorous and very expensive option, and it has its own share of complications of heterotrophic ossification, mechanical failure, and basically it doesn't do what it is supposed to do in the long run, that it doesn't maintain the motion which is which you have pre-operatively. Over the time it spontaneously fuses. So this posterior cervical laminoforaminectomy approach, I think it is a much more physiological approach, much cheaper approach. It is easy to perform, and that is why it is an approach which all of us should not neglect. This is the evolution of posterior cervical discectomy, and we know that Professor Rutan is the one who described this endoscopic approach in 2008, the full endoscopic approach to posterior cervical spine. And indications are predominantly radicular pain. We still don't operate for a fully established myelopathy patients. So indications are disc herniation, soft disc herniation, pressing on the nerve root, or foraminal stenosis. And multi-level is still a challenge for us. So I tried to simplify the approach into two possibilities: a foraminectomy approach, which is basically to decompress the nerve root, and the over-the-top decompression of the cervical laminotomy approach, which is to decompress the spinal cord for bilateral posterior decompression. So this is the positioning of the patient. I started with using a Mayfield rest like this, but now I've completely shifted to that soft head foam which is available in the OT. That is very comfortable for me because that is radiolucent and it can allow the CM to proper visualization in the AP also. So we start with marking of two lines, the mid facet line or the pedicle line, which is in the AP view and the center of the disc in the lateral view. Once that is done, we insert the needle to identify the proper trajectory. Your endoscope has to be in the same direction as that of the disc surface, because if you're oblique, then there is a possibility that you're not able to get on either side of the nerve root and visualize the disc fragment properly. So this is where we dock the working channel at the lamina facet junction, and the opening is towards the medial side. This is the first view which you see, which is the muscles, and once the muscle is removed, you expose the interlaminar space which appears like a V. So this appearance of the V is very, very important, and this is the beginning of the surgery. Drilling always starts with the superior lamina. It should start at the lateral side at the facet junction level, so that there is some bone to protect below, so till you get comfortable using the drill, and then you gradually shift on towards the midline like this. So I prefer to use a side oval burr with a side protection like this, so that it helps me to drill the thickness of the lamina adequately. And for the lower lamina, I usually try to thin it out with a round burr, either a diamond or a cutting burr, whatever is available. And this is very precarious, because you see this is the attachment of the ligamentum flavum. This is the superior lamina. Your drilling starts here, but at the inferior lamina, you are very close to the spinal cord, and the ligamentum flavum is very thin. So if, by mistake, if you just have a up and down movement of the drill, you can just puncture and go and hit the spinal cord. So drilling of the inferior lamina is probably a little bit more dangerous, and you should do it more with a lot of care. And always aim to thin out the lamina so that the remaining part can be removed easily by this tube sheath punch, which is available with RepoSpine. So this is the final picture of a discectomy. Here are a few case examples. Simple cases, a soft disc herniation on the right side, no evidence of myelopathy. And this is the first picture. This is the drilling of the superior lamina with the oval burr. This is the drilling of the medial margin of the facet and the inferior lamina. So what I've done, I've just thinned out the lamina so that it can be easily removed with this tube sheath punch. This is the axilla of the nerve root, and we have to tease it. This is the advantage of a 25 degrees angled endoscope as compared to the microscope, that you are able to see under the nerve root many times. So retraction of the nerve root in the superior or the inferior direction, that is allowed, but you should not retract the spinal cord. Otherwise, you may land up into neurological deficit. Always try to explore the nerve root from both the sides so that there is no remnant fragment seen. Another massive disc herniation reaching right up to the midline. Again, no signs of myelopathy. And these are the post-operative MRI pictures completely. Look at the size of disc herniation which was there in this case. So this is a C7 T1 disc with a very severe weakness of the left hand. And you can see there is short neck patient, muscular patient are not able to see the junction properly. So the visualization of such patients, the interlaminar space has to be visualized in the AP view, and your trajectory direction has to be confirmed in the lateral view like this, using a double needle technique, so that you are in the proper trajectory, so that you can dissect all from both the sides of the nerve root like this. So multiple fragments removed, and this is retraction superior and inferior is allowed. Retraction of the spinal cord again is not allowed. I would like to stress that again and again. And this is the next morning improvement which is seen immediately. Coming to foraminal stenosis part. The difference is the surgery is similar to that what we do it for disc herniation. Only thing is we have to drill the osteophyte which is there pressing on the nerve root from the anterior side. And this is a special device which we use, which is called as a face mill. It is a cylindrical device which can be slided between the pedicle and the nerve root, and you can just retract the nerve root with the smooth side surface of the device. But the anterior margin is very sharp, like an hollow mill. So it is able to go inside and drill the osteophyte by the hand movements, rotating movements of the fingers. So this is complete decompression by the face mill. Again, another case of foraminal stenosis, hard disk seen here. Now, sometimes what we see that there is not adequate space between the nerve root and the pedicle for us to insert this face mill inside. So sometimes we have to do a partial pediculotomy, remove part of the pedicle, create enough space so that the the face mill can be slided in. That's the big osteophyte there being drilled with this face mill, and you just flatten it out. This is the picture which you see after the flattening of the osteophyte. That's the disc surface. There's the disc space in there, and you again have to repeat it on both the sides. Like there's again an osteophyte. So this is the post-operative MRI pictures. Now coming to the third procedure, which we call as the cervical ULBD procedure or the over-the-top decompression procedure. So we have to understand there is a spectrum of decompression available depending on the extent and pathology which is present in the cervical spine. And that spectrum extends from laminoforaminotomy right up to multi-level cervical laminectomy, which is still at a distance. We have still not reached that stage. But focal laminectomies are possible. So laminoforaminotomy, ligamentum flavum resection, hemilaminectomy, and ULBD procedures. These are the procedures which are mainly for patients with predominant radicular symptoms and minor myelopathy symptoms, which are more of posterior column. Whereas cervical laminectomy and cervical laminectomy multi-level, these are mainly for predominant myelopathy symptoms. So why endoscopic decompression? Why not? Why do you have to shift on from open cervical laminectomies to endoscopic decompressions? So you see that the treatment of cervical myelopathy is whenever we have compression of more than 3 levels with a maintained lordosis, we go for laminectomy either without fusion or laminoplasty. And the problems with this are a chronic axial neck pain and shoulder pain, reduced range of motion, post-operative kyphosis, and sometimes a recurrence of the neurological symptoms. And all this can be attributed to the extensive exposure, which is causing damage to the ligamentum nuchae, the attached muscles, and sometimes to the facet joint. So this is a slide from the clinical anatomy, which I'd like to stress. You see the attachment of the trapezius and all the important muscles of the neck, which balance the heavy head on a narrow neck, again connected to the heavy body. So it's like a big lemon applied to a small stick. Neck is like a small stick in between, and there's a big head on top of it. So these muscles, they play a very, very important role in balancing the head and maintaining posture. So if you damage this attachment of these muscles, again, you can, in this third picture, you can see the ligamentum nuchae and the attached extensions, the different parts of ligamentum nuchae. You have the septal part, the dorsal part, and the lateral part. And all of these, how they keep the muscles together and in harmony so that they are able to function the neck, give proper postural, posture can be maintained by these muscles. So this is again architecture of the human ligamentum nuchae. So these are the muscles which are coming in and attaching to the ligamentum nuchae in the between. And this ligamentum nuchae is attached to the tip of the spinous process like this. And that is why the tip of the spinous process is a very, very important structure which provides attachment to the major muscles of the neck. And whereas after the tip is below this part, nothing is important. So if you can remove this lamina and the base of the spinous process, maintaining the attachment of the tip of the spinous process, the problems of this post-operative kyphosis and problems of post-operative neck pain can be minimized significantly. Again, in this particular approaches, what we do is we don't go from the midline. So we don't detach the attachment of the muscles from the tip of the spinous process. We go from the side like this, landing on the laminofacet junction. So these are the advantages of doing endoscopic decompression for multi-level stenosis over the conventional laminectomy. So here is a case example. This was a very unusual case, a 52-year-old female, which she basically complained of severe right upper limb radiculopathy, which was not relieved with absolutely anything. Severe loss of sensations in the right hand, and the loss of sensations was so bad that she suffered a deep burn on the forearm without any pain. There was significant weakness of the triceps and the hand rib, almost 3 by 5, and she had bilateral tingling numbness in both the hands. There's no evidence of myelopathy. So we planned for this ULBD procedure. The dissection in ULBD procedure or resection of the lamina in ULBD procedure is significantly more as compared to what we do for posterior foraminotomy. So we keep on cutting the lamina till the ligamentum flavum is completely detached from the remaining lamina. It can be removed as an on-block thing. And this was a very unusual case. We had a conjoint nerve root there. It was a triangular nerve root with the hernia mass lying in between. This is the upper nerve root. And there were two lower nerve roots, one lying one on top of each other, like this. So once that was done, I drilled the base of the spinous process and you start resecting the ligamentum flavum from the opposite side. And this is the last part of the film. You can see the facet joint on the opposite side. So over the top decompression is possible with this particular technique. So this is what I saw during the procedure, that we had the normal root was non-dominant. It was in the upper part, and the lower root was dominant. It had two separate sensory and motor components. And the hernia was lying in between this triangle. That is why the patient had such severe complaints. So these are the post-operative MRI pictures, and the patient, you can see the burn on the right forearm, which is suffered, and she was absolutely normal the next morning. This is again another case of which I have seen. So this patient was basically operated for a C4-5 significant myelopathy, uric grade 3. Patient was wheelchair bound, and ECDF was performed for at full L4 C4-5 level, and the patient improved of his myelopathy, started walking comfortably. But post-operative, after a few months, he started getting radicular pain in the C5 and C6 dermatome. And when we did a fresh MRI, you can see there is a compression at C4-5, remnant compression at C4-5 level, and which was quite significant, pressing on the spinal cord. So we tried to evaluate, and it was seen that it was not an osteophyte. If you can see the CT scan, it was not an osteophyte, just an annular flap which was pressing on the spinal cord. And we planned for a over-the-top decompression at C4-5 level and PCF approach, the foraminotomy approach for C5-6, both right-sided one. And here you can see in a single incision, we are able to tackle with both the levels like this. So this is the decompression, the first decompression, the second one. And a complete laminotomy from the back has been done. And if you can see the post-operative picture, the cord has been completely decompressed. There is adequate space on the back side, and the cord has regained its original size. So this is the ULBD approach. The axial CT shows complete decompression, and the C5-6 also, you can see a good foraminotomy with removal of the osteophyte there. So what are the indications of ULBD procedure? I think it is good enough for single or two level stenosis. Again, 3-level stenosis, it's a bit tiring. And one of the reasons for this is the very long length of instruments which we have still. The instruments which we are using for cervical decompressions, they are still the lumbar spine instruments. And a lot of these instruments, they are made for the European people. So the length of the instruments makes it very difficult for us to control them properly. And especially the drill. The drill is so long that it really tires it out. So doing a 3-level stenosis is still a challenging procedure for all of us. So bilateral sensory symptoms again, and I wouldn't like to do this procedure again for a focal decompression of stenosis, or not recommended for an established myelopathy where the compression is predominantly from the anterior side. Contraindications, same thing, anterior significant compression, bilateral foraminal anterior compression, instability kyphosis, and multi-level pathologies. So let's talk about complications. Personally, I feel that the incidence of complications of endoscopic cervical spine surgery, they are much, much lower than what we see in open surgery. And one of the reasons is the clarity of vision, the illumination, the magnification, and the normal saline which washes out all the blood clots. So the chance of injury are very, very less unless you are bad in drilling. So, intraoperative bleeding and spinal cord nerve injury or the dural tears, these are the common complications what we see. And all these can be attributed to, the problems with drilling. The commonest complication with any minimally invasive spine surgery for that matter is a wrong level surgery, because if you're not on direct target, then your tendency to shift or drift away from the target is very common. And one of the reason is there is very close proximity of the interlaminar space in the cervical spine. And especially if you look at the lower cervical spine, the disc spaces, they are inclined. There is a caudocranial inclination. So if you don't position your patient properly, then there is a tendency that the endoscope may straighten up during surgery. And if you don't reconfirm, you will land up into the upper segment. So it's very common at the lower levels. And what I do for this is once the position is cannula is inserted, I try to make it straighten and take it vertical to the ground by doing a reverse Trendelenburg's position of the taper. Spinal needle has to be, inserted before the actual incision is taken to identify the correct level and trajectory. And again, before you actually start the drilling, you have to recheck the correct level so that you don't make a mistake. Sometimes the Siam is visualization is difficult. I can tell you is the AP visualization is very, very important, and you can decide the trajectory whether it's right or not right by using this particular double needle technique. The second complication which we can face is the bleeding, and the most probable areas of the bleeding are posterior musculature, the cancellous bone, and the venous plexus, which is lying on the surface of the spinal cord and around the nerve root. And you can see that this is the venous plexus you see on the surface of the cord. And the best way to deal with it is that if you see a screen like this, complete bleeding, you don't have to do anything. What you have to do is just insert a small piece of Abgel through the working channel and remove the endoscope and insert the dilator. Don't press it down. You just insert it, let it go, slide it as per gravity. So this dilator, it acts like a patty, compressing. And if you stop for 10 minutes or 5 minutes and you can just remove it later on, the bleeding is already stopped. Sometimes we can coagulate with it, coagulable bleeders like this with the help of RF, or if the bone bleeding is there, you can shift on to a diamond drill, or even there is a simple technique. What you do is when you're drilling, even with a serrated burr, just start drilling in a reverse mode. Even if drilling in the reverse mode, that can stop the bleeding many times from the bone. And sometimes we have these irritant bleeders which they don't stop by anything. So all you can do is reposition your cannula, rotate the cannula so as to hide the bleeder from the actual visualization. And the second is advance the endoscope. So if you advance the endoscope, automatically the bleeding is not visualized and the field becomes very clear for you to continue your surgery. So never ever increase the fluid pressure by more than 60. 60 is also too much. I would say that more than 50 is very dangerous in the cervical spine. Always try to use your endoscope in an open irrigation system flow, not as a closed system, because if you use it as a closed system, the pressure is pretty high and there is a possibility that the patient may develop severe neurological deficit post-operatively. And this is the most important sentence which I always tell with all my friends is always try to prophylactically coagulate the potential bleeders. So don't stop. The moment you see a bleeder, even no matter how small it is, you have to coagulate it before you proceed on to the next step. Now here's a case of C3-4 disc herniation on the right side. The patient had significant pain on the left side, and there was inability to abduct the shoulder. And we try to do a posterior foraminectomy approach like this, and there you see that this is the root and that's the disc hernia there, and there you see that's the vertebral artery, this one. This is the vertebral artery there, sliding like this, and that's passing through the foramen transverse area. So this is the vertebral artery, and this is the location of the fragment which from which I removed. So you have to be very, very aware of the position of the vertebral artery in the preoperative MRI pictures. So you can see that the disc herniation is there, and this is the vertebral artery. Even if you straighten the endoscope a little bit and you advance the endoscope more deep, there is a likelihood that you can damage the vertebral artery, either with the help of drill or a sharp alligator kind of forceps, or sometimes with the face nail if you're trying to remove the osteophyte, uncovertebral osteophytes. So be very, very careful of the location of the vertebral artery. Vertebral artery injuries are not so common. Now, this is the track which you see that if I stopped here, even if you extend a few millimeters downwards, the vertebral artery is lying exactly below it. So you have to be aware of this by studying the preoperative axial sections. So injuries to the vertebral arteries are not so common in the V2 segment. They are more common in the V3 segment, C1, C2 junction, and especially they are more common with in cases where we use a lot of hardware, the instruments. And but you can see that even with posterior foraminectomy approach, there is a rare incidence of 1.8% which was reported. And so even though it is rare, it can be a very disastrous kind of injury, and you have to be aware of this. So this is again a very important paper by one of my friend, Yongsun Kim, and what he has done, he has defined the anatomical relationship of the vertebral artery with the facet joint and how much to drill in the lateral recess. And what he have mentioned is, as you go above the level of C5, 6 level, the vertebral artery comes closer to the midline. So you have to be very, very careful that the risk of injury increases as you come, as you move above with the cervical spine. So this is again a cadaver dissection paper which is showing the V2 segment of the vertebral artery in close relation with the cervical nerve root. So this is the vertebral artery here, and these are the nerve roots. So the vertebral artery is lying just anteriorly to the nerve root. So if you go too laterally also, there is a chance that you can injure the vertebral artery. Another important paper, I think this is a cadaver paper again, and you can see there is a hairpin bend of the vertebral artery which is seen at the C3-4 level, and the nerve root is engulfed in between. So in this case, even if you're doing an anterior ACDF procedure, there's a high chance that you may damage this vertebral artery if you don't use if you're not aware of this condition preoperatively. So all these things is to make you remind that preoperative MRI studies of the position of the location of the vertebral artery, either with MR angiogram or this axial sections of the MRI, is very, very important. This is again an important paper which was published, and this was a 46-year-old female with left C6 radiculopathy. They performed an open posterior foraminectomy approach. There were no intraoperative complications, but after 7 hours, what she developed was a right homonymous anopia, all the brain symptoms, and there was gait impairment and some kind of quadriparesis. And imaging showed that there was occlusion of the left vertebral artery from C7-T1 junction right up to C4 with an intimal fap. And there was thrombosis which embolized into the brain, causing multiple infarcts. And they could not find any intraoperative cause. The only thing they postulated was they were using a high-speed drill, and the vibration of the drill that was transmitted through the bone, that caused the arterial injury and dissection. The third important complication is the neurological injuries, and I think transient paresthesias are much more common as compared to severe motor nerve palsy. They respond very well to conservative treatment. The reason is severe retraction, improper handling, and the wrong use of radio frequency ablator. You cannot be harsh. It has to be a gentle feather touch around the nerve root, around the spinal cord, which will prevent these kind of complications. And severe motor palsy is possible, especially in the patient having pre-existing motor weakness. Most important, which I feel, is the failure to identify anatomical variations of the nerve roots, which are very common in the cervical spine, is one of the major important reason to cause the severe motor nerve palsy. Also, bad use of the drilling procedure. Spinal cord injury is very rare. I think the only thing it can be, the cord can be injured is when you're plunging your dilator directly through the skin into the interlaminar approach. So what I always tell is that when I take the skin incision, the cervical fascia and the cervical muscles, they're very tough. And it's very difficult for you to insert your dilator right up to the facet joint. So if you use a lot of force, there is a possibility that you can just plunge inside. So what I do is I take the C-arm in the lateral view and I keep on cutting, inserting my knife deep inside till I reach the facet. So actual cutting of the muscles is much more easier than trying to dilate or advance it bluntly with a dilator. So cutting the muscles right up to the facet joints with a small knife, and this cut is less than around 8 millimeters or so, so it doesn't matter. So this is a better approach than direct plunging of the dilator. So excessive traction, mechanical injury, and thermal injuries are the common causes of nerve injuries. And the most common nerve which is affected is C5 nerve root, which is at the C4-5 level. The reason it is at right angles to the spinal cord, directly overlying the disc space, and it is much more thinner and more vulnerable. So usually even after cervical laminoplasty or laminectomy, we do have these kind of procedures. But what I feel is this particular thing, which is the common anatomical variations or anomalies which you can see during your routine spine surgery in the cervical spine. This is the normal one. So we have these oblique roots, high origin, low origin roots, all these congenital nerve roots. But what is more important is to identify this double root which is lying on top of each other. And sometimes you can mistake the lower root as a disc hernia, and you can incise it or try to damage it with a very sharp instrument. So this is the one which is worrisome for beginners. So to avoid this is try to decompress from pedicle to pedicle. You have to get to the root from the lateral margin of the spinal cord. So you have to identify the lateral margin of the spinal cord first, trace it downwards with the help of a dura dissector to see where the margin of the nerve root lies, and that will help you in preventing these particular injuries. So to handle the drill, this is a very, very important, especially for the beginners. So if you see on the left side, this is the first one, which where you can see that the tip of the drill is absolutely not seen. Whereas the second one, you zoom down inside and you see the tip of the drill completely, so that you're able to see what you're drilling and you cannot injure the nerve root. So these are the tips. Drilling has to be intermittent. It has to be done under high magnification. So whenever you zoom in, the hand movements, they become more fine, they become more controlled. The tip of the drill should always be visible. You cannot drill blindly, especially in these very vital areas. The movement of the drill has to be sideways. It is like a pendulum. You should not drill it up and down. Most of the people who are doing transforaminal surgeries, they have the habit of drilling in the up and down movement like this. They push it forward and backward, forward and backward. That kind of drilling is not allowed in interlaminar surgeries. And this cervical spine surgery is a variety of interlaminar surgery. So movement always has to be like sideways, like a pendulum. Drilling has to be done from the side of the burr, not from the tip of the burr. And drilling should be started as laterally as possible near the facet joint till you get comfortable with the drilling at that particular time. And you should not drill the whole thickness of the lamina. You drill it only to thin out the lamina so that the remaining thinned out lamina can be removed with a Carrison punch. So this is how I do. Don't hold the hand piece or the shaver hand piece like sword. It has to be held like a pen or a pencil. Even though it is long, it is still, and the whole system has to move together. You cannot try to bend the drill inside the endoscope, otherwise it will break. So the cannula, the endoscope, and the drill, they all work in unison with each other. They move together as a single unit, and that will prevent breakage of the drills. This is a very rare complication, fluid extravasation, and it's more commonly reported in the shoulder and the hip surgeries and also in urologies. So the only reported case of fluid extravasation was by Bohm in one case of lumbar endoscopy. He did a transfemoral endoscopy, and the patient developed massive dyspnea in combination with severe abdominal pain. And after sonography, it was found there was a large free fluid in the abdominal cavity. The fluid was removed by a CT-guided puncture and drain insertion, and the patient immediately informed surgery. So this was our case. This was one of my cases early in the probably end of 2018 or so. So herniation was there, and it was well performed. So what happened was I docked the working channel at the lamina facet junction. And since I'm a short person, I tried to climb on a step. So I asked my assistant to hold the cannula there, and I was trying to stand on it, and the cannula got dislocated lateral to the facet joint. And the mistake I made is I didn't start before rechecking again on the CM. I continued for the first few minutes. I thought the muscle is there still. So after like 15 or 20 seconds, I rechecked on the CM and I repositioned, and the surgery went on very well. There was no problem intraoperatively, and we removed the disc completely. And when we turned, this was a scene. The neck and the part of the face was all edematous, and the anesthetist found that this is too risky to extubate. So we kept him extubated. So there was extravasation of fluid in the throat and the face region, and it leaked intramuscularly through the facial veins. Ultrasound shows the presence of fluid inside the muscle. And what we did, we kept the patient overnight intubated and gave steroids, and the edema completely subsided in 2 weeks. 2 days, sorry. So this was after 2 days. This is immediately post-operatively, and the patient, it was completely relieved of all the symptoms. So to summarize, I think the incidence of complications in full endoscopic spine surgery is very less as compared to open surgery. And bleeding is something which you have to be, master this technique of combining patience with prophylactic coagulation of the potential bleeder to obtain a clear field of vision. Understanding the location of the vertebral artery. Vertebral artery injuries are very, very rare, but if they happen, they can be catastrophic. So that is why I'm telling you of this particular. Luckily, till now we didn't have any, but I know some of my colleagues from abroad, some Koreans and some they have had this particular injury, and that makes me again and again re-emphasize the importance of understanding the location of the vertebral artery or the shape of the vertebral artery pre-operative imaging. Drilling has to be mastered properly. You cannot take this thing dire. You have to have at least 50 to 100 lumbar cases where you have used drill before you shift on to the cervical spine. And awareness of the nerve root variations is very, very important to minimize complications. Thank you very much.
Thank you, Pramod, for the wonderful overall view on the posterior cervical spine endoscopic approach. So to just add to Pramod's talk, that the chance of error in cervical spine endoscopic spine surgery is very, very narrow because you cannot use a big upcuts, a big Garrison punches as we use in lumbar surgery. We need to have a finer upcuts. Then the thecal sac handling you cannot do as you do in lumbar surgery. So because as you practice lumbar surgery, you get used to the handling of the thecal sac, pushing the thecal sac, handling the root there. But that liberty or chance is not there in cervical surgery. You need to be very, very careful handling the theca there. And the vertebral artery, yes, this happens when you are very aggressive drilling the facet. You drill the facet more laterally, then definitely when you are chasing the venous bleed, what happens, the more lateral you go, the venous lakes, they open up, and the moment you shift the scope to some other direction, these venous lakes starts bleeding. The moment you turn the scope towards them, it will stop. So this will hinder your surgery, and you try to chase this venous lakes. Vertebral artery is just around, and you might injure or you might cause thermal injury to the vertebral artery. So understanding the axial anatomy, T2 weighted axial anatomy, where is the fragment and how much facet I need to drill to tackle that anatomy is one. Second thing, no need to chase the osteophytes. You have done a good posterior decompression and removed the acute offending agent. No need to chase the osteophyte, because you have done a good dorsal decompression. That itself gives you very good relief to the patient long term. So these are some of our observations. Thank you, Pramod. Thank you very much for the time. And I think you have a surgery to be done now. So we'll go to our next session, and we'll meet you next time, Pramod. Thank you very much.
Thank you very much. Thank you.
So we move on to the next important session of the day, the endoscopic spinal fusion. So connect chestava na laptop connect. So today just will the two cases, the one first case will show you the technique Max was describing, the posterolateral approach. It is the same approach what we do day in and day out in open T-leaf or MIS T-leaf. What is our idea? Remove the bone from pedicle to pedicle. So that is our idea, and get as much bone graft as possible to have a very good allograft. And same time, if patient has a bilateral stenosis, you decompress the bilateral stenosis through the same route. So these are our any surgery, as open, MIS or endoscopic. This is our, then how to remove this facet? There are various ways. You can remove it by piecemeal, by either with the drill, kerrison or chisels. And also you can use, as we do in open up, good spine surgeon, he uses his big chisels and give two cuts, one on the lamina, one on the pars. Entire your facet lamina, partial pars is out in one go. So the same thing can be done endoscopically. Then we just devise this easy, how to do it easily. So what you want to remove, the entire area need to be cleared for a good T-leaf. So how it is done? So the first is you remove the pars, lamina and entire inferior facet. Once you remove that, you have a superior facet there, and you try to chop off the tip of superior facet, what we call decapitate it. So you get an entire corridor from pedicle to pedicle freed there. So this is ideal T-leaf, any one of us want to do it, which can be removed as an end block in this technique. So once you remove this end block, definitely you will get 7 to 8 cc of the graft very easily. When you remove the end block and also a superior articular facet tip, you get 8 cc easily. So the landing, which will be shown in the video later. So this is just a short video how it should be done. So doing from the left side here, just removing the landing is always little bit cranial. I'll just show you what are the landmarks in the video. So you can see that is a laminospinous junction. He was telling the point Max was telling. So I'm just decorticating the spinolaminar junction there. That's one. Then I'll demonstrate the upper end of the lamina, the upper margin of the upper lamina. So I'm just demonstrating the upper margin. So leaving a cuff of bone there, I will just decorticate the lamina there. This is to give a laminar cut. So I'm just did a, then this is the pars. So you can see pars is very compact and pale bone. Now I am decorticating the pars. So 3 decortication is necessary, one in the lamina, one in the laminospinous junction, and one is on the pars. Once you do this, you can see entire bone I can remove. Now I use a chisel there, use a chisel which is custom made 4 mm chisel designed by Mahesha with Hebbar surgicals. So we use these chisels. I just need not go through and through. It's just you might have seen stone workers. They don't do through and through. You can just go 1/3 or 2/3. Only pars you need to go because pars is a tough bone. So I go pars through and through, taking the lateral X-rays in between. So you can just take a shoots in between, and once pars breaks, entire bone breaks because you have done already a partial chiseling there. So once you go deep, take a C-arm shoot, you are very safe here. So no problem, you will not injure any root. So because still a bone cuff is preserving the exiting. So you can see there, that's the epidural vessel seen. So entire the bone now is mobile. Just use curette, just gently lift it. Once you lift it, sometimes your ligament is very thick, it is stuck to the ligament. You can use curette to separate it. Now come to the facet joint area which you have already freed. So just lift it from this side. The entire things gets lifted. So this is how it should be done, which will be shown in the video. Once it is done, so you can just use it as a graft and do a fusion. So a few examples already Dr. Abhinandan showed this case in the morning. So when you have such cases, it can be done. I was asking in the morning, when you have a bilateral stenosis, such case, such cases can be done in decompression bilaterally and do very good. You get a graft. You can even remove the chop of the opposite facet also through using chisels and drill. So you can even go with use expandable cages also, which Dr. Kulkarni sir was talking about. Any kind of case which you tend to do it with open surgery or MIS can be easily done with various advantages. So you are looking at the end plate preparation, you are very well confirmed end plate preparation. Definitely this take little bit longer time when compared to transcambion, but it has its own advantage. When you have a global stenosis, definitely it should be done. So these are the advantages. So just these slides were to just make you what that video we want to, what we have done the live surgery, to just we want to show that. So we'll start the case. The next case would be the Mahesha's fusion, the transcambion. So this patient painted, draped under GA. Audio లేదా? Audio రావట్లేదు. Or MIS T-lift or endoscopic T-lift. Endoscopy, again, there are two options here. Either go transcambion approach or posterior. Just go back. On lateral image, there is a grade 1 listhesis. So it's a degenerative listhesis, which is not that much reducing on flexion extension. So MRI, you can see here, there is a multi-level degenerative disease, but more on the L3-4, where patient has more foraminal stenosis on the left side with facet hypertrophy, leading to more of left side symptoms. So again, here the plan is Varun might do a transcambion approach. So patient in this case were very obese, VIP patient, and as I said, I do only in general anesthesia. So my choice was posterior approach in this patient. But you can do a very well transcranial approach, doing a good drilling of the facet, knocking off the foramen, do a foraminoplasty before putting a cage there. So that can be done easily. But here for the demonstration, we are showing the posterior approach here. Stenosis, that can also be dealt when you go posteriorly. That is the biggest advantage of posterior approach over transcranial approach. Once you do this, then we'll remove the disc and go inside and put a cage. In sagittal, you can see the multi-level again degenerative disc disease, of which patient has more of a back pain with left side symptoms, and he is a 72-year-old male, so there is no need for aggressive work here. So just address this L3-4 level and the patient should be very happy here. So we are addressing only L3-4 symptoms here. So patient has already been prone. My colleagues have put opposite side screws and bit distracted. So we'll go for the endofusion now. So here now you can see the opposite side screws have been placed. This is the midline, this is the right side, this is the left side. Now we have to insert the cage from this side. The idea is where to land. So there is a landing is little bit different from stenosis. Normally in stenosis what we do, we land somewhere here and do a laminotomy and decompress the opposite side. But here we need to go to the space and also take out as much bone as possible. So what we do here is we land on the upper pedicle. So this is L3 pedicle, this is L4 pedicle. So you take a medial border of the pedicle like this and mark the inferior border of the pedicle. So somewhere it comes between the pedicle, the pars and the lamina. So all the three junction where they meet, that is the point of entry. So here the one change compared to our stenosis surgeries, the landing is much cranial. So the upper pedicle, where upper pedicle is there, the junction of lamina, upper pedicle and pars. So that is the entry point, more cranial, and you can say grossly the medial pedicular line. So why so lateral entry? Because you need to knock off the facet entirely. You need to see the isthmus of the pars. You need to see the entire lateral border of the facet joint. So this releasing of the soft tissues will ease you to remove the entire facet in one go. So that's why, and going to opposite side is never a problem because you are using an angled scope. Going the opposite side is always easy. Or the point of landing. So somewhere like this we land, somewhere like this. So that is the idea. So I am just landing, as I said, it's just more cranial. So that's where we land. Pedicle, pars and the lamina junction, that is where we want to. So again, to confirm that how you want to go about it, so you take a lateral image keeping there. So this might change with the patient lordosis and your positioning. So now you can see in lateral. So I am parallel to the, what I do here is I keep a dilator just on the surface of the skin. And just press it and take a lateral image. So here you are in line with the disc space. So that is the idea. You have to be in line so that end plate preparation is easy because you are doing with a monoportal technique here. So end plate preparation will be easy if you are parallel to the disc space. That's the important point here. Parallel to the disc space. So now I'll take this is our entry point, so I'll mark my entry point here. So now I'll take a adequate incision of 10 mm because you are using a bigger scope here. The scope we are using is a stenosis scope, working channel 5.5 mm. The outer diameter, the sheath diameter is 10 mm. Yeah, what happens is there is always a dermal ooze. When is a dermal loose, you get irritated, dilator, putting it. I don't like blood to touch my hands. So I always keep that field very clear. So that's why I just give a local there. This just for the dermal, there is no need to give there, but still. I'm taking a small 10 mm incision with a adequate facial. So what I am doing is, you see, I am giving a little bit bigger facial incision. The idea is when you are removing the facet, because you are removing almost 3 to 5 mm, 5 centimeter of bone as a one block. So if it has to come out during removal, you need to have a bigger facial. Skin can stretch, but fascia is more powerful. We can't pull it out easily. So I just give a bit of bigger facial incision, bigger than the skin. Incision. Should. So just lateral to the. Trick is here. You should be parallel to the disc space so that it is easy to insert the cage. Once you go there, identify the pars, identify the lamina, the upper lamina, entire upper lamina. And as I said, don't scrape with the cannula or the dilator. What happens, there will be a lot of bleeding as you do in UBE. Don't do that, because that will cause lot of bleeding. So just go in, coagulate and remove that small muscle layer. So unnecessarily no need to have a bleeding there. So just remove that small bit of muscle. You should identify the bone. Where is the bone? So because here we have on the left side, so what happens? 3 o'clock being cranial, 9 o'clock being caudal, 3 o'clock being caudal, 9 o'clock being cranial because of the left side. So this is cranial, that is 9 o'clock. This is caudal, that is 3 o'clock. So again, you get a lamina upper surface here. So here we need to worry about the upper surface more because we want more lamina. So first we will work cranially. Here already. So probably this is lamina. The moment you see this fat, you should be happy because you are in that periosteal layer, just extra periosteal layer. So just below, anterior to it will be the bone. So that's the bone I am seeing there. I just coagulate the muscle. So as a beginner, the doing a hemostasis is a challenge initially. So we need to learn how to do a proper hemostasis and what is that layer the blood vessels are situated. You see here the blood vessels are situated just beneath this this fat layer. So you should understand to coagulate those blood vessels. A lot of time is being wasted for this hemostasis to happen. So now I am just following the bone medially. So I want to just see the bone where it goes. So I am now following the bone medially now. So just so these are the bleeders. A beginner will always have irritation. We will learn how to do a proper hemostasis, how to identify the bleeders. So all the speakers will be talking about the tips and tricks to control the bleeding points. You can see when the scope is away, you don't see that bleeder point properly. So go just near to the bleeder and coagulate it. So there will be no too much of tissue damage, thermal injury to the muscle is not there. So try to go near the bleeder and coagulate it focally. So now you need to identify the structures. Where is the facet, where is the lamina, where is the interlaminar space. That is what we need to define now. So you are seeing this fat now. I'll just remove this fat so that for the sake of our visibility, I am removing the fat. I am removing the fat. Now you can see the entire lamina there. Now you see that's a lamina. I'll just show you the. Now I'm using a monopolar there, trying to clear the soft tissue. Entire lamina. So I'm just following the lamina cranially, because 9 o'clock being cranial, I'm just following this bone cranially. I'm just following this cranially till the upper space. That's a L1, L2 space. So I'm just following this lamina cranially, L2, L3 space. So I'm just following this cranially and laterally. So when you are going on the facet, that's a facet joint. Laterally. Just identify the bony landmarks first so that it is easy for you. I'm just going all around the facet there. So I know that's the facet. So because here the facet is too much hypertrophic, you can see the facet is too hypertrophic. I'll come inferiorly and laterally. So just this is the facet capsule. So I'm just going into the capsule now to find out the joint space. You can see I'm just entered the joint space there. See there, that's a joint capsule which have breached and have gone into the joint cavity. So that's a joint cavity which have gone, because here our intention is to remove the entire bone, as much bone as possible as one piece, so that we can get a more graft. We use a drill, you will lose the bone. You use a lot of piecemeal chiseling, there will be a lot of bleeding. So that's why you use a end block removal, it is more easy. So beginner need not always practice this. You can remove whatever way you want. Try to remove the bone. So here it just we are showing one method where it's helpful. Medially and inferiorly. So this is a place. This is the point. That's the inferior tip of the IAP. Is a point where the ligament adhesions are tough. So this is the place where you find difficulty lifting the bone. So this point need to be removed or made bare. The joint need to be exposed properly here, so that you can remove so that point. It's an inferior tip of IAP. So that tissue, if you can detach from the facet, that point. So see the tough attachments there, very thick attachments will be there. So you can use a monopolar or by your other thermal energy or cutting tools, we can just detach it till the joint deeper, so that it is easy to lift the bone. So I'm just going using the vision. I'm using the monopolar to go deep. So once I go there, so I've gone enough deep. The superficial layer has been breached, which is more tougher. The deeper layer is intact, so I can use a curate later. So now I'm just going cranially again at the lower part of the facet and the medial border of the facet. I just crossed from cranial, then went lateral, then again going into the interlaminar space. L3-4 interlaminar space. Because of the chronic stenosis, there will be a lot of Yeah, I know you've been complaining that maybe you have to buy a new monopolar machine. It is working. So we'll just sort it out. Recruitment of vessels inside the muscle also, because there was facet hypertrophy, facet inflammation. So there will be a lot of blood vessels all around the facet and the space. So and just clearing those small vessels here, that's a interlaminar space. If I remove the soft tissue there, you will see the medial border of the lamina.
That's the inferior border of the lamina. So that's a spino-laminar junction. So I have to clear this soft tissue to show you the lamina.
So you can use a bigger, thermal energy to shrink the muscle. You can remove the muscle using a plasma that is more faster. So, or here I am removing it physically. I am just removing the periosteum here so that our drill works better. There is no soft tissue coming in the drill. And for the sake of demonstration, I am making it much clearer. So that's the entire lamina from medial to lateral and the facet.
L3-4 space. So now I am just going cranially. So just to make sure that we can take out as adequate bone as possible cranially, as we do in any standard T-lift. So I am just going cranially and coming laterally to define the pars. So as I come subperiosteally, I am just coming subperiosteally here. Usually pars is a more compact bone, so you can see the bone as a very pale yellow
that's
bone.
the isthmus of the pars. Just lateral to the isthmus, you will get that radicular vessel. So you can coagulate, that's a vessel. So you can just see that's the isthmus. So I'm just clearing the soft tissue there.
So this is a pars bone. See, this is a pars.
So this is a point where Mahesha entered. That's the pars and the transverse process level where he cleared the soft tissue there. So deeper to it would be the exiting route. So that's what Mahesha worked yesterday. So that area.
This is the isthmus of the pars. So this is the isthmus of the pars.
So that's I'm just close to the bone I'm working.
So this is the isthmus of the pars.
So just
you follow
here
this
you
isthmus
just
of the pars
entire
into the joint. So this is the lateral border of the pars. That's the isthmus. So this is a joint, facet joint. So facet joint. So follow the facet joint. So what have we exposed here? The entire lamina, lower border, upper border, coming laterally the pars, and this is the facet.
So with just a monoportal technique, we have exposed the entire bone, entire half bone.
Facet joint. So that's a facet joint. So now you can see two bones. This is the inferior facet. This is the superior facet. This is the joint cartilage. Then just following this. So this cartilage is hypertrophied here. So just disconnecting this attachment so that the removal of this facet becomes very easy.
See the hand, my hand, how oblique it is, because we have entered laterally. So it's oblique.
Medial inferior border of the cartilage.
So now I'm using a curette. You see, I'm just separating the ligament, superficial layer of the ligament there.
So just strip off this attachment. You can see, strip off the attachment from the inferior facet. So this is a more toughest layer where the facet will not come out otherwise. This is an important step. I just detach the ligament from medial inferior from the bone. So now I'll orient you. So I'm here standing on the left side of the patient. So at 3-4, so I've landed on the 3 lamina, L3 lamina. So this is a lamino-spinous junction medially. This is inferior part of the lamina, that is L3 inferior part. This is L3 superior part. Come laterally. This is a pars. Then this is a facet, inferior or descending facet.
this is a joint. So we start chiseling out from here and entire lamina and the pars and take out this entire bone as one piece. So that is our goal. So I use a drill just to mark my chisel work. So I use a diamond drill. First I'll see my the hand there, how oblique it is. But when you are chiseling it, you need to make it straight. That very important step, otherwise you will go to the opposite side. If you chisel in the same direction, because I am using a 20-degree scope, you think you are straight, but you are very oblique. So when you are doing that, you need to see from outside how much oblique we are and make it straight. So that when we are chiseling out, I will just show you. Sometimes bone is very hard. Chisel might even get bent because we are using endoscopic chisels which are flimsy. So I am just now again putting this mark or decorticating on the lamina. A part of the bone can be left so that in future some redo surgery has to be done. You have a good anatomical landmarks left there. So that's coming laterally and cranially. That's the pars. So whenever come near the pars, take a shot, take a C-arm shoot. So that whether we
So when I come to the
exactly
pars, I take a shoot so that how cranial I have to go to be flush to the pedicle.
So flush to the border of the pedicle, we will. So can you see the X-ray image? Show the X-ray image. Show the X-ray image. Yeah, you can see that.
You see that
I am just flush to the.
You see that I am just flush to the pedicle there. So the pars is been drilled flush to the pedicle. So when we chisel it out, you need not again use kerrison to remove the remaining parts. So you can just have a very good
there. So that is very important. Otherwise you will damage the upper pedicle. So what I am doing is now, you can make the endoscopic image bigger. So now what I have done is, this is the pars. You can see how pars is a completely compact bone and see the lamina is a pink bone. So that's the toughest bone of the vertebra. Pars is very tough. So I'm just decorticating so that I can chisel it out nicely. So I just gave a cut on the pars, a cut on the lamina and laminospinous junction. So entire bone I can remove it as a one piece. So chisel, I'll take a chisel now. We have this custom made chisel. These chisels are designed by Mahesha.
So you can see my hand now. Just look my hand how I make it straight. Once it's entering the outer cortex. See how I'm making it my hand straight. The maneuver what we use during OLIF, the maneuver like J maneuver what we do. So same thing.
Just do a partial osteotomy first.
See there I am making it straight. Otherwise it will go to the opposite side.
One more trick is, you see my index, the ring finger, I am holding show my ring finger. So this ring finger, you can see, this ring finger I am holding it as a guide. So whenever my colleague is hitting, my ring finger will hold this tightly so that it should not plunge. It gives a counter force, it should not plunge. So that's how it works, so that we are safe. So I am not going through the entire thickness of the bone here. I'll just go through the partially. I'm just going partial thickness. Then I'll come here. I do on the lamina.
So I just done a partial laminar.
So you should train your assistant how hard you should hit.
Here,
So
not through and through.
My team is
Not
well trained now.
Through there.
So they know how to. It's just with some practice, you know how much.
Just a partial.
And anyways, I'm giving the counter force.
Because what I have made with the burr helps me to guide which way to go. So now this is a pars. So pars is the thickest and toughest bone here. So when you keep here, I'll keep it straight, shoot.
So I take a C-arm now. I know how depth I need to go.
I'm flush to the pedicle lower margin. Okay. So then make endoscopic image bigger. See here, my colleague gave a good cut here. Now the pars is broken here. Once pars is broken, you can see here pars is broken, the entire facet is moving now. So that's a thecal sac. That's the advantage of, can you see the thecal sac here? That's a thecal sac. So that's a thecal sac, epidural fat is nicely seen. So now, medially, all around now we have to just go and release this and lift the bone. Now use a curette. So if I come to the joint now, I'll just loosen it all around.
So just you hold the edge of the bone and you lift it. It gets detached from the ligament attachments. So
you can remove this piecemeal also. There is no rule that you should remove en bloc, but removing en bloc has its own advantages, where
so that's the tip of inferior facet. So I'm just lifting it out now because I gave a good cut here. So I can lift this bone easily. If I had not given a good cut, so lifting would have been difficult. You see now, the entire the facet got lifted up. So it's very easy.
Detach the soft tissue from the bone, and we can remove it as a one single piece. So I detached it entirely.
Now it's just floating now.
Just check deeper. So it has detached now. I'll use a tooth punch. I'll use a tooth punch. Once it comes into the subcutaneous plane, just in the last bit of one, so because it's a big bone, it's slipping. So now once in the subcutaneous plane, you hold with the artery forceps.
You just deliver it into the subcutaneous plane. You can use either cockers or a big artery forceps. Hold the bone and just remove it. So that is the advantage if you you have given a bigger cut.
You can see this bone scaling. So this much big bone I removed. You can see the bone, how much big I removed. The entire bone, it's almost 3.5 centimeter bone. So that's by almost 2.5 centimeters. So this much big bone I have removed. This is the inferior facet, lamina and the pars. So entire facet, lamina, partial lamina and the pars has been removed. So this is a very good graft for us. Now we'll go inside and remove the tip of superior articular facet as we remove in our
open surgery or any T-lip surgery. So here, the challenge in this case was there were a lot of additions because of the chronic disease. The traversing route was entirely adherent to the annulus. So removal of the superior articular facet tip. So that's the thecal sac. So now you orient yourself cranially. You have cut flush to the pars. So the caudally there will be tip of SAP, and already you can see some canal opened up there, and the ligament, the left out ligament there, and thecal sac. So I'm just doing some hemostasis. Here because there is a foramen stenosis here, as we saw in MRI. So we need to do a good foraminal decompression. So now we need to identify the superior articular facet. I'm just removing that small piece of bone which when we were chiseling got sliced so that part of bone I am removing, and that helps in our foraminal decompression as well. So just remove that piece which I am trying to remove, then we'll address the superior articular facet. So this is a flush to the pedicle. We are removing the bone here. So now that's a superior articular facet. See the SAP here. So this is a superior articular facet here. We will cut this superior articular facet. So we can remove this superior articular facet. This is a superior articular facet. We can use chisel or the kerrison. If it's not that bulky, you can use a kerrison nicely. So I'm using a kerrison so that I can have a more graft. You can use chisel also here. If you want, you can chop it off. The advantage of this technique is you are doing a foramen decompression, you are doing a lateral recess decompression. If you want, you can go over the top and do a opposite side decompression. So this here, if you have adequate graft, you can use drill also so that your things. What I am trying to do is here the space I want to create for the cage to go inside. So I am chopping off the superior articular facet. This is a facet hypertrophy which overhangs. You can see that's the superior facet hypertrophy which was externally causing this will hinder your cage entry sometimes because it's too hypertrophied. The cage goes medially and it goes to the opposite side. So you want to have a good cage position. These osteophytes or hypertrophy need to be flattened so that your cage trajectory is easy. And just drilling this bone, making this flat, the overgrown part. So why I am trying to clear this inflamed tissue is so that one is the vision is better, your understanding is better here, monochrome. So I'll just expose the entire superior facet, that is a ascending facet for you. That's the joint surface which was inflamed. You can see the cartilage, inflamed cartilage. That's the joint tissue. That's a synovium. So that's entire which was inflamed. That's the inferior lamina. Lower lamina. So that's the lower lamina. I'll just show you. So because if you want to do a good stenosis decompression, you have to do this work. For the sake of demonstration, I am doing this. So now, so that's the lower lamina. It's the lower lamina. Laminofacetal, that is lamino superior facet or ascending facet junction. We come there cranially. This is a tip where we have removed a bit of bone. So all we need to do is remove tip and the medial part of the facet. So I'll just remove this medial part.
So again, it depends upon case to case whether you need to remove this or not.
And space for the cage insertion. So I'm just removing a piecemeal removal of the facet here.
So we are doing the same what we do in an open standard T-leaf. So till this point, any doubts
here one
you can
point
ask.
don't try to remove too much superior facet so that your inferior pedicle is compromised. So always take care not to remove too much. A good foraminotomy has to be done, but at the same time try to prevent the. So that's a medial border and this is apex. So I just create more space for the cage to go inside. So I just remove this. This helps in good lateral recess decompression. So I am just removing the superior facet medial border here. This is the medial border. I'm just still keeping the ligament intact so that if at all I have to use a drill, I can use it better. And just taking out. So this is a biggest advantage is that you get so much bone here. So if a patient has a big space or you need to pack the graft, so this technique will help you to, as a result of which we have seen good fusions with this technique and compared to the other techniques.
And to our own surprise, our fusion rates are much better when compared to the synthetic graft what we were using in transforaminal. And our fusions are better than transcambian approach, so it is taking shorter time. So we are coming up with our own prospective study about the timing of fusion. So I'm just lifting off that entire bone. To our surprise, here in this case, a lot of additions. Yesterday someone was asking about can you do a redo surgery or do when additions are there. Dr. Kulkarni sir, I think you were asking this question. What if there are additions, can you release them when with endoscope? So endoscope gives a very big advantage because of the saline. You can see with the curate, I am just gently caressing out the addition. The saline helps us the vision and gives us the plane. So that's the thecal sac plane. A lot of additions. Usually this much of additions are not there in the lateral recess. There's a good plane between the ligamentum flavum and the root normally. So here there are a lot of additions where I have to use a fine dissection to expose because there was a foraminal foraminal pathology. You can see that initially what we thought as a root was a addition band over the root. So this entire thing was a addition, the soft tissue. Then I have to use a cutter to cut that, separate it from the root. So that entire thing is a adhesive band. So that's a plane. So this plane can be seen better only in endoscopy. So other techniques, you have a bloody field, you can't appreciate the layer. So now I'll try to cut this.
Cut this thick fibrous band here.
See how I am cutting. I will cut. I lift. Thecal sac is not lifting. Then I cut. So I'll hold. I lift. Thecal sac is not lifting. I cut. So the additions release is very important, otherwise they becomes more fibrous and cause again the long-term symptoms. So there was thick addition, so I just spent some 10-15 minutes on this so that I can do a better visualization is also key. What are we doing there? So I just removed this further. Though in this case it was not necessary, the stenosis was only foraminal, but I wanted a clear picture there. I wanted to see what we are doing. We should have absolute control. So I just removed this ligamentum flavum on the root so that to have a good visualization of the entire root. So just detach it inferiorly so that I can have a root seen there clearly. Then I can come up and clear all the addition. So that's the inferior lamina detachment there of the ligamentum flavum. So once I did this, so I have a very good picturization of what is that I am dealing with. So now I have a very good visualization of the normal theca there. So there is no need to go to the opposite side. So now you see a good fat is seen there in the midline. So that's a midline. So even you are dealing with a redo surgery, it will be like this. So still you can do this in even a redo surgery patient. So even you have done a previous open surgery, you can create this plane. Failed to decompress the good lateral recess, the entire traversing root stretch. We could have failed to decompress. See, so much of additions are there. That's a foraminal disc which was coming out. Now I'm just peeling out the. That's the root. That's the root. So that's a addition for need to be released. So now I know where is the root. So that's the root. So that's the addition. So that's a big adhesive band, and I can see the fat there. So once you see the fat, you know that where is the root. So I can cut this easily. So I can cut here. Small cutter. So I'll use a cutter here to cut this band safely. That's the exiting root there. I'll show you the exiting root up. So thick fibrous band has formed between the exiting root and the traversing root here because of the chronic stenosis. The biggest advantage is the exiting root can be made bare from starting origin from the exit extraforaminal area. You can decompress the exiting root very nicely because you have removed the entire pars. So you can decompress the exiting root very well here without any much bleeding. So once you remove that fibrous tissue, that entire thing is the exiting root. So just removing that fibrous band. So once you remove that, the entire thing is the exiting root. So that's the exiting root. So that's the entire exiting root freed now. So this fibrous tissue removal is very important even if you do foraminal. If you can remove such additions, the patient will not have a failed back syndrome. So just decompress the entire exiting root there, that's the exiting root. So now we can just go to the traversing root now, that's the exiting root. The upper border also is seen nicely, the fat is seen nicely there. That is the exiting root, that's the exiting root. So that's the upper border of the exiting root. That's the entire stretch is fibrous tissue in the foramen. I'm trying to remove the extraforaminal tissue there. So that's the exiting root. That's the exiting root. Pedicle is seen above, pedicle nicely seen above. So you can just leave it there, then come down and cut this and start putting the cage. So entire exiting root is freed there. So much additions were there in this case. So these finer details are not possible if you don't do a direct decompression. Some cases we might get away, but when you have a severe adhesions, fibrosis like this, patient continues to have radiculopathy and MRI looks normal. So the MRI doesn't give a picture on this adhesion. So just cleared the adhesions till the fat is seen.
Nicely seen there
So
now.
till the fat is seen, I remove the fibrous bands.
So again I cut this fibrous band.
So now I can cut confidently because it's just a addition. That's a disc.
So that's the axillary fat. That's the fat between the exiting and the traversing route. That's a fat. So that's a plane actually. So all things are the additions. Better. Small additions between the root and the so just release all the additions now.
So this you need some patience because you don't want to have a thick, this adhesion become more fibrous and it forms a cake around the nerve and it will give you more trouble. So I'm just trying to decompress this before we, so the vision gives you such a vision and the saline gives you such a beautiful plane. You can see that's a plane, that's now once you, that's a normal looking now there. So I just remove that.
So you can see the fat now.
Now the fat is
that's
seen.
a plane.
Once the fat is seen, now you see that's a now there.
So that's the entire route for you now. See
now
that
root is entirely free now of that fibrous band. So this release was very important in this patient. Otherwise, you would have had
the root would have been still constricted with that band. Better. So because of this chronic inflammation, patient had this. So this is very important. Putting a case is easy, but patient continues to have the radiculopathy. So then we can't explain him that we have done a good job, but still patient have a problem. RF.
So now we have done a
now good epidural space,
good decompression there,
free
beyond until the pedicle.
Entering into the foramen here,
so
a good fat seen. So coming cranially, so that's the exiting route, fat seen nicely, that's the exiting route. So that's the exiting route.
So now you have the entire corridor opened up.
Decompressed nicely.
Put a cage. Once I
entire exiting route and the traversing route and the disc is entirely decompressed now. And just doing a extra foraminal.
So till this point, if you have any doubt, you can ask.
Not cause again some stenosis or fibrosis.
So big boss is on time now. So remove the expo. There was a lot of additions on the traversing road. So just release the traversing road. The old man with the chronic stenosis.
small.
Because I am using
So
a
now I just
visualized
go to the
cage
exiting
incision,
root so that
so
release
exposing
the
the lateral
small
border of
band,
the root is
constriction band
important
there.
because we are using a retractor to and doing it in visualized fashion. So
that's
yeah. So my
3 root. That's the exiting route.
I do not expose the exiting route routinely. I will do it if somebody wants to see it, number one. Number two, if there is a existing foraminal stenosis which is not relieved by distraction, then I may do it.
Yeah.
And number three, I generally take out the entire lamina as Sukumar does. I always keep some bone cranially for any problems in future. So, because when you keep some bone, you don't have to expose it, because to expose the root, you have to go a little bit under the pars and take out some bone.
So what I have done is I just rotated the same cannula I was using because we have removed the facet. So there is no need for retraction, just it acts as a protectant. Now you can go into the disc and start. Here I use the regular shavers, what we use for any spine open surgery. The same shavers I use. So once I just clear this debris and do some debulking, then I put a shaver inside. You can use a shaver, you can use whatever you want, curette, whatever tools available. The biggest advantage of transforaminal over this is the end plate preparation is better here, faster here, because you are using all the curettes and all bigger ones. The transforaminal has evolved because even now in transforaminal you get a good end plate shavers, both local and international, expandable shavers, debriders, mechanical debriders. So whatever tools are available, it is only to decrease the time. So now I can go inside.
Shaver now around size number 8.
So now you see what I am doing is I removed my sheath is protecting. Sheath is protecting. I put a regular shaver. So I am using a regular T-lift shaver. Here I am putting number 8 here.
You can see there.
So my sheath is protecting the root, so I need not worry.
Do a C-arm picture in picture.
This will also give you the rough size of the.
I'll use a number 9 now.
So we have custom made so the T handle helps us which way the shaver is. It is very easy to understand. It's very simple.
You can see now C-arm image bigger.
So that's a 9 mm which is.
You can see I'm just using a regular shavers protecting the root with my sheath and just using.
Being an elderly man, I am not aggressive on the end plates here.
End plate.
But what you do if you have
a scope,
wider space?
Make endoscopic image.
I use through this sheath.
That will take up to
10. I have a bigger sheath. So otherwise, I use my cage insertion port. That's a screw port. And put a even 12 or 13 mm and do it. So still we are seeing through the scope. So that's one advantage.
Whether they are completely prepared or not, you can see the.
So here
entirely.
As Varun was telling, once you feel that grating sensation, most of the time we think we have done a good job. But sometimes even good grating sensation do leave some end plate on the end plate cartilage is still there.
There will be some tissue inside.
We can clear that so that have a still better fusion. So we can scrape off. So now you see that the distally there still more anteriorly you can see the. So what I use a chisel here, nicely the curved chisel designed by Mahesha, as I said before. I just you can see what I am doing is I am removing the distal end plate cartilage nicely. You can just here we saw the MRI, it was collapsed disc. So Abhinandan has placed the screws on the opposite side and he has done a gentle distraction so that I get some space to work in. Otherwise it was just a 2-3 mm space. So now we have got some 6-7 mm space. Through that we have put a shavers and just, now this chisel is my workhorse when I want to do the anterior removal of this end plate, cartilage. It works very, very well. So you can just shave off this end plate. And I can go till the anterior annulus. I can just go as anterior annulus. As Mahesha told, anterior preparation is very important. So go to the anterior annular fibers, scrape off the entire end plate. So, and see the anterior annular fibers. Then you are very sure that, or you can take a radiological shoot there. So you see that now you can see the anterior annular fiber start seeing there. Good bleeding is happening. It's good for the patient. So once you remove that, this is only to accommodate the good graft as anterior as possible. So that's anterior annulus we are seeing there. This takes 10 to 12 minutes of your time. We have not edited anything here, so it just took us entire thing 15 minutes of end plate preparation. So this is okay. So that's anterior
or biportal. Only endoscopy can let you know that you have done a good end plate preparation. That's the anterior annulus you are seeing now. That's the anterior annulus. So we'll take a shoot here and see.
So I'm just taking a shoot.
So actually the orientation of fibers is different and it is very classical that you can make out endoscopically that you reach the anterior annulus.
You can see there just gone anterior annulus. I am touching there and I just
when you want a good fusion, you want a good anterior fusion.
So I just scrape off the ligament there. You can just see the scraping of the ligament anteriorly. So just edge of the, till the edge I am scraping off. So this has given us very good results. So anterior work, good anterior work, placement of cage as anterior as possible has given us a very good result. And biggest advantage is you can put a bigger cage in this approach. As we were discussing yesterday, the transforaminal approach, when we put size of more than 10 to 11, the paresthesias are little bit high. So we have done a good preparation now. Now see what I am doing. See my scope. I take a suction now and just suck out the saline.
So just sucked out the saline. Now I'll use a funnel to pack the graft. So I'm using a funnel now. Shoot.
So I'm using a regular T-leaf graft funnel.
Shoot. Make the CM image so that they can see the graft. So now you can see the graft here in the.
That's the autograph.
You can see the graft. Nice graft has been done. My colleague has prepared a nice graft now. So I'm packing the graft anteriorly. So around 5 cc of the graft has been packed. Now I'll just tap it. Shoot.
See, I'm going as
Being
anterior
a
as
elderly
possible,
man, I
putting the
don't
graft.
want to too much distract or too much damage also should. So I pack the graft anteriorly as possible. Then what I do now is I remove the sheath. Now my colleague will have to place screws on the opposite side. Has placed the screws already on the opposite side. He has to place the screws on the ipsilateral side. So I'll take a AP. So where my colleague will take a pedicle screw entry should there I'm just marking where he might enter with a screw.
So Dr.
pedicle
Abhinandan
screw.
usually
There
takes
I'll just
a extreme lateral approach. He does a lateral screw entry. He's little bit lateral than conventional. So that is for my advantage. So I take this incision. You can see I mark that screw entry line. So if you, I pause here. So there are two ways of inserting the cage now. So once you can go through the same opening and just make it little bit oblique and insert the cage, or you come more laterally as we do in MIS T-lift or any other T-lift to come laterally and put the cage. So the only advantage of this approach is your obliquity of the cage is better and the chance of retracting the root is very less. So just it is visualized, that's it. So there is nothing.
Pedicle screw entry. So at that level, the upper.
That's the upper pedicle screw entry.
Level.
So I'll just give a local there. Again, what I said, I don't want a bleed.
Where my colleague will take a entry for the screw insertion. So there, I give an incision. I just do a fasciotomy. Now, through that. So just to make sure, there are two incisions now. Okay, even it is dilators, first dilator. There are two incisions now. You can see the two incisions now. One is the scope. The second one is the incision, which is at the level of the sheath, the scope entry, where the pedicle screw enters like this. So that I use as a cage entry port now. So I put a cage here, my screw goes here, my scope goes here. So I'll just again put the scope.
This is just to add the angle. So now I just put a scope, clear the clots and any bone graft has come out a bit. I'll just clear those things.
The graft is filled with along with the clot, which I wanted. So I'm happy that it is already clotted. We just gave 3-4 minutes so that the entire area is clotted. So that's a good thing, so that we have a blood mixed graft which will heal, which will cause fusion faster. So you can see the graft which is packed there.
That's a graft packed with, there's a blood already clotted there, that's the lateral edge of the root. Now we have very good opening lateral to the root where the cage can go inside without too much of traction on the nerve. So that's a big advantage. There is no traction on the nerve here. Remove the clot. This is to just increase the visibility. The floating clots will obscure your vision and creates a lot of confusion.
So now with the screw entry, we are using it as a one more channel to push the cage. So now you can see this is the root, this is a disc space. Now I'll.
Now what I am trying to do is put a dilators. What we regularly use for dilators for.
I am using a dilator. Can you see the dilator here? The dilator is just going in. The purpose of using a dilator is it will just dilate the tract, muscle tract, so that cage goes in easily. So that's why we are using this.
So I don't want to injure the muscle here. So I am just using a dilators to create a tract.
So we'll use a.
So just put a dilators. So to a small trick, you see, I am just cranial caudal motion that will just open up the muzzle, and I just remove that. Now I am ready to insert the cage. So I am inserting a 11 mm cage here because 9 mm shaver was going snugly. I just 2 mm extra. I am just using it as a. So I am just, you see the direction. I am just pushing it with gentle rocking movement, no trauma because we have done a. So just I am inserting. The big advantage is that once it goes inside, you see there, it stops because I know the root is there. Cage has come inside, you see there. So my assistant now helps me retracting the root. That's the root. So this is what we were discussing. So see, I can, without a traction, I can just go in easily. But
directly bang the cage now. But to be more safer side, that's the advantage of this technique. Hold. Now I am using a dissector or any.
So I am using a dissector or any instrument to just retract the root, and my assistant is holding the root, and I just push the. See, there is no traction or anything, and you are 100% sure that you are not injuring the now. You are 100% visualized, and my assistant is ready to hit it. So Dr. Harshit is helping me here.
The cage nicely going in. Cage is nicely going in.
So all the time you are seeing what you are pushing in. So the
now
cage
what we can do is,
the moment the cage has gone inside, you know that it is underneath the root, the anterior to the root. Just remove everything and stop. Start hitting the cage further in blindly. What I am doing it here is opposite. Dr. Abhinandan had little bit distracted it. I am again loosening the screw there, the ini there, so that it can become a little bit lordotic. Cage goes anteriorly, it can become more lordotic. Now I am hitting it further inside.
Because I have gone in, now I need not worry. My entire cage is gone inside, so I need not worry. So I remove this. There is no need for seeing me now. Just I'll go in, shoot. So now I'll just remove the entire thing. हाथ निकाल दे, ये हाथ दोनों.
You see now what I am doing. I am now trying to adjust the direction. Just hitting now. So that's the direction. It's like a same as tea leaf direction. See the angle. We getting a good angle, and it has gone. Cage has gone as anteriorly as possible. Mahesha was telling, and again my assistant tightens the screw head.
Tighten the screw again. Now we'll take a AP.
So no one
can see that.
So that AP, you see that it's nicely sitting there. So I think then we put the opposite side screw and come out. So what have we achieved here? A good decompression. If opposite side it was there, you could have done it. Good foraminal decompression. Got a good autograft, and we have achieved a good placement of the cage without any tension of injuring the traversing root.
So I just removed it. Now we'll take a shoot.
And see, there is no blood coming out from the wound.
Now we'll go inside again.
Just to make sure that you have not injured the root, just go in. It takes 30 seconds to you, and just go in and see whether you have injured anything. You are dead sure that you are not injured now.
So why we have put a scope here is sometimes graft gets dislodged. So just you're not being very careful, you might injure the root. So just check whether any mishaps have happened. So make sure that you're not done anything there. So you can see that even you not disturbed the vasa nervosum here, there is no petechial hemorrhages on the nerve, it means that you have not disturbed the thecal sac at all. You have not retracted the thecal sac at all. Here, too much punch. So this way patient will not complain of any leg pain post-op. So often we see patient complaints of post-op leg pain, that might be because of the traction. Here there is no leg pain if you do this way, and exiting route is way away from your the cage entry. So that's a big advantage, and we have done here, and we can just put the screws on the opposite side, and we have done here. So thank you very much. So this is the way it should be done. What we do, we have termed it as A-surf technique, so which we have submitted for the publication. So we have done around 109 cases till now through this technique. Day by day we are improving our time, our efficiency is increasing, the post-op results, especially the fusion rates, are much better comparing all the techniques, the transforaminal, interlaminar, the posterior approach using graft, autograft, allograft and synthetic graft. We are finding this technique to be much better. You see there 11 mm cage sitting anteriorly with a good traversing route, decompressed, and they are coming out. So that's the end point. So that's the end point. So that's what we wanted. And a good anterior placement of the cage and good reduction of the listhesis, which was not reducing previously. Thank you very much. So the time. If you are not hungry, what we can do is Mahesha will be showing the transforaminal approach, which is around half an hour. So we will continue this so that this flow continues and madness continues till lunch. So sleep. So people who are interested in thoracic, it's a thoracic decompression is there. That is around 45 minutes, so that before you leave to airport, you can go with the good memories from Spinoscope-2024. Questions here, I'll just, before I start that, you can ask some questions. I know there will be a lot of questions. Please, it might be silly, but please ask us, so that so many seniors are there, so they can also help you out with the answers.
So Sukumar has lot of assistants, so he can ask somebody to retract, so he can ask somebody to put screws. But unfortunately, I don't have all these luxuries. So I do little different techniques.
Hello.
So
yeah. What are the complication rate in your 109 cases?
As I said, one cage got backed out, though we placed 12 mm cage, I think 11 or 12 mm, adequately sized cage, but reason unknown, there was a lot of granulation between the cage and the end plate when we went in again. But we removed the cage easily, it was easily retrievable because there was no additions. Except one, that case, we don't had any neuropraxias which usually we see in transcambion. There will be transient neuropraxia, sometime we'll have a transient weakness which might be there for weeks, and severe paresthesias. If you do L4-5, some patients tell tremendous paresthesias in the anterior thigh post-op in transcambion approach, which we thought this approach had a very good result. Two of our patients, very obese patients, one patient, Somalia patient, and one Indian patient, they were hyper obese. Those two patients had the wound collection, the screw site wound collection in one patient, and wound infection in one patient. It's a surgical site infection, so which we treated conservatively. So these were the simple complications, but never a root injury or root complication, because all the time you are seeing. One case we had a severe stenosis, we were trying to do opposite decompression. There was a small durotomy, but arachnoid was intact, so we did just kept a Duragen Plus in the last. So these are the things. Anything else, Abhinandan, you remember?
Rajendra, Tulsi, anything else, Harshit? So overall, because it's an interlaminar approach, you see the nerve first, so it's always under control. So that's the biggest advantage we saw. Yeah.
So Kumar, excellent video, so demonstration. So the thing is, I just want to ask, do you regularly size the cage?
Yeah,
you
so
use the
we
sizes,
do have the
or you
same
do eyeballing?
No. So there are two things. The moment you see the shavers you are using, you get a rough estimate whether which size is appropriate. If you want to exactly look for the appropriate size, you can use the sizers which we use for any MIS or open T-lift. You can use it. So you want to use that, you can use the screw port. You make it initially itself, and you can use that port for the sizing. So you can do that.
My next question is, how many percentage of, do you at all have patients where there is contralateral leg pain after post-operative or dysesthesia? Do you check the opposite side root as well after at the
MRI is the key. If you have MRI, any stenosis or subarticular stenosis or hypertrophy, we always do over-the-top decompression. It takes 5 to 10 minutes. Opposite decompression is very easy and fast.
So you routinely check the opposite root after the T-lift?
Always. So you need to spend 10 minutes extra. So you should not repent after surgery. So always, if you think just 2-3 upcuts on the opposite side, you are doing the good decompression.
So that question is a very silly question. Do you put a drain here? I didn't see drain here. So it's not needed.
As we were discussing yesterday, luckily professor is not there, so I don't put the drain. So Koreans and Taiwan people, they usually put drains. Even in Japan, they usually put drains, even for stenosis. But of late Taiwan, they use lot of flow seal before coming out. But as I said, when I was removing the sheath out intermittently, there was no blood coming out.
So you visualize the entire
So you
depth.
do a proper hemostasis, usually 99% no blood. One case extra, the complication which a patient, we operated a protein S deficiency patient, young girl. So she had a multiple histories of surgeries and post-op hematomas. So we took all the precautions with a good coagulation profile match and kept all the FFPs ready. We transfused everything, but still that patient had a post-op hematoma at the just on the epidural area. So post surgery she had severe pain, not weakness, pain. So we went on the next day itself, again removed and it was already clotted. So all we went there, just remove that clot. Again, no drain. We just came out. So
I have one more question to Dr. Mahisha and you. For seropositive patients, HIV and HBsAg positive patients, do you do, because the saline is continuously flowing, so are you doing this sort of fusions?
Yeah, that's a tricky question. It's up to you whether you want to take that risk or not. Yes, there is a increased risk of you getting wet. So proper draping and taking proper precautions. You do universal precautions in HBsAg, HCV or HIV patients. You put proper gear. I think even saline falls on your feet, nothing happens. What do you say, Mahesh?
We cannot refuse a case because he is having some issue.
Yeah, because of the saline.
In fact, I remember one patient. This patient was a foreign patient. He was HBsAg positive. See, HBsAg is not that risky.
Yes.
It is the HCV which is more dangerous, or HIV.
HIV.
So HBsAg we operated. We never bothered much because it's just HBsAg. He must have had infection somewhere, sometime. It's not symptomatic. Everything is LFT is normal. Everything is all right. So after surgery, before discharge, this patient party was very agitated. So you did not tell us that he is HBsAg positive. So I told him it has nothing to do. Why are you bothered? What is your botheration? Whether it's HBsAg positive or not. So some strange things like this also can happen.
Is there any chances of conversion from endo to open?
Till now, no, touchwood,
No.
never did that.
Never did.
So we'll go to the next case, Mahesha.
Sir, can we put a bigger sleeve, retracting the traversing nerve root means by the bevel of it, and then remove the scope and put a cage?
Yeah, so that Mahesha practices, that's what, that's what I showed. You go through the same incision. So what happens is the cage, you should be smart enough to medialize it properly. Otherwise it goes straight and it becomes like a pliff cage. So you need to be very smart to...
Actually, when we put the cage, we pack the graft like Philip.
Yeah.
When I put the cage, I tilt the angle so that it goes...
So there you just, your sheath slips, you are not a good, you don't have that habit of protecting the root, then you might have an injury because you are banging it blind. So that's the only risk. Otherwise, yes, Mahesha is...
I have done many cases, with the uniportal technique. It is a truly uniportal technique.
Yeah.
The same place where you put the scope, same port I put the cage also.
Yeah.
And I had one back out of cage because of improper cage, which I revised through the same port. No open surgery.
So which size of sleeve you put means that will be...
We have 10 and 12 mm size half sleeves, not full sleeve, half sleeves. So as long as your sleeve is inside the disc, be assured that your dura is protected. Unless this sleeve comes off, nothing will happen to the dura.
So
100%.
As a beginner, you should be seeing 10 things there. Everything you should be focused that your sleeve is adequately, snugly sitting there.
So sleeve has to be
inside the disc, yeah. Okay. So we'll go to the next case. Mahesha will be showing the transcambian approach, what Varun showed in the morning. So, voice pinch.
Presented with the chronic back pain and bilateral sciatica. This is the MRI scan. If you see here, this is the foraminal level, sagittal section. There is listhesis of L5 over S1. You can see the pars defect here, causing this defect and causing the listhesis. And there is severe compression of the exiting root at the foramen because of the listhesis. This is the same thing on the other side. You can see the foraminal disc with the lysis causing listhesis. So coming to axial section, so this is at L5S1 level. This is the foramen. You can see there is osteophyte causing severe complete blocking of the foramen, more on the right side, less on the left side. The central canal is okay. So can we see the X-rays? Pause. So we have AP lateral and flexion extension X-rays. So if you see the X-rays, there is significant osteopenia. So when we reduce it, we have to be careful. And the disc is completely collapsed. The disc space is hardly there. And if you see the flexion X-rays, it is mobile. So generally these kind of lytic listhesis you can reduce without much trouble. But we have to be careful with the screws, because if the screws give way, then you will not be able to reduce it. So the plan is to reduce this first and then do a transcambian fusion. This is an ideal case for transcambian fusion because there is no central canal stenosis. So we don't have to resect the facet or the lamina. We can just do a transcambian cage after reduction. So this is much less invasive and much faster than your interlaminar full endoscopic fusion.
So, Mahesha, according to you, this transcambian is easier than posterior approach?
Yes.
So, for a beginner, which is more safer, posterior approach or transcambian approach?
For a beginner, if he is experienced in transforaminal approach, then transcambian approach is much easier, faster and better.
Okay.
Only issue with transcambian approach is, number one, if the iliac crest is high, then he may face difficulty, especially at L5S1. Here, because it is a female patient and crest is not high, we can get away with the transcambian approach, number one. Number two, if the disc is well preserved, disc height is more than 11 or 12 or 13 mm, then putting a transcambian cage, the regular endo cage will be a little risky because you can end up with the post-operative dysesthesia of the exiting route, which may cause troublesome burning pain for a couple of months. So in those cases, it is better to go either with the interlaminar approach, or you can still go with transcranial approach if you have an expandable cage. But expandable cage is quite expensive.
Okay, so what Mahesh
and third point is you cannot use transcranial approach if you have a severe central canal stenosis.
So plus points of transcranial is it is facet sparing, it is least invasive, and easily it can be done till say disc height is 10 to 11 mm. It can be done. So for a beginner there is no need to worry about the disc space, the roots, thecal sac. So here you can directly go there and do your work and come out and still have a very good reduction and fusion. Minus points are, like as Mahesha said, you want to put a bigger cage or bigger space is there, it becomes difficult. Canal stenosis is there, it becomes difficult. Though sometimes if you have only a lateral recess stenosis, you can do a facet resection and do a lateral recess decompression and do a cage insertion. We do that, but when you learn both, it is easy. You can take your own choices depending upon the patient stature, patient physique, the iliac crest, so many things. So I think this is the best approach. I love this approach, and Mahesha modified this approach and developed so many instruments. So in this conference, we are trying to show all the techniques. So the previous video you saw the interlaminar approach, removing the en bloc facet. Here you are seeing the magic of transcranial approach, how Mahesha does it. So we will already, our colleagues have put the screws and reduced. Abhinandan Reddy has already done excellent reduction, made Mahesha's life easier. X-ray.
Yeah, he has done a very good reduction.
Can you show the X-ray? Yeah, the X-rays, you can see the X-rays. Mahesha is the Dr. Abhinandan and is Dr. Rajendra Reddy has reduced. You see here what the morning Dr. Abhinandan was telling about. When you are dealing with a osteoporotic patient, try to take as anterior purchase as possible. The anterior, he has taken till the sacral promontory in the AP, you see there. So he has done a very good bicortical purchase here, so that when he is using the force, the screw doesn't back out. So and the medialized screws also will give you the more strength for back out. So this is how it should be done, so to prevent implant failure. Space, and it is perfect for the Mahesha to go in and do his job.
So when there is grade 2 or more listhesis, what we do is we always reduce it, because if you try to put the cage first, then the exiting route may come in the way of your cage, number 1. Number 2, it is not possible to completely reduce once you put the cage. So it is, I always prefer to put the screws first and then put the cage in. And here if you see, he has distracted the space well. So I think we can go in with the 10 or 11 mm cage.
Yeah. So Mahesha will go from the midline. He will show you how to mark and how to take the how much from the midline he will go. What is his plan? So he will just describe. Over to Mahesha.
So we first take the AP line. Can we check the CM? Come inside a bit. Okay, sure. So if you see here, I am just above the crest. So I'll just mark this line. So actual direction we will decide on the lateral. Can we take a lateral? Okay. Right. So here we go with the slightly more medial approach than what you do for a regular discectomy. So for 5S1 we generally take 10 to 11 centimeter lateral. So this is fairly all right. Sure. I need a true lateral. So we have to take a true lateral. Otherwise, no, it is still oblique. You have to come up. Okay, sure. So we need parallel screws, parallel end plates, parallel disc plates. Still it is not true lateral. No. You tilt this way, this way, this way, this way. Okay. Sure. Okay, that is perfect. You see parallel end plates, parallel screws. Okay. So can we take a shot? Yeah. Sure. Sure. So this is fairly all right. We are marking the lower part of this mark. So this is my direction and take a AP. So most important aspect of transcambine fusion is the guide wire. So if you put the guide wire properly, then rest of the job becomes easy. Okay. So I will take about
what
10
is that
centimeters from
normal
midline.
entry point you take in transcambine fusion?
Yeah, generally about 9 to 11 millimeter depending on the patient. I think here we took about 10 centimeter lateral to midline.
Okay.
So we have to go above the crest into the foramen. So this is 10 centimeter. Sure.
And you see the angle is going in. He's going with a more deeper angle.
So I am hitting the bone. Maybe it is a facet or pedicle. So let us check a lateral. Lateral.
So that angle is very important. You go more
anterior.
Anterior here. Varun was already mentioned in the morning. You should be in the middle of the disc or more anterior.
Okay.
So I prefer to go more anterior. In AP, it should be the tip of the needle should be in the
have to go more
midline.
deeper.
In lateral, it should be in the anterior third. Only then your cage is
So
more
I am hitting
deeper.
the rods now. Okay, sure.
See the obliquity
I'll
is
cross
going.
the rod. Sure. So I am somewhere here. Sure.
Is on the disc. So it's just
So I am
to
trying to stay as far away from the root as possible. Okay. So I am just hitting the bone now. This is the pedicle which I am hitting. Sure. So I am just at the lower end plate. Sure. I'm just hitting the lower end plate now. Now I just entered. Sure.
So we are
Can
staying
we take a
far
so
away
we
from
confirm
the
again
root.
that whether we are in the medial pedicle line. So always this needle is very important. You have to be away from the root. Okay. So I am just at the medial pedicle line. Are you happy? So I'll just go inside now. Now my next target is center of the disc in AP view and center of the disc in lateral view. Sure. So I will go up to the center of the disc. Sure. Sure. Okay, we take a lateral now. If I am not happy with lateral, I will just change the directions.
He's gone inside. This is what I was telling. The AP in the midline, and in lateral if it is beyond beyond and see that's
So it is bit anterior. I am not happy. So what I do is I go about a centimeter lateral. My initial entry is all right. I will just extend this and go little lateral. Okay.
So if you accept this, your cage also will be almost in the same position because you cannot do too much of adjustments.
So here you can. So if suppose by there was problem and you entered like this, so there is a trick again. Once you are banging the cage, you can just make it little bit lesser angle and hit it so that it can go more oblique. So he's trying to take a little bit lesser angle trajectory here. So these fine things are very important for a beginner. Otherwise, the cage placement becomes more oblique and it's more ipsilateral.
Because if the cage is only on one side, then especially on the side where you're putting, then there is slightly more risk of it backing it out. Whereas if you have crossed the midline, then the risk of caging backing out is very less.
So, sure. Now I am entering into the disc. It's in the midline, lateral.
Okay. Sure. Still it is bit anterior, so I will come out and go in again. Here I will not change the entry point, I will just go a little flatter. Sure. So I'll just
going anterior, just dip your hand and then go inside, so that it goes flatter.
Flat. Sure. AP again. This we can manage with our dilator.
So you have to spend time
You may
here,
put the dilator.
otherwise
You
will lose the entire trajectory.
This looks all right. So guide wire.
In the AP it is in the midline, lateral it is at the middle or slightly anterior, that is okay, acceptable. You can take this
Then put the
needle.
dilator in. Okay.
So then you change the guide wire to the needle. I mean, so change the needle to the guide wire and then put the dilator.
Okay. Sure.
So when you are putting this dilator,
Sure.
always
lateral.
observe the
just
buttock
at the
and
medial
also see if there is any movements, because if you are hitting the root, there will be contraction of the gluteal muscles.
Okay. So you can see my dilator tip at the foramen.
Do you use any
So-
neuromonitoring nowadays?
No.
So we do not use any neuromonitoring for transcam in case.
So here you can see what important Mahesha was talking about patient under GA. You can see the upper pedicle, there is a good space between the upper pedicle and dilator. Purposefully is entering at the lower half of the foramen and lower end plate level, so that you are absolutely safe. You enter like this, so you will not injure the exiting route.
Can you show here? Focus here. Okay.
So you see the dilator,
So
when
what I do
we
is-
bang it, you depress it, so that you get the proper direction.
Okay. Sure. This is the one. Sure. So now if you see, I am in the center of the disc space. Sure. In the lateral view. Sure. And AP. Show in the AP. So in the AP also I have to be in the center of the disc. So this is where my cage is going to be there. So this is very, very important. So if you see both AP and lateral, we are in the center of the disc. So now we put the dilator, I mean cannula. The cannula, the bevel has to face the exiting route. So towards the head end. Okay. So now we put the this. Okay. So push the cannula inside. Sure. Sure. Sure.
So this is a regular cannula of the scope.
take this
This is
out.
not a big cannula, because
Okay,
when
sure.
we were using big 10 mm cannulas,
Sure.
if it rests inside the disc for a long time, it can cause some injury to the exiting route.
Take a lateral.
So this is a regular
So
cannula.
we have put the cannula inside. Let us see. And give me
This
the
is
fluids.
8 mm sheath, 8 mm sheath.
So this is 8 mm sheet.
So this is the cannula.
We can use some manual
we are just in
preparation
the
devices here
I will just
to
put
prepare the
this,
disc.
Big curettes. So this we do it under sure. C-arm. Sure.
So always check AP and lateral views,
okay. Give me the
because
PSL curette.
both views you have
So
to
I
be
can
sure
use
that
this
you are
curette.
not crossing the limits of the disc, because anteriorly
Sure.
there are vital structures.
Sure.
Because sometimes in elderly patients the annulus will be very thin.
Sure.
It is very easy to
we'll take one
puncture the
AP also.
annulus and go to the other side
So
or
it is very
anterior.
important to see both the AP and lateral views. You have some sticker? Yeah, give me some sticker. Just cut half. Can we see the AP? So this is the AP and lateral. Put one AP and one lateral, please.
So once we started this technique, the tools were very minimal. Nowadays you have a good
show them both AP and lateral.
Good tools which Varun showed, and
So
Mahesh has
I put a
devised one
marker here, so I
expandable
know
reamer where you can go in and ream it out. Globus has a very good expandable shaver, and Wolf has come up with a flexible debrider. There's so many tools now available so that you can use it for the faster preparation, and it saves almost 30 to 40 minutes of your time. So here Mahesha is doing under CAM guidance.
You can mark your instrument. Mark your instrument so that you don't have to take repeated CAM shots. You mark your instrument to the maximum depth you can go under. Then you can use your tactile feeling to curate the disc space. बड़ा curate है ना आपके पास नहीं है ये इधर है ये that curate. So we first clear the end plate manually and then we will put the endoscope. Give me this grasper. इसको भी एक marker लगा दो. Sure. So small piece will give. So to know how much is the depth, we put this marker here. Clean. इसको भी एक मार्कर डालो इधर डालो. Yes. So we can use some articulating curettes also. Sure. So you can use various kinds of curettes. We have developed one more curette, which is a oval curette, which is quite a little bigger, and with that you can do it much faster. So even though it's a degenerated disc, still there is disc material, and when we put the scope inside, still you will find more disc material. Please do this. And then we insert the endoscope. To see the grasper. So after the manual preparation, you put the scope. And also to of course you can see a lot of bleeding because it's already prepared, but still there will be some cartilage. We prefer to put the endoscope because we are not taking autograft. We are using allograft or synthetic bone graft. So it is better to have good preparation of the end plates so that there is no compromise in fusion. So you can see that there is still some material inside which we need to clear. So number one, we shift to smaller cannula. Number two, we do the medial.
Simple point you should remember here is because the cannula is bevelly just sitting there, as a beginner you might slowly tilt it and you end up in only removing the subannular disc because the cannula tilts. So your direction should be always like this so that it goes more oblique from one end to the obliquely to the other end. So these are some few tips, otherwise you end up in decompressing only the posterior half.
So here my cannula is snugly fitting, so the 8 mm cannula is snugly fitting. Assistants are good, you don't talk much in the operation theatre because they know what you want. Otherwise, so you can see that the space is getting prepared. You can see both end plates. The disc material is cleared. So if somebody is inefficient, he will shout. So you will never see me shouting in the OT.
So he's trying to use curettes here. That's the only drawback. So he's using a flexible punches also to remove the posterior tissues.
Once you are done, you can see the good end plate preparation on upper end plate, lower end plate.
You can see both end plates prepared well and there is no damage to the end plate, which is very important, because if there is some end plate damage, then there is a risk of cage subsidence.
So that's a good preparation he has done.
So now
both
it is
end plates.
prepared very well. So I'll just come out a bit now.
No, the direction.
So 4S1 and 4.5, always there is some lordosis. So when you put the cage, you have to put it properly.
So probably I will put a 10 or 11 mm cage.
Bone marrow.
So we mix
about
bone
5
marrow with the
cc
allograft.
of, bone marrow and maybe another 5 to 8 cc of allograft. So we mix it and pack it and then put the cage. Okay. So this is the bone marrow. Can I get a glove?
7.5 normal glove.
So 10 hakonala. You can do eyeballing like this because our cannula is 8 mm, which is this part acts like a dilator. Half of the cage is smooth, so that it will not irritate the root. Only the posterior, the posterior 25% is serrated. So this will prevent migration. So this is the design of the cage. So give me the guide wire.
So cage is very important, because if you put a cage which is not properly designed, then it can cause post-operative dysesthesia. So this is a bullet cage. The tip of the cage is shaped like a dilator. So this will negotiate your exiting route. So we put it over the guide wire. We generally do not use any protective sheath, but some people use some sheath and put it. That's also possible.
And actually
You can either pack the cage or you can do it without also, because you pack the space already with some bone graft.
put the guide wire, then you cannot pack
But
it
if you're packing, you have to put the guide wire and then pack it, because otherwise it will not go through.
Okay. So just a little bit of graft is good enough.
So this is a very simple design of the cage.
So now this is okay. This is ready. So
This
we
cage
put the
we are using for the last 6 years with very good results.
So now you can see he's packing the graft, packing the space with the graft.
Hammer.
And using an impactor to just pack it into the space.
Okay.
This is from Jayon company.
So you can take allograft, autograft. Here we have taking autograft here, retrieved from the bone bank. So you just mix it with the blood, and so this allograft works very well, better than a synthetic graft, and it is more cheaper than a synthetic graft. If you take autograft, it's nothing like that. If you can't get autograft, then go for a allograft. Ortho people know more about allograft.
But generally, if you see all over the world, the use of autograft is reduced because of donor site morbidity. So, unless it is absolutely mandatory, we don't take any autographs.
We are packing the graft, almost finished.
Yeah. So then we put this guide wire. We keep the cannula, but remove.
Take out the cannula.
Put the guide wire and then remove the cannula.
Holding the guide wire. Okay.
So that your root does not come in the way.
Now this is very important. You cannot put the cage like this. If you put the cage like this, it will be oblique. So we need to go like this. Okay.
So proper orientation is very important.
You can make the cage image bigger. Cage image bigger. The camera, that's so now you can see
Mahesha is trying to adjust the
Yeah.
cage
So-
is going in.
So demo. So the cage will not go like this. It has to go like this. Okay. To compensate for the inclination. Okay. Sure. So we just
You can see
go
that
inside.
it is near the foramen.
Okay. Sure. Just bypassing the rod. Okay.
Mahesha, you want to take lateral here?
Yeah, I will go inside and then take a lateral. Sure.
So now
Yeah,
that
sure.
it is in the foramen, it is just entering
So
the
just I
disc.
am at the foramen. Now we take a lateral. Okay.
So here, this step, one extra step I do, over the guide wire I put a dilators what we use for percutaneous screws. The same dilators, I place two dilators one over the other. It just dilates your muscles so that your cage, when you're putting it, doesn't give too much of traction, and sometimes you're pushing, guide wire might go anterior as a beginner. So you can have some
Actually, Jayan have a dedicated
Take a
set
lateral.
now,
Yeah,
which with all cannulated dilators and sizers.
Yeah.
So everything is available. So it has become
Once I
easier
am fine,
now.
I will go inside, remove the wire and go inside. Okay. Come down a bit. Down, full machine down. Okay, fine. Yeah, sure.
So it is a very simple technique.
In a
With a
self
10
operative
mm
treatment.
incision, you can prepare the
Okay,
disc. You can put the graft and put the cage.
Okay, I think cage size is all right. What do you think?
Yeah, it's okay.
Yeah. So now we take out the wire. Okay.
So
the wire
this
is out.
Putting the cage
and I will
inside
go
through the
inside,
foramen
okay?
should be very fast. Within second, it has to go inside.
It's going with. Sure. Okay. Here we should not spend much time. Cage has to go in a bang. Okay, now we check AP. And if you see here, just show here, this is how tight it is.
So your
Okay,
cage
that means the
should
size
not
is
come
all
out.
right.
So if the sizing is
Sure.
proper.
Okay, excellent. Take a lateral. So I have space in AP as well as lateral to go inside. So I will go inside a little more and it should be fine. Okay. Sure.
So once the cage is inside, we remove all the instruments and then check once with the scope again. See that everything is all right, there is no graft in the foramen, the root is all right, the cage is all right, and then come out. And
So the
most
cage-
important thing
cage is
is
here.
You can see the
we have
cage
to
there,
put steroids.
well inside, with fragments, any floating around the foramen.
Yeah, that is the
that
cage.
will,
So everything is fine. So our root is good. There is no problem. There is no bone in the foramen.
Yeah.
Because sometimes that can give trouble. If you leave it as it is.
Follow the principles. The transcambian approach is very fast. 45 minutes. You have done
So we
the
will
cage
put some
insertion.
steroid and come out.
45
So
minutes
that-
more for the screw placement. So entire surgery will be over in 1.5 hours, which is your anyway regular T-lift time. So, but you should follow that principles of the landing, guide wire, the end plate preparation, appropriate cage size, then not working around the foramen for a very long time. So these are the few principles you should be following. So once it is done, the normal.
Steroid and come out.
So you see the recording time here. Our recording time is almost less than an hour. So that's the biggest advantage. 20-30 minutes for the cage, the screw. So he has done, because it's a demonstrative case, he has done in 56 minutes. He's out. So 1 hour is definitely, he's putting a steroid there in the end of the procedure just to have the exiting route, paresthesia sometimes and be there. So hope that steroid works. God knows it works or not, but it's for the surgeon satisfaction. We give dexamethasone. This is a final cage. You can see the cage placement. It has come very well. Thank you. So we'll we use the dexamethasone. You can use the Kenacort. So we'll see if you want to see thoracic decompression. We'll break for a very quick lunch and see the thoracic. It's a very good case. We can see. Yes, Ramesh. Last one question we'll take. Babu, videographer, side ikra.
Yeah, is there any difference between the use of titanium cages and PEEK cages as far as telescoping or subsidence?
Yeah, so here
sort of
for
different
the
fusion, of course.
Transcambian, we use only PEEK case or the titanium cages for now because we don't have a cannulated titanium cage in the market.
A PEEK cage, yeah.
Sorry, PEEK cage in the market. So we are using titanium for now. Regarding interlaminar, either way, whichever you are comfortable. Mahesha uses titanium, I use PEEK. So because PEEK, it doesn't give you much information on X-ray, so we are happy. Otherwise, patient says something kept there.
Because titanium has a very long history of, it works very well.
Yeah.
And I don't
Cheaper
find
also.
one reason why I should change from titanium to PEEK, which is more expensive. You give me one reason.
No, the only thing is the texture
It is,
possibly
it
is
is more of marketing thing.
Yeah.
Nothing else.
Yeah.
No, again they are coming back to titanium, the PEEK people. And there is one more material in the market called PEC. So you can, Naresh is there. So Naresh can be a better person who can talk more about PEC material. So there they say it is more stronger, the material like skull bone, and the osteointegration is much better than PEEK. So now they are coming up with PEC cages.
Okay.
So
And don't you compress after this with the
No, it's up to you. You can
do it.
Yeah.
Okay. Well, I saw the extenders have been removed already, so I just thought possibly.
So when you are reducing, so it is difficult. You want to compress, you can, but you put adequate size cage or a little bit 1 mm oversized cage. The moment it goes anterior, it automatically increases the lordosis. So you can do that. You can do that.
Thank you.
So we'll quickly break for the lunch and come back for the thoracic case. In maybe, sir, 20 minutes? 2:45 because so many people have to leave by 4. So we'll complete. So welcome back. So before we start the thoracic, 5 minutes, Dr. Gaurav will be our friend, Gaurav, who is doing endoscopic surgeries since 2 years on his own now. So he will be presenting about the osteophytes. When you have osteophytes, when you're doing interlaminar surgeries or transforaminal, what are the tools to be used? He will just present. Over to you, Gaurav.
Thank you, sir. First of all, thank you, Sukumar sir, Naresh sir, and Abhinandan sir to give me the opportunity. And I'm feeling privileged to come here. I was a first student of Dr. Sukumar sir, and because of him, now I am able to do independently my own cases. So, how to tackle bony osteophytes or calcified disc? So through all yesterday's and today's enlightenment, you can able to land in the disc space area. But identification and correlation. Yesterday, one of my colleague, Mr. Dr. Harshit, has told how to identify the osteophyte, whether it is soft or hard or calcified. So here you can see there is a hard fragment, and because of that hard fragment, the soft fragment has come down little bit, down migrated. So this zoom technique, what yesterday has been taught, that is very handy, and it gives lot of idea about anatomy and surgical planning. So here is another case. You can see, normally we can see a soft fragment easily on regular MRI, but when you zoom it, there is an cranial and caudal osteophyte. Between these two osteophytes, a soft fragment is stuck and causing pain to the patient. Another example, these are inferior end-plate osteophytes, these are superior end-plate osteophytes. So these osteophytes, although majoritarily they will not cause any problem during surgical procedures, but having said in endoscopy, they are ultimate important, because suboptimal work, just removal of soft fragment, will not serve the purpose. These hard osteophytes will cause pressure over the traversing roots or thecal sac. So tackling them is very much important. So there is a first case, interlaminar, and you can see some inferiorly migrated fragment because of hard upper end plate osteophyte, and the fragment is in the left side of the recess. So you can see on the X-ray nicely the osteophyte is visible, and to correlate, there will be the landing point. So after dissection, so this is cranial, that is 9 o'clock, and 3 o'clock is caudal. So after retracting the thecal sac, there is a soft fragment which will pop out immediately. After this, you have to rotate your sheath to take out that soft fragment. So you will remove that soft fragment with grasper's punch. After that, you have to delineate the margins of the osteophytes. It is paramount important that your sheath should always be in a retracting the thecal sac or traversing root. So we can put Kerrison punches. You can put even drill bit, high-speed burrs also. We will show you some of the examples. So after delineation of the osteophyte, we can put diamond burr. So there is a video of we are drilling the inferior end plate osteophyte with a high-speed diamond burr. Important thing is your cannula, the sheath, which is always protecting the traversing root. That is very much important. All the time you have to see your traversing root is being not in the way of your drill. So it is all the time should be behind your cannula. And then there is a cranial osteophyte. Soft part of that osteophyte is being taken out by the cutter, and the hard part is being again another diamond burr is being used for the drilling. So after this tool, we have another tool in our armamentarium, that is chisel, endoscopic chisel, or called goose. This is very much important because where the places your drill won't be, you feel that it is not that much safe to use the burr, your this endoscopic chisels will all the way very much handy. This is the hard fragments which are coming out with the help of cutter, and this is a miller, face miller. So this is another very important tool. It soft to hard fragments, it always helps to neutralize them and gives very good visualization. So this is a PLL, and so you can see both upper and lower end plate osteophytes have been nicely taken out with the help of the tools in our armamentarium. And the thecal sac and traversing road with the axilla, everything is free here. Next, for the transforaminal, here is a case of L1, L2 hard ossified disc. You can see more on the left side, and some caudal hard osteophyte is there. You can see in the pre-op CT we have done, there is a hard osteophyte right from the upper end plate till the lower end plate. You can at the disc level and at the lower end plate. This is our landing point. In AP we are touching near the midline. In lateral we are just in the posterior 1/3. You can see, you can delineate a very hard osteophyte below the needle there. And this correlation is very important in the transforaminal, as understanding that how to land and where to land in the transforaminal technique is very much important. So you have to have a superficial landing in transforaminal to tackle these kind of osteophytes. So here we are on the left side. After removal of soft tissue, there is an articulating burr which is available with the Revo spine. So you can use that to a very good extent. It is almost 90-degree articulating burr. No need to turn or take out your scope outside, and you can use the Kerrison 2mm punch is available with them. So this is an articulating burr which can be used, and it can nicely drill out the upper and lower end plate osteophytes. So this 12 o'clock is towards thecal sac, 6 o'clock is inferior towards the disc face. So with the help of chisel, we'll take out all the hard to firm osteophytes from the upper and lower end plate. This is the upper end plate. You can see the hemostasis is of paramount importance. 12 o'clock you can see a thecal sac with a epidural fat pulsating there. Again articulating burr. All the time the burr should be in your vision, because if it is used inadvertently, it causes torrential bleeding and chances of neural injuries there. Again the chisel is used to caudal end plate to remove that osteophyte, and after this removal of osteophyte, bleeding control is of paramount importance. You have to have good hemostatic techniques. So you can see the thecal sac is now getting free. Now this is still midline. There is a midline osteophyte, as we have seen, that has completely being taken out. Some part of the cranial osteophyte was remaining, that has also been tackled. So this is the end point of our osteophyte removal. You can see nicely thecal sac is bulging, and some of the osteophytes which were there in the epidural space is being taken out with the help of annular cutter. So this is a post-op scan. You can see almost you can say 90% of the osteophyte has been taken out through transforaminal technique, as it is upper lumbar disc. So these are the tools which we want to mention here. This is an articulating burr which we were talking about. Almost you see 90 degree of articulation, and this comes very handy when you are using transforaminal technique, where your limitation of scope movement is there. And these are the regular burrs which already being shown over a period of 2 days. And these are face miller. This is 3 mm. This is an illotome, we can say chisel or goose, and this is a articulating curate. So with these basic 7-8 instruments, you can do good osteophyte work, as I say, or calcified disc work. And having these in your armamentarium will make surgeon's life very easy. Thank you.
Hello. So excellent work, Gaurav. Any doubts? Otherwise, we'll go to the next talk because lack of time. We'll go to this thoracic decompression. So always thorax, either you go from anterior or posterior. So whatever is there in thorax, it's always difficult because the discs are hard. Most of the time it gets ossified, and if it is posterior, there is ossification of the yellow ligament. So yeah, then the madhyalo pettis. So here this is a case of volume pinches. Pinches and onlone undi. Elderly man with a severe numbness in both the organs with no significant previous trauma history, with all myelopathy signs, with exaggerated reflexes, with plantar subdural. So progressive difficulty in walking. So MRI was showing a dorsal compression here. When you see a sagittal venous C2, there are small disc bulges, but there is a significant posterior compression leading to stenosis and also navigation cord failures here. When you see the axial crux, it depicts more. You have a significant compression at D9 depth. In the level, the other levels of mild compression is there, but mainly you can see this. There is a significant compression. And CT scan images. CT scan shows this ligamentum flavum, which drapes around the facets, is calcified. So that's why you are having a fixed stenosis there. So we will, the plan here is we will go posteriorly, land on the lamina, that is D9 lamina. So when you want to go posteriorly, the challenges are here. The lamina is very oblique. The laminas are very oblique. There are hardly any interlaminar space, and the interlaminar space is much medial, very medial, and there is a very small window. So whatever you land more laterally on the pars and the facet. So is online, yeah. So we just Dr. Sanjay Konakondla is from USA. Is online. He is the pioneer in thoracic disc surgery in USA. He has mastered this. Welcome, Sanjay.
Hello, how are you? Good afternoon.
Good afternoon. So we are very happy to you be associated with us. This is Dr. Sukumar here. So I was telling about you, he's a very well accomplished, we can call himself a thoracic endoscopic spine surgeon. He is doing excellent work in USA, and he does the maximum thoracic work in entire America now. So he was supposed to come, but unfortunately due to some personal reasons he couldn't travel on time. So he is presenting today about his thoracic work by endoscopic spine surgery. Over to you, Sanjay.
You can share the screen, yeah.
Okay, do you see it?
Yeah, you can go ahead.
Okay, thank you so much for inviting me again to this masterclass. I'm privileged to share our experience in endoscopic thoracic disc herniations, and feel free to interrupt, ask any questions. We'll hopefully keep it live, and if anyone has any comments throughout the talk, please let me know. So, endoscopic thoracic disc herniations are challenging, but they're super appetizing, right? Because the symptomatic yield against the surgical invasiveness is very tempting because of what you can accomplish with the endoscope. I'm a spine and neurosurgeon in central Pennsylvania in the U.S. and currently the only endoscopic surgeon in the system. So it's not as easily or quickly adopted here in the U.S. for many reasons, some of them being financial. But it's good to be part of the movement and the very small group worldwide, I would say. The objectives of this talk are pretty simple: to go over the technical pearls and and look at the new considerations and the new applications of spinal endoscopy in the thoracic spine. We'll talk about how to avoid really bad issues and pitfalls. And, at the end of the day, we're still learning, right? So we still have to try to get the endoscope in some pretty hard places. But when we challenge ourselves, we can find out that we can do some pretty impactful things. And we'll go back and forth between these pearls, pitfalls, and challenges. This is currently how we leverage the scope in Geisinger in our institution. So, everyone's question, at least in America, is, why do we need a fancy camera to do lumbar discs, right? But, the answer is it's sort of a gateway, right? After you start doing lumbar discs, you can start getting a little bit more trained with the endoscope and its techniques and the handling. And then you can apply it into synovial cysts and cervical disc herniations and central stenosis. You can treat hardware complications. You can do osteodiscitis. You can drain abscesses. You could fix spontaneous spinal fluid leaks. Tethered cord releases is another thing we just started to do. But of course, we'll talk about thoracic disc herniations. Any patient, whether myelopathy or radiculopathy, in any size and shape of any discs. Typically, some quick facts of thoracic discs: they're less than 1% of disc herniations. They can come in all shapes and sizes, right? Soft calcified, most are calcified. They can be large. Most are in the central canal versus foraminal or extraforaminal. Some say these discs can be intradural, but most are extradural, and they can cause myelopathy, radiculopathy, or both. But of course, all the goals and considerations of a surgery are to preserve function, resolve pain, and give the best chance for functional recovery. Now, what are our current options, right? Our current options right now are to do posterior laminectomies, everything posterior lateral, right? Big collateral damage, multiple various incision options, with each of them being large muscle dissections or significant bony resection. You may or may not need an access surgeon. So significant resources have to be taken in order to sometimes accomplish this, and a lot of multidisciplinary discussion to take care of these discs just in a different area of the spine. And of course, there's endoscopic approaches when there are interlaminar versus transforaminal, but we'll focus more on the transforaminal because these are more of a ventral pathology. And interlaminars is not that groundbreaking because we can use that for dorsal pathology pretty easily. So, currently there's no standard, but soon I'm pretty sure we can all agree that the endoscopic approaches will be standard of care for thoracic disc herniations at the very least. even though endoscopic surgery is smaller, right? Even though it's a smaller incision, even though collateral damage is very minimal, the considerations are still the same with the spinal cord, right? We're still in the same place. So with every open surgery, there's visualization limitations, canal to cord ratio is smaller. The watershed zone is a real thing for the thoracic spinal cord. But all these considerations are the same for the endoscopic surgery. So we have to maybe suggest to folks that this doesn't necessarily mean it's an easier surgery to do, right? In fact, it's harder, it's more challenging, because we have to get to these places with a very super specialized, targeted, patient-specific and pathology-specific approach. When you look at the large bony resections of the other surgeries, you can have some pretty bad complications, and the numbers aren't small. You know, up to 25% of complication rates are for the other conventional, traditional thoracic surgeries. And we're talking about CSF leaks in the thoracic cavity, which exposes it to the negative pressures of the thoracic cavity, which can be very difficult and challenging complications to treat and fix. Now, if you want to remember one slide of endothoracic applications, this is probably it. The indications are the same, but we'll go through some nuances and changes there because of the application of the endoscope in the thoracic spine. But the steps are really important. The first three steps in any thoracic surgery, any spine surgery, is going to be plan and then plan again. A lot of the challenges with these cases is actually getting the right level, right? When we use fluoroscopy, this can be very disorienting, right? Lateral x-rays and AP x-rays, and every level looks the same in the thoracic spine. So when trainees want to get into the lab and practice a thoracic disc with the endoscope, that's fine and it's important, but the fear and the consideration of the proper level in a cadaver is hard to replicate. So there's many things in a real case that you have to learn almost for the first time, even after you've practiced and studied this approach. Then you mark your trajectory, you go towards the trajectory. Some people are still reaming in the thoracic spine. I prefer not to for many reasons, but one main reason is for safety, but also for visualization and clear optics. I like to see preserved anatomy and drill it purposefully under direct visualization. And after you introduce the scope, you identify the anatomy, you take care of the SAPs, and we'll go through these steps specifically. There's a lot of pros to endoscopic surgery, right? Less collateral damage, less bone work. The off-axis view, we use a 30-degree scope for the thoracic spine, just so we can see behind corners and ventral to the thoracic spinal cord. And of course, it avoids scar tissue, right? If there's previous dorsal decompression in the thoracic spine or instrumentation, you're avoiding all of that by doing the transforaminal approach. Now, it is a steep learning curve, and there's definitely little room for error, right? As opposed to the lumbar spine, if you plunge, you're just bouncing off the thecal sac, where the cauda equina nerve roots can sort of just move away, but the spinal cord is not going to move, right? So if you accidentally push down and go more ventral in a very fast, rapid motion, that can cause some pretty devastating, irreversible injury. Now, there's several notes and considerations to be made through endoscopic thoracic disc surgery, but we'll go through the specific notes as we talk about cases. Now, we suggested some new indications, right? What are they? You know, when we look at pictures like this, we have to sort of step back, breathe, and then sort of review not only the picture, but talk to the patient, right? There are multiple patients just walking around with bad radiculopathy with thoracic disc herniations. Now, those folks before endoscopy were sometimes not even offered surgery because sometimes the surgery is worse than the disease, right? And sometimes the radiculopathy that they have is not bad enough to treat with a big, open shark bite incision, as we call it, rib resection, moving the lung, bony resection, and then a chest tube and a hospital stay, right? That surgery, that post-operative course is not worth it for a traditional or a symptomatic radiculopathy that's only radiculopathy and not bad enough. So this gives us a new indication. It sort of opens a new business line, so to speak, right? Now these patients can be treated because you can now approach this with the 8mm incision. This is how our operating room looks like. It's just set up just like any other transfemoral approach. I'm sure it's not different from any setups across the globe, but we have the equipment, instrumentation, the monitor on the opposite side of the surgeon. The surgeon typically stands on the side of the pathology with the assistant, and the anesthesia is at the head of the bed. Now, this is how we think of all our endoscopic cases, but of course, with our endoscopic thoracic cases as well. It starts with the planning discussion. That's part of the surgery, right? I mean, and again, I'm sure we can all agree that, the planning and the patient discussion is just as important as doing the surgery. Sometimes I tell the patient, the surgery is the easy part in this whole equation, right? The harder part is figuring out if this surgery is going to help you, right? And that's a very important thing for them to know, because we could do anything, right? We can make any incision anywhere and put any instrument and any equipment to address any pathology if we wanted to. But our main job is to figure out if that patient needs it, and if we do this surgery with 100% success, will that patient get better? And that's the hard part. That's why, as you can see here by the timestamps, we spend most of our time with the patient discussion and expectations, and also then addressing the pathology. With things like targeting and identifying landmarks and closing, obviously, once we streamline these steps of the procedure, they're all the same, right? It's identifying the same landmarks, it's targeting the same way, it's making the same lines, and again, these get pretty streamlined and standardized fast, and they don't take much time during the case. Now, with targeting, when we're teaching trainees, we always talk about missing shallow, right? All these red arrows, these are deep misses, okay? Clearly, if you miss anywhere here, these are going to be bad places, right? We don't want to take an x-ray and have our needle there for the first time, or here, If we take an x-ray or a lateral here, a fluoroscopic image here, this may look good, right? It may look good, we're heading towards the right direction, but on the AP x-ray, we are far from the spine, right? That's not a good picture. So if you're teaching a trainee and the first x-ray they take is somewhere that localizes in this area, obviously that's not a bad, this is a bad, it's not a good place to start. So these are all good misses. They're not in the right place, but they're safe, right? This is in muscle, this is hitting bone, this is hitting ventral or dorsal, this is dorsal lamina and dorsal facet. These are all fine because you could eventually walk down to the actual area and nothing actually happens, right? So that's an important sort of tenet to remember, right? Missing shallow. Now there's various considerations for thoracic disc herniations, but we'll go through that. But the considerations are important. This is a new approach in a new area, and in an area where you're not used to making an incision. So there could be spinal cord stimulator leads or other incisions and other considerations that you have to make, so you don't implicate other surgeries or other devices that the patient has. This is how the initial targeting x-ray look. We use all fluoroscopic imaging for this. So clearly, all these levels look exactly the same, right? So when you're taking these x-rays over and over in the operating room, you have to know that you're operating on the right level. So after you adequately count, at least for me, I'll put a spinal needle on the contralateral caudal pedicle of the target of the index level. So if I'm doing this level, I'll put that needle there. It's out of my way. And it's the only static instrument that's on the spine. So as I'm moving this endoscope, I know that I'm operating still on the correct level after I initially counted. Because in surgeons that don't do endoscopic surgery, they have to know that everything is dynamic, right? In minimally invasive surgery, sometimes we have a tube, but that's connected to a table, right? That's fixed in one area. That's your fixed instrument. In endoscopic surgery, nothing is fixed, right? Very small movements can put you at a very different level. So this spinal needle, to me, is very important to skip one step of thinking throughout the case to make sure, again, you're doing the right level. Now, this is a modified approach that we're showing here because we're actually docking on the superior articulating process. But this is exactly the move. This is a small drill here, and I'm drilling the SAP to get more medial to eventually reach the canal. And these are our checks, right? Feeling above and below the disc space to make sure that we're addressing the pathology in total and full. This is the anatomy I like to see. Inferior articulating process, superior articulating process, and the joint space, okay? Once you find this, you're automatically oriented. So I didn't have to tell you where the head is and where the feet are, because if this is the IAP and this is SAP, you know this is the orientation, right? And behind this SAP, after we go through it, it's going to be epidural space, and then you know our arch, our pedicle to the vertebral body is going to be somewhere there, okay? So those are our landmarks that we identify. This is obviously how it looks like. We are drilling the ventral portion of the superior articulating process. You can see the ligamentum flavum right there, okay? Ventral to the superior articulating process, and now the SAP arch down to the pedicle towards the vertebral body. Okay, and then after we take the superior articulating process off, you can see that there's all this stuff before the epidural space and before the actual dura, right? There are these pseudomembranes that we all know as endoscopic surgeons exist. We've recently submitted a paper talking about these pseudomembranes, but it got rejected because people think that this is just the medial portion of the facet capsule. But I'm sure we all know that these peridural membranes are a real thing, right? This is not dura, but they can be very deceiving. So when we get down there, we have to look for fat, and we always say trust the fat, right? If there's a bunch of fat behind a tissue plane, we know this tissue plane is not going to be dura, because on the other side of dura should be the intradural space, not fat. So if we see fat peeking through some tissues, we know that that tissue can be removed safely to enter the true epidural space and see the dura. Now this is a somewhat confusing picture, but you can get a glimpse of the spinal cord here. But all this is calcified disc, okay? And we're working through the other side, so that's also dura there. So what we're working on is hollowing out the calcified disc, okay? You can see that this is the disc space proper over here, and this is the window on the other side of the calcification. So what we have to do at this point is to remove all this, which is a last rim of calcification of that disc, and free the spinal cord. And we always think that's the last easy step, but what usually happens is this, right? The whole screen fills with blood. It turns red. And sometimes that can get pretty annoying during a surgery. And in lumbar surgeries, it's fine. You know, you get the camera down there and you put some instruments down and you try to coagulate this area. But when there's a exposed thoracic spinal cord behind this blood, it can get a little scary, so you have to, advance instruments with a little bit of trepidation. But there are some techniques that you can use to do this, right? Remember, there's continued irrigation, And this is a free scope, so you can rotate the scope to get the water and the irrigation coming out different areas. You have to advance closer to where your presumed bleeding site is, and you advance the instrument slowly. As soon as you have the instrument within your working channel of your endoscope, there's automatically more pressure. And with more pressure comes, you know, fluid dynamic changes that hopefully allows you to see and increases your visualization. And then you place the instrument on the area of bleeding, and without turning it on, that will stop the bleeding. And once you're in a safe space, then you can turn it on and coagulate. And the next step is addressing the pathology. This is what a decompressed spinal cord would look like. And remember, there's continuous irrigation on, right? So it may still look like there's some sort of compressive component there, but it's important to turn the irrigation off to see if this assumes its natural cylindric morphology. But this is important to note too, because in any thoracic case, we have to follow that river of disc. Once we find the disc, laterally, we follow the river centrally and more medially till we see that dam of disc herniation, right? So anything over here, which would be like a dam to this river, we have to remove, which would be a disc herniation. So you have vertebral body above, vertebral body below, and disc herniation that we follow medially. Disc space that we follow medially to get to the disc herniation to decompress the spinal cord. This is a case example. It's a 57-year-old female who actually just had radiculopathy, and she was told that her surgery was too dangerous because all she had was pain for this big thoracic disc. On examination, she was actually severely myelopathic. You always get a CAT scan because most of them are calcified, but it's not enough to know, you know, whether it is calcified or it isn't calcified, right? We have to know a little bit more. We have to make a little bit more consideration, you know. Is it 50% calcified? Is it scattered or speckled calcification? How is this going to be handled during the surgery? Can we manipulate this disc in one piece? Is it going to come out in piecemeal? But as you can see here by the scattered calcification of this disc, it's likely going to be, you know, picked at in multiple pieces, right? Just like a stale cookie consistency. Again, we have our steps. We rinse and repeat, right? Same thing. We dock down in superior articulating process. We have one non-mobile piece of equipment, that spinal needle, to tell us that we're at the right level. We make sure we're above and below. We make sure we're medial based on our pathology, and then we take the disc out. Again, IAP, SAP, superior articulating, joint space, right? And then and then arch towards the pedicle. Spinal cord is starting to come out here. There's the last remaining portion of the superior articulating process here. We could already see the disc herniation. This is our instrument curving ventral to the spinal cord. And then we want to see this ventral epidural space. This is the video of us taking out that stale cookie-like consistency disc. And we want to keep picking at it because this is exactly how we thought it would come out, right? So after we remove this, we can see that we're ventral to the spinal cord. There's adequate space there. It's pulsatile. And now we have a decompressed spinal cord. So that's how you know when you're done, right? You have a spinal cord here, all the space ventral to it, and nothing dorsally displacing that spinal cord anymore. So, you know, what we had is a big disc pre-op, and that's the pre-op CT. And this is the post-op, right? We had to actually make sure this was the right patient because of the very minimal collateral damage, right? You had this big disc here, and now the spinal cord is all decompressed without any really clear collateral damage, at least on the sagittal MRIs. But this is our collateral damage, right? That's our approach. That's our trans-SAP approach from the endoscope. So we're not dealing with any major vessels. We're not dealing with the lung. We're not in the thoracic cavity. We're not removing any of this rib. And we're coming completely dorsal to the thoracic space. the thoracic cavity and docking down at the disc space, and with her angled scope looking ventral to the spinal cord. And we all know that's how the incisions look on any endoscopic case. It's no different with thoracic cases. And this patient was actually discharged home the same day, and after a year follow-up, she was walking without a walker, and all her pre-op pain was gone. So very happy patient. Another case, a little bit more complicated. This is a 32-year-old female. BMI was actually 54. She was severely myelopathic and then progressive for over 6 months. You can tell very large disc, but this time caudally displaced, right? If we have a pedicle here, which we do, most of this disc is medial to the pedicle, as we can see here on the axial. So the good news is for this disc, it's paracentral to the right side, which makes it a little bit more favorable for an endoscopic approach because that's exactly where we can target it. I put this scout imaging here for a reason, right? Any approach to the thoracic spine would be very difficult, right? And prove to be a very challenging case no matter what approach you choose. But as you can imagine, any major approach, any large incisions, any tissue dissection would be almost half of the surgery with an open approach. But with an endoscopic approach, it's all still the same, right? But before we do anything, we have to do a CAT scan. And it's not enough to know whether it's calcified or not. It's important to know more information about the calcification. This one has a rim of calcification and speckled calcification inside. So what that means is we can hollow this disc out, and then we have to manipulate the disc wall because, like, again, it has a thick calcification. And that can help us in maneuvering this disc during surgery. Because of how complex this was, we actually made some 3D renderings, and our 3D lab helped us make these CADs on the computer. And we also resected some bone, right? So we removed the bone and subtracted the bone of anticipated bony removal, which ended up being the SAP, the TP, and the pedicle of T10, and the T9 IAP to help us see all this green disc. And we also 3D printed that. We use some 3D printing for some of our cases. Number one, not only for surgical planning for complex cases, but more importantly, we're finding that it helps with true full informed consent, right? Patients want to know what they have. They're interested now more and more about what you're going to do in surgery, and having sort of a life-size model of their spine and their pathology helps them fully understand how technically challenging some of these cases are. It really helps them understand what you're trying to do for them as opposed to other surgeries. Here's some key intraoperative images that we like to get for all of our cases. I always do a midline line. I do a line, you can see the purple line of the line of the disc space and the line of the trajectory. This targeting and trajectory is a little bit different because we want to target lateral to the pedicle because we have to drill through that eventually because we know our disc is going to be here, right? So this is how the drilling through the pedicle looks like. The good news is for thoracic discs, 70 to 80% of the pedicles in the thoracic spine are cancellous. So things like a coarse diamond drill bit can go through the cancellous bone of the pedicle very easily. What we eventually have to look for is this cancellous bone, right? You can tell the difference between the cortical bone. You can tell the difference between the cancellous bone here and the cortical bone here. And we know to take X-ray at that point because now our drill is on the medial border of that pedicle, and just behind that, that medial border of the pedicle is going to be our disc herniation. So we get through all that, and you can see that this is the spinal cord under still some severe compression because this last calcified remaining disc is compressing the spinal cord. We remove that, and we finally see the spinal cord in its natural cylindrical morphology. That video is also available to view online. So this is her pre-op imaging. This is her post-op imaging. No more spinal cord compression, again, our approach, our collateral damage, and her incision at 2 weeks. So very high yield of symptomatic relief against surgical invasiveness, and another successful case. But this is eventually what the practice turns into when colleagues and partners and competitors and folks across the country start recognizing that you're able to help these patients with thoracic disc herniations with endoscopic applications. And, you know, they start getting referred to you because, number one, no one enjoys doing a large surgery for a small pathology, right? Sometimes, again, folks are worse after these surgeries than they were before they started. So being able to treat that is a real pleasure. Here's just an interesting video, right? Again, understanding how calcified your disc is and where it is important in the manipulation of this disc and how you're going to treat it during the surgery. You can see this is a big calcified rim and it's a smooth surface. So after releasing that from the ventral thoracic dura, we're able to have a nerve hook in there and manipulate it and deliver that towards us to remove that disc again in piecemeal. So, you know, I actually have to update these numbers. Over the last 36 months, we're about 40 patients and 42 discs, which, you know, for a pathology that's less than 1% of all disc herniations, it's a pretty high number, and we don't expect that to slow down. You know, with all this data, we're sort of pulling together some numbers to sort of help us design some treatment algorithms, patient selection frameworks, and really, you know, still learn from how we target and what we're able to do. But we have to, you know, still talking about the limitations. Some disc herniations can be really stuck. Some can be so medialized or broad-based that we may have to consider contralateral approaches or bilateral approaches for some of these discs. And you know, when a patient wakes up after an incomplete disc herniation or disc resection from an open thoracic procedure, that conversation is very different than if they wake up with residual disc after an endoscopic procedure. The question usually is, you know, when can you try again? If you do an open approach and you don't get all the disc out, they're probably saying, please stay away from me, right? So these are very different conversations you have, but, you know, the benefits of doing smaller procedures with minimal collateral damage is we get to redefine failure, right? You know, where these patients are coming along with us for that ride. That's why that important conversation before any intervention is key to helping them understand, you know, what you're actually doing. So we look at the disc characteristics, you know, the size of the disc, calcification or not, but more detailed description of calcification. Is it a caudal or cranial migration of a fragment? The patient characteristics are important. Level of pathology is important. Do we have to deal with the scapula? As we go higher up in the spine, the costovertebral joint is right in the middle of our disc space that we have to drill the rib head sometimes to get access to the disc space. The rib morphology is important. The apex of the rib to stay outside of the thoracic cavity. These are also important things. So always remember, plan first. Level of surgery, use a static instrument, whatever your workflow is to get the right level. Always miss shallow. Targeting is patient specific again and pathology specific. Going outside to in, meaning making a big space before going inside instead of coming back out and realizing you need more space and more drilling outside after you have the spinal cord is probably a less safe way to do it. Trust the fat, don't plunge, and again, just because it's smaller doesn't mean it's easier, right? This is our endoscopic team here at our institution. Obviously, it's a big team. All these people are exposed to new procedures and new equipment and new surgery and new setup. So it takes a long time to get things going. But once people see that all these people are looking a lot different than typical spine patients, they quickly rally behind you. We are part of a national multi-institutional research group also. So I'm not the only one doing these thoracic discs, but we are collecting some data for that. We've recently published some papers on thoracic discs. We have a neurosurgery paper in the Red Journal that just came out that looked at our patient population against historical cohorts, and that data is pretty encouraging, right? We have almost 100x less of blood loss. We have 16x less length of hospital stay. Surgical invasiveness is significantly decreased. Complication rates are down almost 5x. So these are big numbers, right? So we're excited to share our experience, and that actually, since publishing that paper, we almost have double the amount of patients now. So we're going to probably put up a follow-up paper for that. But this is the disc herniation that's been haunting us throughout the presentation, right? This is that last disc, that calcified portion of the disc. You can see us maneuvering that last calcified portion of the disc and pushing it down into the space that we've created, right? In any thoracic case, we want to make some space ventral to the spinal cord, and we want to deliver that. It's tempting to grab that disc herniation and pull it towards you, but remember, in an angled scope, you will pull it across the ventral portion of that spinal cord. So we have to actually drop it ventral first, and then pull it laterally, and then pull it out to avoid compressing that spinal cord as you deliver the disc. So who's the perfect patient for an endoscopic procedure? Obviously, you can't ask that question anymore. They're being applied in any pathology in any area of the spine. So always appreciate being part of this very exciting conference, and hope to be a part of it as it develops. Please let me know if you have any questions.
Thank you, Sanjay. It's an excellent talk. So I've been doing thoracic disc surgery since 4 years now. So I've done around 12 cases. So it's a very, very difficult trajectory. The uppermost level I've done is D23. So in fact, do you remember, Sanjay, that patient was referred by you from New Delhi? Yeah. So it's a patient I operate. The uppermost level was D23. So it's always difficult as you covered almost everything. The steps, the important steps is the facet drilling, and sometimes you might have to drill the rib head, which comes in your way. So the margin is less, because if you go lateral little bit, sometimes the discs are so hard and you just push things hard, you might enter the pleura. So these are the things you need to understand. And as Sanjay showed in few cases where the hump is too big, already spinal cord is ischemic, their slightest manipulation of the cord might give you trouble. So always stay inside the osteophyte, core it out, drill it out, use all the tools you have. Once it is thinned out, then you slowly start chiseling it out and removing it. Use a diamond burr, both the simple diamond and articulated burr to the fullest, and drill adequately. Do some pediculotomies, no problem. Identify the base of the pedicle, drill the entire superior facet, no problem in thorax, because there you have a good rib cage support. There is no need to worry about the facet. You can just knock off the entire superior facet, as Dr. Kochi Sairo yesterday showed in few cases. You can entirely knock off the facet. Idea is to do a good pedicle to pedicle clearance first, then go beyond the pedicle. So because here you see most of the thoracic cases, the classic calcification is beyond the end plate. That's the important thing. So to disconnect that, you might have to do some drilling of the body, upper and lower body also, so that it's like a trumpet osteotomy, what we call, where you do a wide-mouthed drilling there, so that you can disconnect the osteophyte from cranial and caudal, so that you can mobilize the entire calcium or ossification in a big piece and you can remove it. Thank you very much, Sanjay. I think any questions, one or two, we can take it. Yeah. A question to you, Sanjay. Do you use neuromonitoring routinely?
Yes. In all thoracic cases, we neuromonitor with MEPs, SSAPs, and EMGs, and we do push maps. We keep the mean arterial blood pressure above 80, 85.
Okay, okay. Yeah.
Sanjay, can you come on, stop your screen sharing,
and you can
so that you can see the people?
Yeah, we can see you, Sanjay. Yeah.
Yeah, perfect.
So the question from Professor Kulkarni from King's College London. So his doubt is, what if there is a dural injury, or do you had any dural injuries in your experience of past 3 years?
Yeah, that's always a very popular question, right? A dural injury, whether it's thoracic, cervical, lumbar. We've treated durotomies in the lumbar spine pretty successfully with minimal solutions, right? We've never had to open a case to fix a durotomy. What we do is pack an inlay of some dural substitute. We put it within the dura, and when the arachnoid is spared, it's an easy decision because the arachnoid pushes it out. But also without arachnoid sparing durotomy, you can put an inlay, put an onlay, and then squirt some dural substitute, some fibrin analog down that endoscopic channel. We've actually fixed spontaneous ventral cerebrospinal fluid leaks from the thoracic spine, and that technique is the same, right? That is docking in the same area, getting ventral to the spinal cord, identifying that durotomy or that hole through the dura in the ventral portion of the canal, and packing it. Sometimes we can take fat and muscle from the incision itself and pass it through the working channel and pack everything ventral to the spinal cord, and then squirt some fibrin analog through the endoscope, and that works very well.
Yeah, thank you, Sanjay. So that was so to answer, extend that answer, Professor. Usually the dural injuries are less common in thorax because of our trajectory. Our trajectory is so oblique. Whatever instrument we miss, it just goes into the space. First, second thing, though we do see in open surgeries that there is no plane between the osteophyte and the dura. But in reality, with the good water irrigation, saline irrigation, we always there is always a plane between the osteophyte and the dura. It's all we need to appreciate. So for simple way to appreciate it is go cranial or caudal to the epidural space. The moment you go there, you can pass an instrument and gently separate it from the dura. Then you start drilling again. So most of the time, because we are all the time going from below, it's not interlaminar surgery where we see the thecal elements first. It is the transforaminal approach where you are inside the pathology most of the time and you are reaching the theca at the last. So the chance of dural injury is less. Second thing, the biggest advantage here is the exiting route. As Dr. Saeed Usman talk we saw yesterday, the exiting route is always going cranial. So as a result of which the exiting route injuries are very, very less compared to the lumbar region. So this way the dural injuries are less, but if it happens, definitely yes, what Sanjay told, whatever today the dural substitutes we have, we can do it. If you have done a major catastrophe, then it's very unfortunate. Then we have to do accordingly, we have to act with no compromise on the outcome. So thank you, Sanjay. Thank you very much for the... yeah. So the last question asked was, what is that dimensions of the scope you use, which type of scope you use, angle and the working channel?
This scope has a working channel of 3.5 or 3.7 working channel, so it's an angle of 30 degrees, and we're able to put a 3.5 round drill bit in there.
Yeah, so we can use the same transforaminal scope or interlaminar scope because the distance from the midline is hardly 7 to 8 centimeter or sometimes 6 centimeter. So we can use the interlaminar scope also, the shorter one. So any scope which you use for lumbar can be used here, and all the same instruments what we use in lumbar, we use it here. So there's no additional. The drill is the key. The diamond burr, you should have a very good drill, and good RF is the key.
And when you start doing more of these cases, you soon realize that there's a lot less drilling and bone work you have to do in the thoracic spine compared to the lumbar spine. Yeah. So once you get the targeting down and you have a good trajectory, it's actually less work in the thoracic spine. You just have to be a little bit more careful.
Yeah.
Yeah. Hi, Sanjay. This is Naresh. Thank you for an excellent talk, as usual. One question I have, how frequently you do that 3D modeling for your thoracic cases that you keep posting regularly now? Are you doing for each patient before your pre-surgery?
No, not for each patient. Early on, we used to do it frequently, especially for the complex cases. If I get a complex case that I haven't done before, with some new considerations, I would. But recently, I haven't been printing it. What we can do is the 3D renderings, just the CADs on the computer, without printing it, and that we do pretty often, just to get a better idea of the 3D representation, the anatomy of what we need to do with the trajectory. But when we do print it, we have grants here, so it's no additional cost to the patient, and they actually get to keep their models. So it's the very least we can do for them to be our sort of guinea pigs throughout all this.
Yeah, that's a very good idea. Now in Indian markets, to get a 3D printed model of this case, for example, a particular case, it costs you around. A soft copy also. No, bone model is better always to decide for a beginner or for a early beginner, where you can. It costs around 15,000 now. So you can practice on it. You can practice on it. How much I need to drill before I can reach the pathology. You can practice how much I need to drill cranial caudal. So these things can be done on the model, the sawbone model. Now the 3D companies are there, which there is a stall here also. So you get a very good idea for especially case like thorax. Discs where you can plan it better. So to conclude, thank you Sanjay, thank you very much, and next time we hope that you are here and show your magic live someday. Maybe.
Yeah, hopefully, yeah. We'll make it happen.
So you block your dates for the next Spinoscope-2025. So maybe we keep a thoracic case for you, so you can operate live.
Wow, perfect. Okay.
Yeah, definitely. Thank you, Sanjay. Thank you. Have
thank you so much.
A great day. Thank you. Thank you. So we'll move on to the continue the talk which we were seeing. So moving from thoracic disc to thoracic stenosis, you see here the volume pattern. So commonest problem here would be the missing the level.
So simple way is preoperatively you tell your assistant to do a chest X-ray AP so that you can have a good ribs counted from whether 11 ribs or 12 ribs. It's always easy to count based on the ribs. So if you miss that, then it is a big headache where you have to count on table from below, from above. 20-30 shots are taken extra, and you might still miss there. So simple thing is you take a X-ray before covering the entire 12 ribs. Here, because I wanted to drill the entire facet laterally, so I just landing little bit lateral so that I can drill the entire facet joint so that to have a good decompression. I will knock off the entire facet inferior and superior and entire calcium in front of it. Medial to medial pedicular line. Just little bit lateral than routine entry. Yeah. Yeah, posterior upper. This is posterior. Right? Here you put a scope now, observing the level correctly, counting from ribs and counting from above down. Now we got a space here. So once you go there, obviously you will be landing here on the lamina because we are in the dorsal region. You will be on the lamina or some bone or facet. So you don't need to worry. But you need to understand, identify the which part of the bone. See, I am here on the left side here. I am standing on the left side. So that we can 9 o'clock is cranial. Understand the anatomy well. So once you go there, important is to see this chart. If you are seeing this chart, it means that you are in that space where we can just delete it with the bone. So the moment you see this space, you should be happy because the fat or removal of the fat, you see the bone. So that's the bone. You see the bone here. So once you see the bone, you just clear the soft tissue. Mahisha is standing here, so Mahisha will say some wisdom. Give mic to Mahisha. So you can just share his experience or his difficulties of a thoracic pathology. Why thoracic pathology should be attempted last by any endoscopic site. Thoracic is the one who should come last. So over to Mahisha. Mahisha, can you please put us right on your experience?
Thoracic is the most unforgiving part of the spine. Cervical or lumbar is much more forgiving than thoracic. Thoracic problem is the vascularity of the cord is very poor here, and generally when the patient comes, they come with severe compression or malformation of the cord. So even if you don't make a mistake, still you can end up with a problem that patient can have a post-operative infection or motor weakness, so which can happen. So that's why you have to be extremely careful when you're dealing with thoracic spine. And other thing is marking is very important because you can mix the level very easily. So that is another point. So basically here we have to identify this first. So you have to identify the lamina, the laminar edge, the caudal lamina, and the interlaminar window.
So whenever you get a bone,
thoracic spine, the interlaminar window is very narrow. So
whenever you get a bone, first walk medially so that you can.
The flavum extends far more down. So the craniocaudal extent of decompression is much more than what is in lumbar spine. The flavum extends much below the lower disc level. And you just cannot put a big keratin and do bone work. Monopolar is an excellent tool. Especially for operating a fusion case, it's a lot to create adhesions and targets. To get very good picture.
So I'm going more medially now. So I'm just going medially now. So just to cut this, clear the tissue medially, so that we can.
again, last time Mahesh gave a lecture, so how we can cut down the cost of endoscopic spine surgery. So definitely that has made our life very easy.
So how much money are you saving on RX?
A lot of money.
So maybe you should give me some money. So definitely, no, I don't really use much RX nowadays.
So Mahesha has left. Otherwise, Mahesha should have been given the royalty.
So RX I use only for antelope bleeding at the corner or over the dura.
So I'm seeing a bone, I'm just trying to see the lateral edges waving the lamina end. I'm just following the.
So you see that one vessel I coagulated just now, that denotes your pars there. That's a pars area. I'm just going cranially now.
Because now our team is doing more, so sometimes it gets bent. They use it as a dissector sometimes. So it might, it's only the tip that is breaking. Otherwise, you can use it for any long time. Cable is not a problem, so you can use it.
So you should always have a good quality cable and probe. So otherwise sometimes cable will be or the probe will be.
So
you don't have a problem.
So that's the lateral most limit. So that's upper end of the lamina. So that's lower end. You can see the lower end there. So now I got the lower level, the edge.
You find the edge of the lamina. So lamina, I am standing on the right side, so 3 o'clock is the caudal. So we are just trying to go to the lamina edge here. Here the interlaminar space is very narrow.
No, left. I'm on the left only. Yeah, I'm on the left. So sister is standing on my right. So it's a caudal end. try to take a shoot and VP also where you are comfortable, So once you define these bony landmarks, then you can start drilling. So just entire lamina, cranial, caudal, lateral facet, everything is delineated there. So you can just entire bone, what you are seeing there, you can drill. So there is no need to worry. That's the inferior facet tip. You can see the inferior facet tip at 4 o'clock. So that's the inferior facet. That's the inferior facet tip. So you can start drilling as you do in open surgery, the interlaminar surgery in lumbar. So we just see the extent we got, extent we got. So just take a shoot here so that here we will drill from lower pedicle. So I'll just mark it. So you start if you start drilling from here, so decompression will be from the lower pedicle. Show the radiology MRI, show the X-ray image. X-ray is not coming in the picture. X-ray, yeah. So you can see this is the upper level. So that's the upper pedicle margin. That's so that much clearance we can give with the single entry. What we drill, what bone we have exposed, we can entirely remove that. Whatever bone is there, whatever structure is there, till the fecal cut, you have to drill it. So there are various ways of drilling it. Once you make a cavity and then start drilling from inside, or you just spin it out, eggshell it out and remove it. That's the upper end of the lamina. Yeah, base of spinous process will be away. So once we go more medial, if it is coming in our way, same like lumbar, we can drill it to go to the opposite side. Here, no. Yeah, we use ventral compression is more I use, and if patient is already having some weakness, motor weakness, we use. But here patient had only sensory symptoms, so we didn't use it. Here thoracic, it is always difficult. So you are very fortunate. So because don't take any risk in periphery, patient kuch problem ho gaya, or you want to extend your time. Patient cannot lie down for more than 4 or 5 hours. So always suppose what if you need to convert it, you need to open it. So then again you have to make him supine, induce him and again do it. So prepare for the worst always. So backup nahi hai to mushkil hai. So you need to have always a backup plan. So God will help us always, but sometimes He say you are too daring, he might give us trouble. So always have that backup plan. So the more you drill, the moment you drill the facet, be on the facet side, it is more safer. Once you inferior facet is completed, you get the cartilage. So then you get a superior facet. You can see nicely. From there, it is very easy. So once you see the joint cartilage, from there things becomes very clear. So I'm just getting some. You see here, once I drill the that's a joint cartilage which is calcified there. So I'm just, we can drill that so that we'll see the tip of SAP. So you can so once you, because here patient also had some foraminal stenosis, so I went a little bit more lateral here. Otherwise, I would have not gone so lateral. You see the complete superior articular facet now. So I'll just go cranially further so that the tip of superior articular facet is nicely seen, and the foramen gets opened up there cranially. So just think as a transforaminal surgery, how the anatomy looks like, or interlaminar anatomy. So we just want to, so that's the end of inferior facet, and you drill further cranial, it is lamina, upper lamina. Now you see there, that's a tip of SAP, that's a tip of SAP. So that's a yellow ligament medially which is calcified. So that's upper lamina. So remaining upper lamina, I am drilling it now. So we had thinned it before. extension and using the oval burr. You allow the sharp edges of the burr to cut. Don't use force. You just keep it on the bone. Allow that bend to work, bend hit to work. You don't use your force. Otherwise, you might have a lot of devastating problems. Especially here, you plunge inside already compromised cause of the Mahesh has said already, compromised cause you will injure. So now we are just, you notice one layer of the bone has been removed. We have think it like a sandwich. So now we are just partial. So you can see the three layers here. You see the descending facet or inferior facet, the cartilage, and you see the ascending facet or superior facet. So we have these three layers of the sandwich still here. So all I am trying to do is go cranially. Beyond the tip of the proceeding. You can see here that the cartilage ending here. You can see the tip of SAP now. And the calcified yellow ligament. You can see the calcified yellow ligament. So I am drilling on the lamina, and anyway ligamentum flavum is calcified. You see there, that's a ligament ending there. So now I am drilling the base of spinous process. That's the base of spinous process I am drilling. So that's a base, that's towards the opposite side. So that's towards the opposite side. So first we just want to, so I'm just going inferiorly there. So entire ligamentum flavum there with the underneath the lamina is ossified. So I need to remove that entire ligamentum flavum ossification. So that entire thing is ossified ligamentum flavum, you can see. So you can use accurate, you can for I'm just thinning it out till the soft part of the ligamentum flavum comes. So So if you can do a discectomy this way also. Knock out the entire facet. From there you just go and remove the disc. You can do thoracic discs which are not hard, soft, this way very easily. Interlaminar. Because you are lateral to the sac, just go there and just remove the disc. So it is easy. No need to fix because you have not done anything to the interspinous area. Opposite side you have not done. Rib cage is always there. So entire facet joint is knocked out. Nothing happens in thoracic. That's the biggest advantage. Unilateral, yeah. So that's a big advantage here. Now you see the inferiorly the facet lamina junction inferiorly, same as we do in stenosis surgery. I have done it. So I'm just creating the space inferior lamina to be more visible there. So anatomy understanding is very important. Once you understand this, it's very easy to do. It's any other surgery, only taking precautions not to damage the cord. So that's the inferior lamina edge. So you got entire bony picture now. So we can just work around that place. So now you see that that's the entire lower lamina. So you can just drill a bit of it so that lower lamina also, as Mahesha was telling, the ligamentum calcification has extended lower level. So I'm just trying to remove that superficial layer. You can see the calcified ligament. It's very hard, very firm. I am just extending. Here you can use upcut also once you open, but thinning out always helps you better because you can use a number one kerison rather than using a bigger kerison. So lower lamina, so upper lamina we have gone and till the ligament attachment you have done it. Yeah, we are on the left side. Abhi nahi gaye sir. Once we remove this, then we can go over the top. Here because there is a severe stenosis, opposite facet drilling is also important. So that's
here,
so first we
upper
remove
lamina
this.
and lower lamina and interlaminar space are clearly seen here. So this is the lower lamina. This is upper laminar edge. Curate. And that's a small interlaminar window. So this is a small interlaminar window and that's the edge. Upcut is so chin upcut. Chin upcut. Blue color. Isko manna drill.
So now I'll just drill at the edge because I know
So
the
this
edge
is
is
the edge of the
safer.
hole.
So anyway, ligamentum flavum will be there anterior to it. I'm using the belly of the burr. Don't use the tip, the front side of the burr. Always use the belly of the burr. So you'll be safe. here the chance of plunging is there, so be very, very careful here. So you will be shown to, in the entire 2 days conference, you might have seen yesterday and today we have recorded almost 8 cases or 9 cases where you will see all the recorded videos. We have not edited much so that you thin out the bone, anything. You can just remove that. You can pause anywhere and ask the questions. You can ask the questions. We'll pause the video. All the seniors will be there. Myself, Mahesha, Dr. Pramod, all other seniors will be there. Curate. So you can ask questions to anyone. You are all most welcome. This conference is not about showing who can do what. The conference is all about learning the basics of drilling, the concepts of endoscopy, what all can be done. Drill. So now I got an edge here, so I keep on going on the edge. So you see the edge of the bone, I can see the edge of the bone, so I can go to on the edge. We can use upcut, but safer is the drill. As Mahesha said, you need patience. So all it takes 10 or more minutes. If you worry about the cord below, you can use a upcut, a small upcut, and remove the bone. So I just thinned it out further, curate. So I'll just use a curate here going because already we have thinned it. I am going cranially, that is the end point, so I am going cranially till the lamina is removed, so that's just growing cranially. So the last bit of it is there. So once I do that, upper drilling is over. You can see here already that ligament is, I am using a small number 1 kerrison here. It's a very small kerrison. Thin, to remove the thinned out bone, it's very good. So till now, any doubts you can ask. You can see the epidural fat there. Oh, correct. Obviously, there will be some bleeding because of the canal stenosis here. As Mahesha said in the morning, always if you anticipate bleeding, so first coagulate and then use a kerrison or a cutter. Otherwise, you will struggle. Also depends upon your fatigue. It is always safe, no? So medial you go, so sometimes the ligamentum flavum might be calcified, sometimes might not. So if it is calcified, you don't know. If ligamentum flavum is also ossified, you don't know where to end. You keep on drilling, there is no plane between the bone and the ossified ligamentum flavum. You keep on going, suddenly you enter the thecal sac. So the ligament has ended there. The moment you see the superior facet, you know the depth. So that is the level of thecal sac. You know from here on I should be. Yeah. So because the anatomy we are not sure, so always start lateral. So now I am using the regular kerrison because laterally it is safe. So now I leave some cuff of bone and ligament laterally because I want to drill still further. Here why I did this is to know the extent, show you the extent of ligament attachment, where it ends. So it ends cranially just as any other lamina. You can see that congested vessels because of the epidural congestion, because of the stenosis. So now you know that cranial extent is done. So then medial lateral has to be dealt. So once you get this, you are good to work all around with either small upcuts, because you thinned out the bone.
As Dr. Lokande said, even in lumbar also, don't drill anteroposterior. Your drilling should be always sidewards, either towards cranial or towards caudal or towards your side. Even if you slip, so if you're doing a drilling like this, even you slip cranially. If you drilling like this, you slip caudally. You are drilling like this, you slip towards yourself. But when you drill like this, you slip, you go deeper. So always try to make a habit of drilling from the belly of the drill bit. As a neurosurgeon or an open spine surgeon, we have a habit of drilling like this. So that is very dangerous. That's why you want to see the edge of the bone is you can start drilling from there. In MIS surgery or open surgery, whatever bone we see in MIS, sometimes you don't see the edge of the bone. You start drilling the bone, go deeper, then use upcut and start removing the bone. So there it is okay because you have a two-hand control. Here you are using one hand, it might just plunge. So that's a trick, always use sideways. So the side of the burr is always to be practiced.
Saline entalo undra? Entundi. So I just checked because you opened the epidural space. I checked with my technical team. So that's inferior lamina.
So upper is over, though I'm coming to the inferior.
Medial summit of the inferior lamina.
Sai, increase the volume, Sai. Volume increase.
Upcut, kerison and remove it. But I'll just thin it out before we do that.
So that is cranial. That is cranial.
Then we'll start removing the.
So this is caudal.
Bone.
So I'm just still using a drill to thin out till that disconnection happens.
So this will conclude our pedicle to pedicle decompression craniocaudally. So I just thinned it out so that I can use up.
So now I just removed that entire ligament now. So the entire ligament.
So as I said, this is important bone we need to remove. You can see here there is a tough.
So that's a remnant SAP there. So that's a remnant SAP. So you just remove that
drill,
SAP.
You can use a chisel.
You can see already the lateral edge of the thecal sac there. So go laterally. Just see now I'm not at all handling the cord. I'm just away from the cord. So trying to remove the bone. So this much lateral we have come. So if you have any disc, lateral disc.
You can see I'm just creating a more space laterally so that I can go around the bone rather than pushing the cord. So I can just.
So now I've just removed the entire SAP bone now till the inferior lamina. So you can see now the entire
the
thecal sac
opened up nicely.
Now I have to go to the opposite side, which is more critical here. The opposite side is a more critical part. So I've done the ipsilateral part here. Dr. Rakesh, I've done the ipsilateral part. Removed the superior articular
ipsilateral hemicord nicely decompressed. Cure it. Now we'll just go to the opposite side once I remove this a bit of ligamentum flavum. And then
Lamina.
I'll go to the opposite side.
Yeah, it's obviously the lamina is very short. There is no to proper.
Yeah, and just I to use
just land there.
upcut. And so Mahesh's question is just how inferior we have gone, whether we is gone till the shoot.
See, you can see there. I'll shake a shoot and show you how much inferior.
Gone till the inferior pedicle, inferior mid half of the pedicle. So this is what we want in any decompression surgery, good cranial and caudal decompression.
So now inferiorly we have gone beyond the pedicle here. So that should be enough because we are seeing nice fat there. So we'll go now to the opposite side.
Show the X-ray. That's the lateral extent. You are seeing the X-ray. That's the lateral extent.
So that's
what
where we have gone.
So from cranial, I'll just show the cranial extent now. How much cranial we have gone. Shoot.
That's
so
the cranial.
Till the pedicle,
so
upper
pedicle to pedicle
we
we have done.
Now we have to just, we have thinned it out, already they thinned out the opposite.
So now we can keep drilling the base and go to the opposite side. See, now I rotate the scope.
Naresh ఒకసారి నరేష్ కాల్ చేసి మహేష్ సార్ని డ్రాప్ చేసి రావాలి రాజు డ్రైవర్. So now we have thinned out the opposite now, just like our over the top technique, because we have thinned out the bone. We are going to the opposite side here.
That's the opposite thing we
are
need
going to the opposite side. So we need to drill a little bit more. So I'll just.
You see the sheath should be always floating, never plunge here. So this entire thing is coming in my way, so I'll just start drilling this. This is the opposite lamina. It's opposite lamina. So that's opposite lamina.
Drilling the opposite lamina here.
After this, you can use a chisel or drill or upcut. So it's up to you. But drilling this part is very crucial to have a good opposite side decompression.
Flexible articulating the.
You can see that entire opposite calcified facet capsule I am just drilling. That's the opposite side ligamentum flavum. That's opposite side ligamentum
You can
flavum.
see this is opposite side ligamentum flavum, ossified ligamentum flavum. So just drill the opposite side now.
Hello. So here the crucial part is inferiorly. Again, you have to go till the facet lamina junction. So that has to be exposed properly. So I'm just going down. That's the entire yellow ligament, which is ossified anterior to the facet. So we are just drilling that bony part.
So that's, you can see that that's a bone ended there. So I'll just It's opposite inferior lamina.
Don't get confused if you are not able to understand the anatomy. Just drill whatever you can.
Same.
Whatever bone you see there, you just drill it. So that's the inferior lamina joining the opposite lamina. So you have gone till the inferior part. So all you have to detach this ligament. Once you detach this ligament.
So I'm just working at.
So after just this 5 minutes, we have a talk by our colleague where he will be talking on very basic, very common topic, how to use the intricacies of using the instruments. So that's just for 5 minutes. Our colleague Ishwar will tell you.
Calcified
and
or
if
ossified
anyone
part of the
interested, because lack of time, there is ergonomics of endoscopic spine surgery. How surgeon suffers. So my colleague is a sports medicine specialist. He will show at what position, how am I doing wrong things. He has taken all the photos and he will show you what we as a surgeon are doing problem. So how we can correct it. He is an excellent science man on that position gate. So just 10 minutes, 5 minutes each talk, so that then we'll end the session. This is over. Why I am just running this is Dr. Rakesh asked, that's the opposite side, Rakesh. So that's the opposite side facet which is calcified entirely. So if you don't remove that part, patient will have the opposite recess stenosis. So that's the Suresh is here. I think Suresh should comment about your experience also. Suresh. So because Suresh also started doing thoracic now in his country. So come Suresh here, you can come here. So where just Suresh can talk about his one or points had
detaching the ligament
experience.
So basically how I approach exactly like how you approach Dr. Sukumar. First is clearance of the lamina, both upper and lower lamina. Make sure your bony landmarks are identified. In thoracic especially, you need to get a good bony landmark identification. So once that is done, because here we know the interlaminar space is very, very narrow. So the drilling and the surgical techniques are basically same as what Dr. Sukumar is doing. So here, the entire operation, I like to use only diamond burr. I don't use any cutting burr. And one thing we have to be very cautious here is use of the RF. When the dura is exposed, so control the use of RF. And the other thing is I don't use pump pressure in thoracic spine, only the gravity assisted water irrigation.
So that's the opposite calcified medial part of the facet. I'm just, you can see I'm leaving the cuff of ligament and drilling. So that gives you a safety.
I remove the ligament is because this is a this is
so
the
you can
most
see that's a
important
bulge.
part
So
to remove.
very important. You can see that Rakesh. You can see that that's a medial bulge which push the thecal sac. We see in the MRI the thecal sac becomes more triangle and more conical. So this is a one which the bulge around
What I
the
do
facet.
is here, I just drill like this, disconnect it, then you can easily do it this way.
So that's why instead of going over the thecal sac, I am carving around it.
Out the
So,
facet there.
yeah.
And keeping this ligament as a cushion. I am using this ligament as my shield.
It's always safe. So,
Right there. So, yeah.
Even you plunge there, it's nothing there laterally. So, lateral to the root there. So now you can just use a curate and just push it outwards. So
release it, yeah, yeah. Yeah, so Mahesha says you go over the pathology, then it's always safe. Otherwise, you might injure.
So that's a IAP. Deeper you see the SAP, and this is a one which is protruding inside. So medial to the
just
SAP.
This part is there. I'll drill this. Then we can use a chisel or.
So this is very important part on the opposite side.
So this is very important. Operating half side is not the complete job.
So you can see nicely it is disconnected.
So what I do, once I thin it out, I use this.
So now you can see it moved now. So it just came out. Yeah, you can use, but you don't know how much lateral the fecal sac is still going. So once you remove this and you get a vision,
seen there,
and you are sure that there is nothing, then you can put it.
Facet. So this is a tip of the superior facet. So just go inferiorly. So you just check for the space. I have some space here. So here two things, because laterally there is nothing here. I use a chisel. I use a chisel here.
Now I use a chisel here.
Just try upcut first. Upcut. So I go inferiorly first here because I have some space. Then I go as lateral as possible.
So this is the advantage of thinning.
That's the part which we wanted to break. It is breaking, so you are fortunate here. Cord, yes. So most important step is not to press the cord. Use as less manipulation as possible. You can use a RFE. Osteotome also.
You can see that's the lateral edge of the fecal sac now.
Easily.
So, but still I am not happy cranially. Still there is some.
I am using a monopolar, the bipolar also very less here. Upcut. So. Here having a important carisons, also very important. I am just going now laterally now.
So that's
this is lateral to the root. You can see that's the lateral to the root, but we need to remove this bone.
That's a SAP.
That is the lateral edge of the root.
Overhanging. So that's a SAP is overhanging there.
Now I can use a chisel.
So I just use a chisel to chop off the.
That's a tip of your SAP. So this is a chisel I use here. Angle is such that. So we have not. We will not miss. Even we miss if we will not touch the cord.
So now you can see a good space.
Creating more space laterally is very important. Carison. So now we have just done.
So you have done a SAP tip removal. So
big one.
So that's
see now how much space we have created on the opposite recess nicely. That's the upper foramen. I'm going to the upper foramen there, removing the bone, creating space for the opposite foramen, because here in MRI you see there is a bilateral foramen narrowing. I'm just trying to create the space to the opposite foramen as much as possible. So this much you should do to have a good decompression bilateral. So you follow the principles. So thoracic can also be done easily. Main problem is the missing of the level. So that's the opposite disc. You want to remove the disc. So that's the opposite side. Go in and remove the disc there. So opposite entire opposite disc. There is a 2 mm space lateral to the thecal sac. So nicely decompressed opposite side. So that removal of that facet is very important. And small spike there. Yeah, that I will remove. Yeah. So that small spike is removed. So now we are done with our job here. So that spike is removed, so entire thecal sac. Then I just come inferiorly a bit, just a base of the ascending facet and the inferior lamina. Just do a foraminotomy inferiorly. So sometimes and then we are done here. I call this a surgeon itch. You have done a good job, but still you want to do something more. So you should always know where to stop. So if you think you have done a good job, inferior part you can don't good unglify. I call it.
Being a neurosurgeon is difficult. Orthopedic would have stopped by now.
Yeah. So this you should always stop. So you can see the opposite inferior. So that's this is opposite inferior. Same like opposite side we have done here. Then cranially again take a shot. So opposite cranial, again opposite cranial, we have gone till the upper pedicle. So we have done a good job here, cleared bilaterally, so patient should be happy. You follow the basic principles, land laterally, that is a key, then you can go all around easily. So you are safe, even you miss, you are in the disc only laterally, and that's the superior facet below, so you are safe. So that's a take home. So thoracic can be done easily, single level, 2 levels can be done. Initially it takes some time, but you have patience, we can do it in 1 hour. So you can see the operating time below, because the demonstration time, it's 1 hour 45 minutes. So 1.5 hours we can do 1 level easily. So that's a end point. Thank you. So next talk, just bear 10 minutes with us. 2 simple talks. One is by Ishwar, is an excellent surgeon, endoscopic surgeon from Vizag. He started doing since 3.5 years. So his talk is very unique to, very important to the beginners. So how to hold out the, use the instruments, how to, you can see the scope, how to hold the scope, how to use it. So very important points for a beginner. So over to Ishwar.
Good evening everyone. Thank you Sukumar sir for this opportunity. Actually my talk has been covered extensively from yesterday. Almost all the points Sukumar sir and Mahesh sir, they have emphasized how to hold, and the entire total things here they have already explained in detail. So my talk is just for the sake of completion. So a successful interlaminar endoscopy, it requires a precise handling and manipulation of the scope so that you can minimize the tissue damage and optimal visualization. So key aspects of holding endoscope, like stability and control is the first, then visualization of the targeted tissues, and tissue manipulation, and instrument coordination with the scope, and ergonomics of and surgeon comfort. So holding the scope, you have to hold the scope and working sleeve together, and you have to move both working sleeve and scope together, and you use the thumb for zoom in and zoom out. Visualization. Always adjust the angle of the scope to the, such that the target point should be in the middle of the field. Yeah. Also look the tip of, always look at the tip of the instrument before catching any tissues. So working sleeve can be used as a retractor, working sleeve can be used as a retractor, avoid pressure on surrounding tissues, and adjust the scope so that your target area should be in the middle. Sometimes we can retract the theca like this. But nowadays we stop doing this retraction with the sleeve because of this many root injuries are happening. Then instrument coordination. First see the instrument, then catch a tissue or cut the tissue, whatever. Especially with the sharp instruments like knife or cutters. While using the burr, always stop the burr before you take out, otherwise you can damage your scope. Always assess the tissue amount before removing through the working channel, otherwise your scope may get damaged. Like this, whenever you are removing the bone with a kerrison, sometimes it hit the lens of the scope and it can get damaged. Ergonomics, so monitor should be at the level of the eye or just below, and the table should be below your waist, and so that you can hold the instruments like at elbow at a 90 degrees. So if you're use a adjustable height table or use stools. So mastering the scope is at most important for safety and efficacy of surgery. It comes with a more practice, so it can't be learned in a 1 or 2 cases. Every day it is with every case you evolve how to use the scope, how to reach the corners, and how to use the instruments along with the scope. So for that you also need to attend more training and more practice. Thank you. So next speaker.
Good evening, everyone. I'm Dr. Suman. I'm a sports medicine physician. I'm sure you all have had a lot of knowledge shared about endoscopic spine surgeries over the past 2 days. I come from a background of kinesiology and biomechanics of spine. So I work at Asian Spine Hospital. So I work on the basics of spine biomechanics a lot. So ergonomics is the scientific study of people at work. It's how you adjust your posture to improve your efficacy of your work, productivity in your work. So it's how often we actually ask patients who are into IT sector or anybody who sit in front of the laptop for a long time. We do ask them questions like, what is your posture? How do you sit? Especially when it comes to athletes, we do ask this question: what is the position you play in, or what is the which hand dominant are you? So we do all these. We do take history of all these before even setting up a treatment plan for any patient. So poor ergonomics is a common knowledge that poor ergonomics can lead to work-related musculoskeletal disorders. So my goal here was only to speak a little bit about posture and give you a solution of certain exercises. I'm not saying those exercises are the ones which you should be doing regularly, but those exercises will help, especially when it comes to endoscopic spine surgeries, because I looked up a little bit of research on what are the challenges which spine surgeons face. So what I understood was there was prolonged static positions for longer time, when looked up on research with open versus endoscopic spine surgeries, open definitely there was more movements like flexion and extension of the knee, neck, but then when in endoscope definitely there is too much of isometric loading on towards the neck muscles. So either it is repetitive nature of endoscopic tasks like instrumentation manipulation, or for that matter precision of skills, you need to keep doing it again and again. I mean, over the past 2 days I've seen surgeons holding the scope with the left hand and manipulating it for a very long period of time. So beyond physical strain, definitely there is too much of concentration and focus, which will lead to mental fatigue as well. And one most important thing is prolonged weight bearing in a very odd position. So usually when we stand, our feet position should be slightly in parallel to your hip joint. But I've seen this a lot, that we stand on towards one side of the leg, one side of the weight bearing towards one side or the other side with respect to their dominant side. So in this picture, when I actually took this picture, I can see there is too much weight bearing only onto the left side of the hip joint, and bilateral shoulders are definitely not in the same line. And if we see the distance between the neck and the tip of the ear is slightly, definitely more than compared to right to the left, because here the neck is going into left flexion and towards rotation towards the other side, because the screen is placed on the other side. So this definitely causes too much of eccentric load on the right side of your sternocleidomastoid and scalene muscles, which can definitely lead to neck pain. And because there is too much of weight bearing on the left hip joint, your glutes and your IT band can definitely go into tightness. So these are the things. And if you see in this next picture also, the way the scope is being held with the left hand, there is wrist flexion towards the ulna side, and if you can see the thumb, it is hyperextended. So those particular muscles are definitely at load when this has been done again and again over a period of time. So with taking all these into considerations, our team have formed a set of exercises. I would not say those are the exercises you should do it, but then if you do it, definitely it will be helpful. So my friends who are already doing regular exercises can also start doing this, because these exercises focus on a very small muscles. If you go to the gym and start doing your regular exercises, you will focus on the larger group of muscles. But these exercises you can actually focus on smaller group of muscles as well. So this is a ergonomic picture. My friend in the previous talk has mentioned it. So this is the first exercise. If you see, there is stretch. We do stretching of levator-scapulae and do the stretch for about good 10 to 15 seconds, and then slightly turn your neck towards one side, and then do a flexion which will stretch your upper trapezius as well. So this is a foam rolling exercise. It's very good for your thoracic mobility. Usually this video has 3 levels of exercise. One is this man is just keeping his foam roll at a certain level of vertebra and just holding it, that's all. You can do it at each and every level of vertebra, one. And then a neck flexion and extension will definitely cause a lot of mobility in the thoracic joint as well. That is the second exercise. Then the next one is complete rolling of the foam roller throughout your back, which definitely gives relief to your superficial muscles, which is erector spinae. But you guys should try doing this neck extension and flexion. Definitely you will have a lot of relief. So this is the exercise in the left side is more for a position of your scope holding, because most of the muscles come from your scapula. So scapular stabilization is very important. So do scapular retractions like a wall push-up. It is very helpful. And if you see the video in the right side, so he's pulled it and he's holding it. So holding isometric for a very long time definitely will strengthen your isometric strength. And then do a shoulder rotator strength. It is essential for your scope holding positions. So this is a wrist joint exercises, all the flexion, extension and mid-prone variations. And if you see that picture with the dumbbell on the right side, he's just lifted the dumbbell and he's holding it, that's all. There is isometric force in your forearm muscles. You can lift a 10 kg dumbbell, do 10-15 repetitions and go away, but that thing won't help in maintaining your muscle endurance for a longer time. Might as well do this something like lifting a heavy weight, whatever it is a 7 kg dumbbell. You can choose a 10 kg dumbbell or 15 kg one, but hold it for a long time. Build up muscle endurance in that. This is stretching for your lower limb muscles. I would say start training your legs every day, because long-standing job definitely needs muscle endurance in the leg muscles. So stretching and strengthening, because of the abnormal posture we have, weight bearing towards one side, foam rolling on towards that side will be very, very helpful. So when I said leg strengthening, keep it very simple. I have kept it very simple in the slide, but you can as well do heavy exercise as well. But these are the simple exercises in the legs which focus on glutes, which is hip extension and which will strengthen your glutes. And then this is an isometric wall squat. I'm sure everybody in our growing age would have done as a punishment in schooling. But you can keep your hip at a slightly higher height, or if your knees are stronger, then you can do a much more knee flexion also. This strengthens your quads, hams and glutes all together, helps you in better weight bearing. This is one exercise, very simple, very common exercise, but good strength for your hamstrings and glutes muscles. This is very neglected muscle groups, which are calf and inversion and eversion of ankle and plantar flexion and dorsiflexion. You can use resistance bands. It is very simple to do it. I keep listening from a lot of my friends that we don't have time for exercise, but all this will take hardly 10 to 15 minutes. So you all can plan it and do it accordingly. If you have any further doubts, you can definitely ask me. Thank you. I would like to thank Dr. Sukumar sir to give this opportunity, and I would like to thank my team of endoscopic surgeons also. It is who actually they came up with this idea of ergonomics in this talk.
So
Thanks.
After Suman joining us last talk, our champion who is a pinch hitter. Dr. Suman joined us 2 years back. After Suman joining our team, the entire outlook of our patient gait management has changed. So we got a lot of ideas. He's not a physiotherapist, he's a sports medicine. He did MBBS and MD sports medicine. He's the first sports medicine MD in India. So he the one who is making protocols. Now he is proposing Sports Authority of India to have a screening before taking any person to sports. You want to send your kid to school and you want to pursue some sports, professional sports, that kid need to be screened first whether he is fit to join that sports. Then they should join the sport. Otherwise the kid might have injuries, they might be injury prone. So he is proposing that guidelines. Thank you, Suman, excellent. We always ignore our muscles. So thank you very much. So last but not the least, Daibate will talk us about how to decompress the disc in a simple way, interlaminar approach. Over to you, Srikanth.
Thank you very much, Sukumar sir, for the opportunity. First of all, good news is that this is the last presentation, so it's my responsibility. I won't take your much time. So the presentation is about the central disc prolapse. So let's start with the history. So he was a 34-year-old male patient. He was having acute onset back pain and severe right leg pain since last 5 to 6 days. So he was having perineal numbness as well as the ball bladder involvement. Right TA was weak. So if you look at the sagittal images, there is a massive disc prolapse, massive extruded disc prolapse, which is pushing the dura literally dorsally. And if you look at the third image, there is also a global disc prolapse in the center as well. So this is the axial images where you can see there is a central global disc bulge with the right-sided annular tear, and there is a huge central disc prolapse which is more towards the left side. If you give closer attention to the details, and if you use the zoom in technique, you can see here the extruded fragment is not soft, the extruded fragment is hard, whereas the global disc bulge which is in the center is soft. So if you see this X-ray, interlaminar window is very narrow. So depending on these things, the plan of action would be the right-sided interlaminar endoscopy in this patient. So we are going to do bilateral decompression, because the idea is that in central disc prolapses, as the dura is pushed dorsally and the roots are pushed dorsally and laterally, you have very little space to maneuver. So the idea is to create the space lateral to the dura so that you can reach up to the disc without even touching the dural sac. So in this particular case, there are two components. One is the extruded disc and second is the global disc bulge. So in this particular case, we have to manage both the things differently. So what are the challenges in this particular case? The first challenge itself is the central location of the disc. The central discs, they are very difficult to remove. There are very high chances of neurological deficit because of two things: because of the direct injury which may happen during your surgery because of the sharp instrument, and the indirect injury which may happen because of the undue retraction of the nerve roots. And the third challenge is very high incidence of the residual disc. So let's see how we can do the surgery in a better way and how we can prevent these complications. So the usual steps, they are same. We land at the laminofascial junction and do our bony decompression. So for the orientation, 3 o'clock is cranial, 9 o'clock is caudal, 12 o'clock is medial, and 6 o'clock is lateral. So these are the landmarks. This is IAP, this is the superior lamina, this is the base of the spinous process, and this is the inferior lamina. So there are two ways you can start doing your bone drilling. Either you can start from superior lamina, go downwards to the inferior articular process, or you can go downwards and then above. So after drilling the inferior articular process and superior lamina, now you can go to the opposite side, because our plan is to do bilateral decompression. So this is what I am drilling, the base of the spinous process and opposite IAP. So after drilling the upper part, now it's time to drill the inferior articular process. So by doing so, we are creating the space all around. At the same time, we are not manipulating the structure, because you know at the dura is pushed posteriorly, so there are very higher chances of neurological injury here. So once you have drilled all around, now it is one of the easiest step is to remove the superficial layer of ligamentum flavum. Once you remove the superficial layer of ligamentum flavum, all the bony landmarks, they become very clear and your further surgery becomes very easier. So here I am removing the superficial layer of the ligamentum flavum. So now there are two ways you can remove the ligamentum flavum. You have removed the superficial layer. Now there are two ways you can remove the remaining ligamentum flavum. Either you can remove it in en bloc, or you can remove it in piecemeal. In this particular case, I don't want to go from the center, so I decided to do the piecemeal ligamentum flavum removal from the shoulder area. So shoulder area is a virgin area where there are no neurological structures. So in this particular case, you can start removing the ligamentum flavum from the shoulder area and then come down in the lateral recess. The remaining ligamentum flavum, you should use smaller diameter instruments or less traumatic instruments like the tube sheath punch. You can remove the entire flavum with this instrument without any damage. So this is what we are removing the ligamentum flavum in the lateral recess. You can already see the lateral border of the thecal sac here. Even at this side also, we haven't even retracted the dural sac medially. So after doing the bony decompression and flavum removal on one side, now it's time to do the bony decompression on the other side. This is what I am doing: contralateral decompression and removing the ligamentum flavum from the contralateral side. Again, at this stage also, we haven't manipulated dura 8. So now you can see I'm just moving my dissector and trying to retract the dura medially, but it becomes very difficult because of the huge underlining disc fragment lying there. So there are two ways. Now if you are using Spinoscope for this surgery, just see this video. It is highly impossible to rotate your working sleeve, which is the usual way to retract the structures medially. It is very difficult to rotate your sleeve, rotate the dura medially. So in this case, what I would recommend, to debulk your disc material first and then try to manipulate the dura. So there are two ways how you can debulk the disc material. First, you can use this type of the nerve hook retractor, which you can put inside and use instruments on the other side. What personally I do in my cases is that I use the tip of instrument as a retractor. So this is the cutter which I am using. The blunt side which is retracting the neurostructure medially, and the sharp side is removing the doing the annulotomy. So you have to always remember the tip of sharp tip of the instrument should always be under vision. So after you have done the annulotomy, it's time to remove the disc fragments, even again without retraction of the cord, because you know there is a big structure lying underneath. So I am doing the discectomy here. I am removing the fragment, whichever possible I am going to remove it. So you can use this type of hook and to manipulate the disc fragment from medial to lateral. So what I personally do, once I remove the sufficient amount of disc material, once I debulk the disc material, I exchange the scope from Spinoscope to discoscope. So there are two advantages of using discoscope. The first advantage, the working sleeve is smaller, so the chances of neural injury due to retraction are less. And second, the angle of inclination, that is the angle of viewing, is more, that is 30 degree. So you can see beyond the midline with the help of the discoscope. So now you can see after replacing the scope, I can easily rotate neurostructures medially and do the remainder of disc material. I can do discectomy here. So here I did the remaining discectomy has been done here. So you can see always in young patients, the disc fragments, they are does not come in one piece. So always there are multiple disc fragments, and as we already seen on the MRI, the disc fragments were hard. Even you can see here the disc fragments are not soft, they are hard. So now we have tackled one thing, that is the excluded disc material. Now the second most important is we have to tackle the global disc bulge as well. So you know that if you don't remove that global disc bulge, patient will come to you with the recurrence of symptoms. So here I am removing the hard annular hump which is lying there towards the below the traversing nerve root as well as in the center. So in some cases, like in this case, the disc material was very huge, the sequestrated fragment was very huge, so I have to go from the axilla. For that you have to burr little bit of more inferior lamina. You can create little bit of space in the axilla, and with your smaller instrument you can go beyond the midline and remove the remaining fragments from there. So this is again one important step. As we already seen in the MRI, there were few soft fragments lying inside the disc, so it is also important to remove those fragments to prevent the recurrence. So in this particular case, there was a global disc prolapse. So you have to go to the opposite side and do the discectomy as well. You have to do annulotomy on the other side. So I have done annulotomy, contralateral annulotomy from the same incision. So this is sort of the final decompression. You can see here the cord is completely free. There is no disc lying underneath. You can see the opposite side also. It is also completely free. This is the post-operative MRI. Compared to the pre-operative MRI, I think it looks satisfactory. This is the axial MRI. There is no fragment lying there. So the contralateral as well as the ipsilateral decompression is adequate. No fragment. Even the global annular bulge has gone there. So this is one more case. Central disc prolapse. I did interlaminar endoscopy in this case. Huge central disc with literally a banana type of cord. This is immediate post-operative MRI, and this is MRI after 3 months. One more case, pre-operative MRI shows huge disc, central disc. Then again interlaminar endoscopy was done. This is immediate post-operative MRI, and this is MRI after 3 months. Thank you very much.
Thank you. So Dr. Suresh from Malaysia wants to show an interesting case of thoracic 3-level decompression he did last week. He wants to show some intricacies because we showed a thoracic case. He just want to show this interesting scenario. Over to you, Suresh. Correct you. So excellent, Doctor. For Srikanth talk, we are dealing with a soft central disc. It is very easy. Interlaminar, you drill little bit laterally, go and remove, no problem. But if it is a hard hump or a firm hump, then we face challenges. What happens? When you are lifting the bone, the disc is not negotiable. So the pressure falls on the root or thecal sac. You start lifting the thecal sac with the bevel like this. Out from inside, you don't know how much you are lifting, but you are lifting almost like this when you are working in the midline. So what happens, the medial roots, that's S1, S2 roots, they're under tremendous pressure. So post-op patient can have a S1, S2 weakness, especially the inverter, reverter weakness. Subtle weakness will come if you ask them carefully, they will say they will have inverter, aorta weakness. Second thing, they will get a lot of paresthesias. When we are dealing with such central disc, when disc is very hard or you are using chisel, when you are using chisel also you tend to retract the thecal sac much. So simple measures are, you drill more bone, a little bit your lateral, then your entry is more oblique, little bit into the midline, so getting pressure on the thecal sac less. So these are few tips need to be followed for a firm central disc. Thank you. Suresh.
Since we have seen a video just now, surgical steps, I just share a few of the cases that I've done. This is a 35-year-old male weighing under 10 kg, progressive weakness of bilateral lower limb with numbness more than 3 months, which was worse past 2 weeks. And when he came in, he was on wheelchair, power, both lower limb 3 or 4. Bowel bladder intact. The problem was ossified yellow ligament at T8, T9, T9, T10, T10, T11 with spinal stenosis. So for this patient, I did a 3-level stenosis decompression. Took me almost about 5 hours. And post-op, the patient did well. So this is the MRI. The CT scan, axial cuts. So this post-decompression T8, T9. Well decompressed on both sides. T9, T10. T10, T11. This is the one more case, 51-year-old male, bilateral lower limb claudication and numbness, left more than right. Problem 2-level, T10, T11, T11, T12. So 2-level decompression done. So these are the pre-op CT scans and MRIs and post-op CT scan and MRI. This is another patient, 55-year-old male, progressive left lower limb weakness, more than 4 months, worse past 2 weeks. Left lower limb muscle power of grade 3. And this patient at T11, T12 with myelopathy. So those are the pre and post-op, and video playing that well decompressed spinal cord. This is another case, 54-year-old female at bilateral lower limb weakness more than 2 years, and past 6 months unsteady gait. And this patient had actually two components of stenosis. One is that disc itself and also the ossified yellow ligament. So here I only went in posterior and did the posterior decompression, and I did not remove the disc. But for this patient, the patient eventually did very well and didn't come back for follow-up. Thank you. These are the few cases I wanted to share.
So, Suresh, just one, what is a common difficulty you face when you're doing thoracic decompression? One. Second thing, how many hours you took for this?
The 3-level took me almost 5 hours.
Okay.
Yeah.
And what is that one difficulty you face when you're doing this? Is it
in thoracic level, basically the problem is identifying, because the the window is very narrow, so identifying the bony landmark is quite difficult. So once you identify the bony landmarks, superior and inferior lamina and the facets, then once the drilling is easier.
Okay, okay. So how often you see this in your country? It's very common.
Very rare. I only done about 10 cases in the last about 3 years.
Yeah. So, but the take-home message is definitely When you get a case single level, two level, definitely you can do interlaminar approach very easily. So only thing is taking care not to injure the thecal sac, not to use the instruments over the cord. Don't use the radio frequency too much near the cord, because already it's compromised. So these are the three important take home from the this.
And the carisons always use the smallest carisons if possible.
Yeah. Thank you, Suresh.
Thank you, Dr. Smith.
1 mm is available now. So my use kar raha tha na, that is 1 mm. So you can use that, especially it's very useful. And crux is thin out the bone, eggshell the bone. So that's very important, because even आपके पास upcut नहीं है, you eggshell the bone, use a curette and just do this, it will break. So it is very easy. So, and biggest advantage in thorax is you can drill more. So there is no need, fear of losing the facet there, you can drill. Right now, still I prefer open because bad OPLL, so cervical still, maybe we need to see the experience of the other colleagues, but single level, two level stenosis, okay, but multi-level I don't think how much it is useful. We need to just wait and see. Next spinoscope, yes, definitely. Yeah, definitely. Yeah, definitely. So, Kulkarni sir, want to some closing comments if possible.
It's interesting. I think I use a lot of bone scalpel, sonopet, and I miss it everywhere here when endoscopic work is going on. Somebody, I think like Mr. Naresh, has to invent something which they can use sonopet endoscopically, where you're using everywhere this when thick bone is coming, soft tissue is coming. I just miss, because I use bone scalpel and in every case, cervical, lumbar, I keep the drill as well as bone scalpel. When it's initially you want the thick bone, you just drill. When you come closer to the soft tissue, nerve root, spinal cord, use bone scalpel, and it's like a sculpture. It's very nice to use it. I miss it everywhere. And you don't have to worry too much about soft tissue damage as well with that. So I think that I find is very useful. Just last week, my colleague was doing thoracic discectomy. And then he called me because he used sonopets. I just want to be there. And so I joined him. And at that time, when he used bone scalpel, it was so nice to do discectomy with that. So I just missed that where you are doing bony work endoscopically, I just said, why bone scalpel cannot be used here? Because when I use through the tubular retractors, I use bone scalpel, and the handle of the bone scalpel is quite thick. When you're using it, it obscures your vision, and that's why I use 26 millimeter tube, and then I use because I do unilateral and bilateral decompression through that. And it becomes so nice to use it. You don't have to worry about drill damaging the nerve root or dura. What are the incidents of dural tear in cervical spine with the bone scalpel? And what is the trick to prevent it? I used it for OPLL, as we were just talking about OPLL just now. I used for OPLL, and it's quite good. No CSF leak, nothing. Of course, this OPLL was, when you get a double layer sign, you have a 50% chance of CSF leak. So I put the lumbar to start with. And then when there was a CSF leak, then I just open the tab, because after doing long surgery, you don't want to waste time doing lumbar punctures, because sometimes CSF is lost, you don't get good lumbar puncture. So I do that sort of thing. Posteriorly, I use for foraminectomy also, I use sonopet. So it's easy, it doesn't bleed. So wherever I was seeing all microscopy surgery.
So there are a couple of companies available, sir. The existing probes they have, they can use it for either say biportal or distando, because as you said, the probe is bulky. So and the length, whatever probes and length available today, it's not for the endoscope. So maybe
That's what I
maybe in 1 year, already 3 companies are coming up. So if they start coming up, so definitely our bone work, especially the fusion what I showed in the morning, it becomes very faster.
Very thing. I think the drill will be obsolete. I think that is one of my feeling, that the drill, after a few years, people will say, oh, people will be using this high-speed drill very close to the nerve root and dura, CSF leak and that kind of thing.
So definitely, and doing cervical multiple levels again, it becomes become a boon endoscopically. So we'll just to say that surgeon should not get disappointed. Endoscopy has a bright future. Once Dr. Gore sir had said, so just to believe transforaminal approach and only you do transforaminal endoscopy, you become a billionaire. So he had said 15 years or 13 years back. I think Laukush is here. Already is going to become one. So he's a shishya of Gore sir also. So what I mean to say is definitely what all you do with open surgery, MIS surgery today, we can do with endoscopy. All you need is some patience, perseverance, and learning curve being steep. You need to persist, and definitely Rakesh is a live example. He's a being accomplished MIS surgeon. He need not learn endoscopy, but he started doing endoscopy I think 3 years back, 4 years back. So now he says he loves endoscopy, and so he's at the age of 74 is also learning endoscopy. Yes, so there is no limit for the learning or age for learning, but definitely there is lot of scope. So Spinoscope-2024 will have a lot of things to come. So I thank everyone, sir. You came all the way from London to cheer us and share your wisdom. Thank you very much, and I thank each of the faculty, our dear friends, and the delegates who came all over India, and from Southeast, Middle East, has been coming first time. I think first time to India. Yeah, so I think you people are taking home. Hope that you are got the messages what you wanted to take home, and you might have seen so many new things. Hope that we add more and more in coming years. But bottom line, try to learn the things correct way. So that is the most important thing. Whatever you do, patient safety is important and outcome is important. You practice outcome-based medicine, you need not worry about the technique. Thank you. Thank you very much. Thank you. Thank you.
Thank you very much. I learned a lot.
So I hope to see you soon. Okay. We can Dubai one year, inshallah. Yeah, please. Yeah, but, surely if you pass there, Dubai, you just let me know. Yeah.